researchers, all singularly gathered, focused on the long-term follow-up and care of Kawasaki disease. We are extremely honored to have the guest faculty, Dr. Etsuko Suda, who's a world authority on long-term follow-up of Kawasaki disease. So today we have an exciting lineup of sessions which are designed to spark meaningful conversation and discussion, and we hope all of us would actively participate and exchange ideas and learn from one another. A warm welcome once again. So the first session would be the oral presentation, which will be presented by budding clinicians and researchers. To chair this session, we welcome Dr. Priyankar Pal and Dr. Sajay Philip on the dais. Dr. Priyankar Pal is the professor and head of the department Pediatrics, unit head of Pediatric Rheumatology in the Institute of Child Health, Kolkata. He was the past president of Pediatric Rheumatology Society of India and the past president of Indian Society of Kawasaki Disease. Dr. Sajay Philip is the founder president of Kawasaki Disease Foundation of India and Indian Society of Kawasaki Disease. He is now the clinical and administrative coordinator of Dr. K.M. Cherian Heart Foundation, Parumala, Kerala. His expertise is on Kawasaki disease and fetal cardiology. So the first session would be oral presentation. We have 6 speakers lined up. So each speaker would be given a time of 5 minutes for the presentation, and there would be 2 minutes for question and answers. Each presentation would be timed. So we invite the first speaker, Dr. Vibhu Joshi.
Good morning, everyone. I'll be presenting my PhD thesis work on expression of Fc gamma receptors in Kawasaki disease, pre and post immunoglobulin therapy. So as we all know, Kawasaki disease is a medium vessel vasculitis. The etiopathogenesis is unclear and is thought to be a complex interplay of genetic factors, infections and immunity. IVIG is standard of care, and high dose IVIG provides prompt anti-inflammatory effect. However, the exact mechanism of action is not clearly understood. The Fc region of IgG mediates its effective function and binds with Fc gamma receptors. These are the family of Fc gamma receptors, amongst which all are the activatory receptors, while only one, CD32B, which is Fc gamma receptor 2B, is inhibitory receptor. Altered Fc gamma receptor expression can lead to complications like development of coronary artery aneurysms. So genome-wide association studies have identified Fc gamma receptor 2A as a susceptibility locus, and subsequent studies have shown that non-allelic homologous recombination has resulted in copy number variations and noble chimeric genes, resulting in aberrant functional expression. However, there are no detailed expression studies for patients with Kawasaki disease. So there are challenges in immunophenotyping of Fc gamma receptors due to the high sequence homology. It is difficult to dissect the subsets of Fc gamma receptor 2, and moreover Fc gamma receptor 2C is a pseudogene. So the study design involved acute KD patients, and subsequently post 36 to 72 hours of IVIG, the samples were, these were resampled, and the surface expression of these Fc gamma receptors was done. So this was the staining protocol, and using flow cytometry, the surface expression was seen on lymphocyte, monocyte, neutrophils, B cells, T cell, the subsets of monocytes. And this is how the surface expression looked in control, pre-IVIG and post-IVIG. The surface expression of the delta median MFI of Fc gamma receptor 1 on neutrophils was significantly increased in patients with acute KD prior to administration of IVIG. While for the Fc gamma receptor 2A, the delta MFI decreased post-IVIG, and for Fc gamma receptor 2B/C, it was decreased before administration of IVIG compared to control, significantly decreased. However, the inhibitory receptor increased post administration of IVIG. Similarly, for the expression of Fc gamma receptor 3A, it was significantly decreased in acute patients, and Fc gamma receptor 3B also was significantly decreased in acute patients compared to the control. So the consolidated results of acute KD versus control, these showed that the Fc gamma receptor 1 on neutrophils was significantly increased compared to the controls. Fc gamma receptor 2B was significantly downregulated compared to the controls, and Fc gamma receptor 3A and 3B were significantly decreased compared to the controls. On comparison of pre-IVIG versus post-IVIG, the Fc gamma inhibitor receptor was significantly increased after administration of IVIG. However, the activatory receptor 2A was significantly downregulated in post-administration of IVIG. So, our hypothesis confirms that the activation of activatory receptors decreases following IVIG, which can be seen in the picture, that the activatory receptors, they get internalized and degraded and hence decrease post IVIG. However, the activatory receptor, they get recycled back to the surface to be available for another round of signaling. And these results were also confirmed by a confocal study by Zhang et al. The clinical applications of the study were that the recent literature had shown that immunophenotyping of Fc gamma receptor expression on leukemic cells using peripheral blood, which is rapidly available and improves risk stratification in acute myeloid leukemia. Similar studies also were shown in responses to rituximab in patients with rheumatoid arthritis and SLE. Our study in KD suggests the potential utility of immunophenotyping of Fc gamma receptors to be helpful in assessing response to IVIG and may serve as prognostic and diagnostic marker in KD. I would like to thank my co-guides, all the consultants, fellow PhDs, postdocs, research fellows, senior residents, and DST Inspire for the fellowship support. Thank you.
In high dose or IVIG, sometimes it can saturate and block receptors. So, is there any problem for you to quantify the receptors after the IVIG?
Sir, initially we did not realize this fact, but then we changed our strategy and we blocked the receptors with inhibitory receptor first, so that we could get the specific expression. So this was the strategy in which we initially blocked the unwanted non-specific Fc receptors. Then we gave the specific staining with the inhibitory receptor for half an hour, so that we get the specific results for inhibitory receptor. Then we washed the cells again and then stained with rest of the activatory receptor and rest of the antibodies to be more specific.
And this surface expressions all
Sir, it was difficult to dissect all the receptors because of the sequence homology between these receptors. So we had dissected the 2A into 2A, 2B. However, 2B and 2C could not be distinguished because of the fact that 2C is pseudogene and only expressed in some patients with certain allelic variations. It's not present in all cases and controls.
One or 2 points for the clinical application in KD cases.
So we had also segregated these patients on basis of the response to IVIG and on the basis of coronary artery involvement. So our sample size is low to conclude the fact that however, we have hypothesized that we will be able to predict whether this patient will respond to IVIG or will not respond to IVIG, so that the alternative therapy can be started on time to prevent aneurysms in the patient.
So you have mentioned from the leukemia study that it's pretty fast. So how rapidly is that? Because we are, what I understood that we can understand the IVIG resistance. So how rapidly can you get
So the test results are available as lymphocyte subset only. Overnight, we can provide the surface staining results.
So within 24 hours.
Yes, yes. But we had kept the IVIG resistant time point as we had taken the specific time point according to AHA as 36 to 72 hours. So yes, the results can be available overnight.
So some of it adds to the chain also.
Yes. Thank you. Thank you.
For the second presentation, we have Ms. Pavli Kaur, who is the series on giant coronary vasculitis.
Yeah, no. Next laser. Thank you.
A very good morning to all present. I would like to present our experience at the All India Institute of Medical Science with respect to giant coronaries in children with Kawasaki disease. So, as we all know, coronary artery abnormalities are potentially fatal complication of Kawasaki disease, with 17% of the patients developing the same, with giant aneurysms as frequent as 3.1%. We know that they regress, and there are factors which predispose and decide who regresses and who worsens, and patients who would require adjunctive therapy. In our practice, we encountered 5 out of 34 children in the last 5 years with giant coronary arteries. So the first case was that of a 24-month-old boy. He presented to us with fever, hand dorsum edema, desquamation, and conjunctivitis. A provisional diagnosis of incomplete KD was made, and IVIG was started. A coronary echocardiogram was obtained during this period, and we found a giant aneurysm of the LMCA. The therapy was intensified primarily with infliximab, and that is when the patient presented to AIIMS. So we were monitoring the patient, and the second half aliquot of the infliximab was ongoing, and we noted that 4 days into therapy, his coronary aneurysm had arrested in progress, and he was monitored and discharged on aspirin, enoxaparin, and atorvastatin. At recent follow-up 6 years post, he persists to have giant coronary artery aneurysms, but is clinically stable and is able to lead a normal life. The other case was that of a 60-month-old boy who presented again with incomplete Kawasaki disease and was found to have giant coronary aneurysms and was referred to us at day 8 of illness. IVIG therapy was started, and the patient was intensified primarily with infliximab and also supported with oral steroids. Echocardiographic follow-up showed a persistent coronary artery aneurysm, in fact an initial bursting. However, subsequent monitoring showed some regression. He was discharged on aspirin, enoxaparin, and statins, and he's doing well 3 years post follow-up. The third case was that of a 6-month-old boy, a young infant with fever, conjunctivitis, and rash. He'd been treated outside at day 30 of life when he was screened suspecting in hindsight Kawasaki disease. He was found to have giant coronary artery aneurysm. Sizes were not documented, and for multidisciplinary management, he was referred to AIIMS, New Delhi. We confirmed that he had giant coronaries, and there was no fever, no inflammatory markers. So we decided to support therapy with aspirin and antiplatelet agents and to follow the patient. 6 years into this, he's doing well. The fourth case was that of a 8-year-old boy. He presented again with fever, edema, and desquamation, little outside of the range of age that we expected him to be. He had elevated inflammatory markers and giant coronary arteries. Z scores were available from outside and not the absolute sizes. He was started on IVIG in the emergency and was primarily intensified. We did a repeat echocardiogram which had confirmed the giant coronary artery aneurysms. Once the disease had deafest, we discharged him on beta blockers in view of LV dysfunction that we had found during our management, and warfarin, enoxaparin, and atorvastatin. He's 7 years into follow-up and doing well, going to school. The last case was a little atypical. It was that of a 5-month-old girl. She'd been febrile for 10 days, and the parents characteristically complained that she had fast breathing and diaphoresis, and some swelling that had developed in the bilateral axillary region. On evaluation, the picture was similar to KD, except for the swelling in the bilateral axilla, which was a little atypical. She had been treated with multiple oral and IV antibiotics. On arrival at AIIMS, we screened her coronaries and found that she had dilated coronaries, and IVIG was started pending admission. The axillary swelling was pulsatile, as is appreciable, and bilateral. An echocardiogram confirmed dilated coronaries with aneurysmal LAD, dilated descending thoracic aorta on Doppler, and subclavian and axillary axis also being involved, with a dilated common femoral artery as well. We intensified our therapy primarily with IV methylprednisolone and infliximab, and ultimately had to transition to steroids because the patient had persistently elevated markers, active fever, and a pulsatile swelling, persistently enlarged coronaries. So the patient was under monitoring. We also did a volume rendered computed tomography for this patient and found that there was aneurysmal involvement of the right coronary artery, left anterior descending, left circumflex, in addition to the systemic vascular involvement of the subclavian, aortic, and the femoral axis. Ultimately, the patient passed away, likely due to coronary rupture. There was no visible impression of hemoperitoneum, but the patient did have aortic aneurysm and was under consideration for an intervention by the CTVS and the cardiology teams. However, she could not be salvaged. So to summarize, we had 5 cases, one of whom did not make it. All of them were incomplete KD, but did not pass the cutoff of the Kobayashi score. That is, they were all less than 4. So our observations were in line with the available evidence. Incomplete KD may have a high propensity to develop giant coronaries, possibly refractory to immunomodulation, and delayed diagnosis and immunomodulation are important factors determining the prognosis. Although rare, systemic arterial aneurysms may be life-threatening despite immunomodulation. Thank you.
In some of the cases you put in the bracket, that is Z-score.
Yes, sir.
And the 6 months old case,
Yes, sir.
GIAN levels you mentioned, but the measurement not.
Yes, sir. That patient was referred to us from outside and they did not mention Z scores and they could only write dilated coronaries. Since this is retrospective data, there is that limitation and I acknowledge that. Once we entertain the patient in the ER, with our facilities there we are able to discern dilated coronaries, but for accurate sizing we have to take them to the CNC, the cardiovascular building. That takes some time, but we start therapy pending the same.
Out of 4 cases, one case received beta blocker.
Yes, sir.
In your follow-up, have you noticed any regression of the aneurysm in the beta blocker case?
So there is non-progression. We would not be so bold as to say that there is regression, but there is definite non-progression.
In the beta blocker should be added for non-aneurysm, the giant aneurysm cases.
Yes.
And I really appreciate your pictures, again stating that there is a definite echocardiographic limitation.
Yes.
CT is necessary to
Yes.
see all the generalized aneurysms.
Yes, sir. But for case number 3, we did CT for all our patients and I could not include them for paucity of time, but this case was quite striking. The axillary aneurysms were not expected by the referring physician, and it was a high index of suspicion by the ER team that this might be a part of Kawasaki. So I would like to acknowledge them also in the same. No, sir, no major adverse cardiac events so far. They are doing day-to-day activities but not participating in contact sports. Sir, all of them had to switch to warfarin and we are running into trouble with the anticoagulation. We are jumping our INR targets. So that is the affordability for inoxa is a definite problem, and DOACs are not commonplace use, although cardiologists seem inclined to shift to them in coming future. Statins are being given routinely at our center. That is their in-house protocol. Yes, sir. Yes, sir. Yes, sir. We had 14% and 34. The number itself is low. During COVID also we saw more MISC dilated coronaries rather than KD. And because of the referral center bias, maybe we're getting a lot of giant proportion. We got 14% as opposed to literature reported 0.15 to 3.4%. So, but that it enhances our experience in managing these cases. No, sir. None of the children had any thrombus. They were actually many a times pre-treated before referral. The treating physicians, they were not able to manage cardiological interventions, but for the same they referred and they added some kind of antiplatelet anticoagulant so that the children would not develop thrombus. So we had an informed referral pattern as well. Maybe Delhi has that facility. So patients came to us mostly in a state where they did not have a thrombus. 5 out of 5 actually. Thank you so much, sir. Good day.
Thank you, Mr. Ambedkar. The next presentation we have Mr. Yago.
Next, laser.
Good morning, everyone. I am Dr. Riya Ghosh. I will be presenting on a case report on autoimmune shenanigans, so the SLE and Kawasaki disease crossover. I would like to give thanks to my guide, Director and Professor Dr. Dionath Mahato, Professor Dr. Anu Maheshwari, and Professor Dr. Shamit Gulati. So SLE is a multi-system autoimmune disease with a multifactorial pathogenesis presenting with varied symptoms that may be challenging to diagnose and tends to have a more aggressive course in children than in adults. Kawasaki disease is a self-limiting febrile illness causing inflammation in medium-sized vessels, especially the coronary arteries, and it is the leading cause of acquired heart disease in children. Peripheral gangrene is, however, a rare manifestation of the Kawasaki disease. However, it is a relatively more common presentation in SLE, as both SLE and KD share the same etiological factors and both have multifactorial etiology, with autoimmunity considered as one of the important etiopathogenesis. So we report here a case of 13-year-old girl presented with dry digital gangrene and self-amputation of digits. The gangrene raised suspicion of vasculitis, while a 2D echocardiography revealed coronary vessel dilatation with aneurysm, suggesting a possible overlap of SLE and KD. So case report, a 13-year-old girl presented with a 1-week history of high-grade fever, which subsided with antibiotics, followed by which she developed blackish discoloration of her fingers and toes for 10 days, along with a burning sensation in both upper and lower limbs. She also had a significant past history of similar symptoms, leading to self-amputation of a digit and toe a year ago. There were no symptoms of redness of eyes, hair loss, seizures, behavioral changes, Raynaud's phenomena, oral ulcerations or arthritis, rash, photosensitivity, weight loss, anorexia or hematuria prior to this presentation. So on examination, as you can see, there are gangrenous changes were noted in digits of both upper and lower limbs. BP was measured 140 and 110. It was hypertensive with no significant differences noted in forelimb BP. Peripheral pulses were variable, bilateral, radial, brachial, femoral pulses were of low volume, and peripheral pulses like dorsalis, pedis, anterior tibial and popliteal were also low volume. So the investigations were done keeping in mind the diagnosis of vasculitis. So anemia on differential counts, anemia, leukopenia, however normal platelet count was present. ANA by IF titer was 1:80 and diffuse pattern. Anti-DS DNA was more than 400 international unit per ml. C3 and C4 level was low. P ANCA and C ANCA was negative. APLA was negative and DCT was negative. However, ESR was raised. QCRP was raised. CECT angiography of upper limb and chest was done. Right distal radial artery thrombosis at the level of distal radius. Thrombosis of right cephalic vein was present, and there were some features suggestive of pulmonary artery hypertension. Bilateral pleural and pericardial effusion was there. CECT angiography of lower limb was done. Non-opacification of right distal dorsalis pedis artery was present even on the venous phase. Considering that the child fulfills the criteria of SLE, diagnosed as SLE, however, considering the possibility of vasculitis presenting as gangrene and the rare presentation of Kawasaki disease, a 2D echo was done which revealed coronary artery dilatation. Moderate pericardial effusion of 13 mm, LMCH score plus 2.9, LAD was plus 3.3 and RCA plus 1.23. So working diagnosis is kept SLE overlap with Kawasaki disease. Child was given IVIG at the rate of 2 gram per kg over 12 hours with aspirin 4 mg per kg per day. For SLE, hydroxychloroquine was started at 5 mkd and discharged on oral prednisolone and hydroxychloroquine. Following the treatment with the IVIG and aspirin, patient has shown the improvement. So to the best of our knowledge, or so far, only 3 case reports of the overlap between SLE and Kawasaki disease have been published. So these are the cases. One was published in 1988, another 2012, another in 2016. Here you can see the first case, KD, was followed by SLE 3.5 years later, and there was features of pseudocyetis and coronary artery dilatation. ANA and dsDNA in 3 of these cases were positive, and they were treated with IVIG and aspirin followed by methylprednisolone pulse. However, in the third case, they were given as IV cyclophosphamide, keeping in mind the diagnosis of lupus myocarditis. All of these cases are on follow-up on 2D echo. The size of coronary artery diameter was dictated. So, conclusion that coronary artery vasculitis and gangrene may manifest as Kawasaki disease in the background of SLE. Both conditions, as they share overlapping triggers, making KD possible in SLE patient. Although ANA have occasionally been reported in children with KD, a diffuse pattern of ANA along with a very high titer of anti-dsDNA antibody and positive ANA antibodies are strong pointers towards SLE. The child may have had undiagnosed KD a year ago, leading to coronary artery dilatation and gangrene. Improvement in coronary artery diameter after IVIG treatment that supports our Kawasaki disease diagnosis. So given the concurrent autoimmune process in both SLE and KD, symptoms may present more aggressively, increasing the likelihood of misdiagnosis. So KD may be missed in SLE cases as IVIG is not a standard treatment protocol for SLE. Thank you. So these are the references. Thank you.
Why not just a lupus? So what is the cardiac involvement in lupus?
Sir, in the lupus, there could be lupus myocarditis, there could be involvement of like Liebman-Sack endocarditis can also be there. But compared to Kawasaki disease, this involvement like of coronary arteritis or coronary artery dilatation is however rare. So we kept a diagnosis of Kawasaki disease initially in the background of SLE. So,
Lupus is basically kind of a
pancarditis, yes sir.
And your patient has
Yes sir, severe pericarditis.
And the coronaries were not cross-dilated. The disease goes around small aneurysms, let's say.
Yes sir.
You would consider it more of a...
So it was more of a background of SLE that however it can be there with Kawasaki disease. So more towards...
It was negative, right? Phospholipid was negative.
Yes sir.
So what is seronegative area? What about seronegative area?
Sir, I don't remember exactly right now.
Any criteria has been fulfilled for KD disease other than coronary?
No, sir, only the fever was present. However, there was no disquamation, no behavioral changes. So we can keep that as a diagnosis of atypical KD. QCRP level was sir high and ESR level was high. Because sir, in adolescent age group, the atypical presentation is more common in Kawasaki disease. So we kept that other differential diagnosis in this case.
Do you think that the criteria, at least 2 or 3 criteria has to be fulfilled in favor for KD, the than coronary one? Because many diseases can get the vasculitis, like cardiovascular arteritis, many overlapping diseases. Even dengue also can overlap, but criteria has to be fulfilled. If it is not fulfilled and coronary only involvement, then still, as Dr. said, more in favor for SLE presentation.
So the
Then you consider only gangrene and
gangrene and coronary artery dilatation involvement is. Okay. Thank you, sir.
Thank you, Mr. Yakush. For the next presentation, we have Dr. Sonjali Raha, who will be presenting the clinical case.
नेक्स्ट लेजर बताइए आप।
A very good morning to all. My case presentation title is Nailed by the Nails, Kawasaki disease missed in the acute phase, unmasked by Bewes lines. So as we all know, Kawasaki disease is the commonest childhood vasculitis and is the most common cause of acquired heart disease in children, predominantly affecting children below 5 years of age. Diagnosis of KD is clinical with no pathognomonic laboratory investigation, and investigations support the clinical findings. Hence, a significant proportion of KD cases are missed or are diagnosed late. Now, several types of nail changes have been described in patients with KD, mainly during the convalescent phase. Though they are not in the diagnostic criteria, they can often help in reaching the crucial diagnosis. Hence, the importance of physical examination can't be emphasized more, and this fact will be highlighted in my case. So today we have a 4-year-old boy presenting with fever for 5 days in the month of December 2024. So the child had presented to us with daily high-grade intermittent fever spikes for 5 days that was associated with dry cough. Now on probing history, we found that the child had actually been symptomatic for the last 6 months from August 2024, when he had high-grade intermittent fever spikes lasting for 6 to 7 days at a time, and 3 such episodes in August 2024. From September to October, the child had daily high-grade intermittent fever spikes that had lasted for 20 days duration. Now during this time, he had visited multiple healthcare professionals, had been treated on the lines of upper respiratory tract infection, and had received multiple courses of oral antibiotics. At the same time, the child had rash, which was non-pruritic erythematous rash, starting from face and progressing to entire body, lasted for around 11 to 12 days and had weaned off, and this was followed by skin pilling that had again weaned off by beginning of November. The child also had a single grape-sized swelling on the back of the neck on the left side, along with redness of eyes, which was non-purulent and had lasted for 5 days. The rest of the history was non-contributory. The child belonged to an upper class in socioeconomic status. In examination, vitals were within normal limit and anthropometry was well preserved for the child. The child was alert but was significantly irritable at the time of examination. The salient points in general physical examination include edema that was noted over the dorsum of hand and in feet. We can also note Bewes lines and chromonychia here, which is highlighted in the next slide. So Bewes lines are basically transverse depressions like this across the nail plate, which signifies systemic disruption of the nail matrix. They are not specific to any particular diagnosis, neither they are specific for KD. However, in the presence of a clinical scenario and a history and physical examination, Bewes lines can place one diagnosis over the other. So the presence of Bewes lines made KD high on cards in this case. The rest of the systemic examination was within normal limits. So with this history and physical examination, a diagnosis of Kawasaki disease was missed Kawasaki disease was made. So we went on going on to the laboratory investigations for this child. The only significant finding here is a pro-BNP elevated and a mild level of anemia present in the child. Coronary artery imaging showed dilatation. The echocardiographic findings showed dilatation in all the coronaries. However, a CT coronary angiogram that was done later showed a dilatation in the left main coronary artery, and the rest of the coronaries were within normal. So this is the CT coronary angiography finding for this child, which shows a fusiform dilatation in the left main coronary artery. So the child was subsequently treated for Kawasaki disease. The child received IVIG 2 gram per kg on day 1 of admission, followed by methylprednisolone pulse for 3 days and continued on oral prednisolone. He was also started on cyclosporin and received infliximab on day of admission 3. For giant aneurysm, he was started on aspirin and low molecular weight heparin and was discharged on these drugs. He continues to be on our follow-up. Currently, he is only on aspirin. The immunosuppression has been weaned off, and he is currently doing well. The repeat coronary angiography findings show a reduction in the size of the aneurysm. So the message from today's presentation is a variety of nail signs have been described in Kawasaki disease, though they are not part of the diagnostic criteria. Bewes lines are transverse ridges on nails signifying systemic disruption in nail matrix. They are not specific for any particular disease, and they are seen in the convalescent phase of Kawasaki disease. A thorough clinical examination and a high degree of suspicion is essential to clinch the diagnosis of Kawasaki disease in many cases. More awareness is needed among referring centers to pick up the disease in the acute phase and prevent devastating complications. Thank you.
You given IVIG and followed by infliximab during the convalescent phase?
Yes, sir. But this was,
Inflammatory markers were very high.
it was not high, sir. But we gave because the child had already developed aneurysms by this time. So IVIG we gave, and then since he is 4 years of age and giant coronary aneurysms were already present, so we gave followed by IVIG the other end.
Just for your satisfaction, so we understood that the inflammatory markers are not high.
Not high, sir.
Settled. Then no point of giving
So the slide of the coronaries, the progress curve, you have a slide, you can see the angio also, A1, A2, A28. So, so what is impressive, I would say that they treated the child almost after 2 months.
Yes,
So
sir.
if you consider that the time of occurrence
Yes, sir.
around October, because that
September, October, and we December we have treated.
So for almost 2 months, and you know that most times also come after at least 3 weeks.
Yes, sir.
Around 3 weeks the most times are there. So even late with normal inflammatory markers, but there was some improvement.
Yes, sir.
With hiking of the management. I think that should be the
Yes, sir. So it has reduced, and further after this was around January, this CT coronary angiography could have been done. And then in February, the repeat echocardiography has been done. That shows a medium level dilatation currently.
That means after 3 months.
After 3 months almost.
So that can be like a natural course of solution.
Yes, sir.
I don't think so, because as far as we understood that the inflammatory markers are high, definitely we are going to be.
thank you.
Yes, sir.
Next speaker will be Dr. Yasin.
Next. Yes, sir.
Good morning to one and all. I am Dr. Riya Singh and I will be presenting a case of thrombosis with multiple coronary aneurysms in infantile Kawasaki disease. As we all know, Kawasaki disease is an acute systemic vasculitis that involves coronary arteries in young children, and even though giant aneurysms are rare, they can be complicated by thrombus formation leading to myocardial ischemia, myocardial infarction and even death. So, this is a 9-month male infant who presented with high-grade fever for 11 days with transient erythematous rash and red eyes on day 3 to 4 of fever. He was diagnosed as incomplete Kawasaki disease. On blood investigation, it shows high TLC count with 15,800 neutrophilic, platelets were 9.5 lakhs and raised CRP with 123 milligram per liter. Echo showed giant aneurysm in LMCA with Z-score of 12.6, medium aneurysm in LED and RCA with Z-score of 6.7 and 8.4 respectively, and there was a thrombus at LMCA bifurcation measuring 4.6 to 3.5. This is an image showing LMCA with large thrombus. So, the child was diagnosed as incomplete Kawasaki disease with multiple coronary artery aneurysm with a thrombus in LMCA and was initiated with treatment with IVIG, infliximab, aspirin and low molecular weight heparin. And daily echo was done. In our serial echo after 4 days showed a new thrombus in LAD in spite of the treatment. So, the treatment was intensified with oral cyclosporin and clopidogrel. This is an image showing thrombus in LMCA and LED. So, on day 1 of diagnosis, there was a giant aneurysm in LMCA, medium aneurysm in LED and RCA with a thrombus in LMCA. On day 3 of diagnosis, the Z-score in LMCA and LED increased, leading to giant aneurysms, and RCA showed medium aneurysm. And the thrombus was almost same in size. But after day 4 days of this echo, on day 7 of diagnosis, there was another thrombus in LED measuring 6 mm by 4 mm. So at this time, our treatment was intensified with oral cyclosporin and clopidogrel, and on day 20th of diagnosis, the LMCA aneurysm reduced to medium size. Medium size aneurysm was still present in LED and RCA, but there was no thrombus in the lumen. So the outcome of this by day 20 was that there was resolution of both thrombi. The giant aneurysm in LMCA and LAD reduced to moderate sized, which was later corroborated by CTCA after 6 weeks. Last follow-up was done 7 days back after 5 months from the onset of the disease, which showed LMCA having small aneurysm with Z-score of 3.5 at bifurcation, and all other coronary sizes were normal and lumen was free of thrombus. The child was managed intensively with IVIG, infliximab, cyclosporin, dual antiplatelets and low molecular weight heparin. An echocardiography was done daily initially for 10 days till stabilization of the thrombus size, and then alternate days till resolution of the thrombus. So we conclude that frequent echocardiographic monitoring during the acute phase of KD helps in early detection of complications like progression in size of the aneurysm and formation of the thrombus. Timely aggressive management can lead to dissolution of the thrombus and also regression in the size of the aneurysm. So I would like to end this presentation with a question that can we consider treat to target in KD? Thank you.
So this child, infant, 11 months old infant, presented on day 11 with a thrombus.
Yes, sir.
So would you consider this thrombus to be a little early?
Early thrombus, yes, sir, because it is known after 2 weeks of the illness, but it is on 11 day, within 2 weeks of the illness.
Do you have the monitoring facility for the factor X?
No, sir. Yes, sir. Yes, sir, but we don't have that facility.
Early thrombus formation is
Thank you, sir.
Next presentation is by Dr. Harlan.
ये ना प्रेजेंटेशन है आर्टिफिशियल इंटेलिजेंस
आगे कैसे होती है स्लाइड इसमें
ये नेक्स्ट है लेजर
Good morning everyone. My name is Harnoor Sidhu and I am 5th year student of Doctor of Pharmacy in Adesh University. So I am the youngest of everyone present here and so my topic is artificial intelligence in Kawasaki disease. So Kawasaki disease is an acute febrile systemic vasculitis, also known as medium vessel vasculitis, because it mainly affects coronary arteries if left untreated. Untimely treatment or late diagnosis may lead to coronary artery aneurysm. There are 20 to 25% chances of CAL. KD impart high risk in male gender compared to female. The incidence of Kawasaki disease is highest in East Asian countries, moderate in USA, and low in Europe, variation based on the ethnicity. In India, the recent reported data on the incidence of KD is 8.89 cases per 1 lakh patients, 1 lakh people. So these are the clinical features. Fever, that is the main feature, persistent for 5 days and followed by conjunctival infection, bilateral and exanthema, lymphadenopathy, mainly unilateral, changes in the lips and oral mucosa, also called as pink tongue and dried cracky lips, changes in the hands and the feet. So these are the laboratory findings. So Kawasaki disease in special situations such as in infants, in older children, mainly represent in form of myocarditis, atypical Kawasaki, and may be associated with infection or sepsis. So it is really important to diagnose it carefully and don't so that we can treat KD appropriately. So why AI in medical sciences? It can improve the patient care and workflow efficiency, drug discovery due to the vast data analysis, professional assistant to the medical clinicians so that they can do efficient diagnosis and prognosis, personalization of drug therapy, and contact tracing for disease control measure. As we have seen in COVID-19, it is the main feature of AI. So why AI in Kawasaki disease? Early diagnosis and acute diagnosis, because there are many clinical conditions that may show the symptoms of Kawasaki disease. So AI can help to analyze the patient data, lab results, and imaging to help doctors to differentiate KD from similar condition, reducing the diagnostic errors. Predicting IVIG resistance. We all know that IVIG and aspirin are the only medicines that we can fully rely on the treatment of KD. If we can predict the resistance, so the clinician can start the robust anti-inflammatory therapy early on in the therapy. So risk stratification of coronary artery complications. AI can assess the echocardiogram and the lab result to predict which patients are the high risk of developing coronary aneurysm. Personalization of treatment plans, enhancing imaging interpretations, and reducing the healthcare burden by automating the data analysis, predicting disease outcomes, and optimizing resource allocation. So this is the basic thing that AI can use, that is preventing the coronary artery aneurysm by enhancing the diagnosis so that early condition can be identified in the patients. So these are some tools according to the recent articles that are published. I have collected all the tools that are used. These all diagnostic tools have high specificity according to the research article that the researchers have published. So the difficulties in using AI are the accountability and liability, and the need for regulatory frameworks to define the role of clinician, developers, and the institutions. So reproducibility and reliability, the data should be collected across the diverse population and the healthcare setting. Standardized protocols for benchmarking and assessing AI performance are essential. Ethical and legal consideration, patient data privacy must be ensured with strict anonymization and security measures. AI should use only essential medical data following legal and ethical guidelines. And AI models trained on large data sets from different hospitals must perform consistently, ensuring AI is robust and adaptable to various clinical environments. So this is the conclusion. There are several additional possible uses of AI. The data, so the main thing with AI is the data. The data should be collected from the multiple institutions so that an effective AI algorithm should be implemented so that the diverse population patients can be treated accordingly. And also they should meet the ethical and legal requirements. So the way that the individual with KD are treated and get medical care will be more enhanced with the involvement of AI. Thank you. This is the reference.
Is this your just a proposal or have you tried this in practically?
Sir, no, I have not tried it practically. This is basic review of all the AI tools that are available and which have high specificity and selectivity for treatment of Kawasaki.
I did a project on hormone converting to phonocardium have to give a deep learning technique for all the scorings, Harada score, Sandoshka score, then signs and symptoms, laboratory parameters, everything has to be to the software people has to help you for deep learning. And then we have to give a trial that computer will improve the problem. Now itself, with one criteria and two criteria, BP plus again.
Okay, sir.
I don't know whether it is possible. It's here now. Yeah, and some comment whether it is possible with the deep learning technique.
Yeah, actually, both the deep learning and machine learning. I'm Dr. James. I'm an associate president in institutions. I'm working in this process for the last 10 years. That is, I'm working with the music career, but I have not been given the still I have not accepted the data of gaming. I'm just reviewing all the AI methodologies in my presentation. Now, deep learning is what I'm doing that we have deep architectures that have many layers of artificial intelligence, and they actually extract the features from very small part, 3 by 3 video of the image, and then it has been trained step by step for each image. Then we extract those features and then we optimize those features which are the best features, like Emerson detections, the 3D volumes, volumetric analysis, and then we have now we have another things that is extremely AI. It is previously what we used to say a machine learning algorithms, but now if we say see this thing that is a computer system, they are black boxes. You have given inputs, then you have to follow. But when you deal with machine learning with extreme AI, they give you what are the features which are contributing exactly to the disease, and what are the complications, what are the risk factors, what are the strategies which shall be followed, which are contributing more to that. They give the percentages of the contributing factors. Then, if we mix these laboratory testing all these factors, then we have much more better diagnosis.
Thank you.
Yes. Thank you, sir.
I think we conclude this presentation. Thank you.
Thank you, sir. So the next couple of topics would be on the burning topics of today's world, artificial intelligence. To chair the first session, I invite Dr. Rakesh Kumar Pilania. He is Associate Professor of Pediatric Allergy and Immunology Unit in the Postgraduate Institute of Medical Education and Research. He has published more than 100 papers in peer-reviewed international and national journals. And his key areas of interest are Kawasaki disease, pediatric lupus, and inborn errors of immunity.
Sir,
good morning all. So, to start with the session on artificial intelligence, and I would invite Dr. Anuma Gulagi. She is a professor at Lady Harding Medical College at Longterm Children's Hospital, New Delhi. She is Euler certified pediatric hematologist and have more than 50 publications in books, international and national journals, and her area of interest in pediatric knowledge and hematology. And she is speaking on AI-driven diagnosis of severe disease in Kawasaki disease.
Okay. Thank you, Dr. Rakesh, for inviting me to speak on a very interesting topic, something I'm sure young MD students and our SRs, and I think all the young people are, they are gearing up for all the Chat GPT, Perplexity, Copilot. Yes, it's a very exciting time for medicine, and I would say I'm not that old, I'm not that young, I'm still learning. And it was and thank you, Dr. Rakesh, for giving me this talk. In fact, I'm hoping that in the next few years, all of us would be working on AI-driven diagnosis, prediction modules, and a lot of other things. So an exciting time for us, right? A picture's worth 1,000 words. You can see on the one side, we have a lot of a group of doctors, the professor, the associate professors, the students, everyone's there putting their brains together. While on the other side, there is one humanoid, android, whatever you want to call it, chatbot. Yes, it is the future. Whether we like it or we don't, we obviously don't want to get replaced. But we will not get replaced if we use artificial intelligence or augmented intelligence or whatever you want to call it, judiciously. So artificial intelligence, what exactly is artificial intelligence? Well, there's nothing artificial about it, right? So what is AI? Oh, sorry. So what is AI? AI is what you teach the computer. Right now, a lot of AI, the chatbots, everything, the Chat GPT, they are basically large language models. What are they learning from? Like if you ask, what is the treatment of pneumonia? It's not going to give you from Nelson or Ghai or maybe Harrison. It's going to give you from all the sources, from Google, from forums, from vlogs, because they are basically large language models. They're accepting everything. So what is the future for us? We should develop small language models in which maybe you give it only medical textbooks. So what is this going to do? It's going to read the medical textbooks, make the algorithms, and going to give you proper whatever is given in your textbooks and not what's given on Google. So it's basically a computer system, and I think this is a better term. I like the word machine intelligence. And what does it do? It extracts information from the environment, whether it's a PDF, whether PDF of the book, whether images, whether textual context, whatever. It'll take all the data and then it'll give some output. And output would depend upon, and it mimics our intelligence. Like, we see first patient of KD, we realize, oh, we missed this. We see the second one, we missed lesser. Then we keep doing more and more patients and we become more expert. So that is what AI is also doing. AI is also learning with each question that you ask. In fact, I'm sure a lot of people have used Chat GPT on their rounds, right? So you keep refining. Okay, give me references from the PubMed. Give me references from Google Scholar. And believe me, it'll keep refining, it'll keep refining, and it's an amazing technology. So a brief history, it's not that new. In 1950s, the term artificial intelligence was coined. 1960s and 70s, we had this Eliza, the chat box. I'm sure a lot of us know about that. Shaky the robot. So there was a very limited computing capacity during your 1960s and 70s. So this period of 1970 to 1990 was known as AI winter. AI winter means that there wasn't much that was happening. So 1990s, we are 1990s people. So first driverless cars, Deep Blue, which was playing the chess. So all that's evolved. Now 2000 onwards, we had these social robots, Kismet, the Sophia, the NASA rovers, Alexa, Siri. So what is happening now, that there is a neural network. That is, they start learning, they start behaving like humans. They are becoming humanoid. And I think ma'am was just talking about deep learning. So these are few of the technologies that are coming up. And AI surge, of course, has been from 2020 onwards, and COVID has really, I think, launched it into its, sorry, I think I'm not. So behind the scene, I'm not going to bore you with this. We all know data is there. And then you use this data science and machine learning algorithms. And you can have supervised technologies where you do regression, classification, predictive analysis. And unsupervised is what the deep learning is going to do. Like, you give it images, it's going to keep learning. You give more images, it's again going to keep learning. So AI is a very fascinating tool. So why do we need, we are so intelligent, we have all cleared NEET, we have all cleared INI CET. Do we really need an AI to help us during our rounds? We have our textbooks. I think we do because, see, all of us get tired, all of us have our moods, all of us have our emotions. So AI doesn't have its emotions. So every time it's going to give you the same answer. Like if I'm assessing 10 students, I might start with giving 50 on 50, but by the end I'll get fed up and I'll start giving 20 on. So that is not going to happen with AI. AI is going to perform the same way that it is a lot of predictability. So early detection, risk management, cognitive support to the clinicians. See, all of us are humans. I might have an IQ of, let's say, X. Somebody may have an IQ of X plus 10. Somebody may have an IQ of X minus 10. So we all, if we are working and we are taking rounds and one patient, we may have a different opinion. But AI will detect subtle patterns, will detect subtle changes, and it will give you better results. So you can use it as an assistant. It's not going to replace you. I don't think AI is going to replace us at all. And plus, it will optimize our disease care and delivery of treatment. And millions of people, like I'm sure if we develop an AI module which is on your smartphones and you're asked, okay, put in these parameters and it's going to tell you whether it's KD or not, it's going to help. A lot of areas do not have PGI, AIMS or other centers, right? And so they might benefit from these AI modules. So what are the techniques that are used in Kawasaki disease? See, machine learning was there. It's still there. It's getting improved. It's that forest plots that we use, the logistic regressions that we use. But deep learning is something very interesting. Image-based. You send it echo images. It will start assessing your coronary arteries, may detect other changes also, which maybe our human eye has not yet considered it a pattern. So in the future it may. Then this is what I was talking about, large language models. So whatever knowledge that ChatGPT is giving you is not restricted to your textbooks. Maybe if we have small language models, which references of our textbooks, our standard textbooks, we may have a better AI model. So challenges, we all know about the challenges, right? Atypical presentation. Currently, somebody may feel, oh, strawberry tongue hai. Somebody may say, no, there is no strawberry tongue. And somebody may say, oh, this is viral exanthem, this is adenoviral infections. So there can be a lot of opinions, and these signs are often attributed to dehydration, multinutrient deficiencies and other things. So AI would not have those emotions, biases, right? If it is there, it is there. So it may help in diagnosis. So we did a systematic search of the PubMed and a lot of resources, and we found 46 studies. That's a lot of number between 2000 to 2024. So around 25 years, quarter of a century. So these studies were basically focused on diagnosis and outcome prediction, because that's what we are, right now we are engrossed in that only. So AI models for prediction of diagnosis in KD was very, very high. The sensitivities were in its 90s and specificity was as high as 97%. And it also predicted IVIG resistance better than the normal conventional scores. So echocardiographic analysis, many models are there, but this is the one, I think Dr. Devdatta ma'am might shed some light on these kind of softwares. I couldn't understand much of it. So whatever I could understand, that it is an unsupervised AI method, and it keeps learning from the images that you keep putting in it. And it's got a good predictive value, and it does differentiate severe cases for early intervention. So these, again, high accuracy, high sensitivity and specificity. Now, something that is more of my my playing field. So this was something which was done from our unit. This was, I would like to thank Dr. Sameer Gulati, because he's the one who did the coding and the analysis, and I just provided the data. So this is how we use the AI for predictive analysis. So what we wanted, the mass is a dreaded complication of Kawasaki disease, and it would really help us if we can use the simple history, examination and simple investigations like LFTs, CRPs, and if we are able to basically say that, okay, this patient is of mass and we need to intensify the therapy, it will be great.
in a utopic world. So what did we do? We took 42 children diagnosed with KD. This was during the COVID time where we had a lot of KD and our center was working and we did not pick and choose COVID patients. So we had 33% of our patients developed mass, which was a very high number. And we made a classification tree. Basically, the data is divided into the data set and the training set. So what did we come up with? A very simple if and but model. So whenever a patient comes to us, myocardial dysfunction was defined as shock with cardiac markers increased. So if myocardial dysfunction was present, look at the serum albumin. If hypoalbuminemia less than 2.8 was there, then you look at the fever duration. If the fever duration was more than 6 days, then the node 12, that means 100% of probability that this kind of picture would have mass. Similarly, it was done for different. So, we may not get fibrinogen at point of care. We may not get ferritin at point of care, but we certainly will get LFTs. We will get an albumin. We will get NT-proBNP. We will get CPKMB. We may get TROP-T. Right? So this made our life a little easier and more, hopefully we'll get more predictive analysis. So another one, biomarkers. I think everyone is very fond of biomarkers, NT-proBNP, CRP, even thyroid hormones, GGT. So many markers are coming up. So this was another paper that I found where they derived a blood test and they compared it patients with KD and patients with an acute viral illness or an acute febrile illness. So what they did was they started with 11 biomarkers. So what did they do? They basically evaluated the diagnostic performance of this blood test, right? So they had some 1,000 patients and what they did was they reduced this 11 biomarkers to 3 biomarkers, which was CRP, NT-proBNP and thyroid hormone uptake. I think NT-proBNP and CRP we are using very commonly. I think it is a standard of care now. But thyroid hormone uptake was a little difficult for me to put it in our algorithm. But they did have a very high specificity and sensitivity as well. So again, 92% AUC, area under the curve, with 86% sensitivity and specificity, which I really feel is very good. I mean, I know this gathering people may have 95% and above diagnostic rates for KD, but otherwise if you go outside the group, if you look at our general pediatric colleagues or other institutes where KD is not being treated, this will do wonders for them. Another, then what about the meta-analysis? So how is machine learning performing? So is there any data on that? Yes, there was a meta-analysis here that was done from China. And this study assessed the accuracy of machine learning models. And what did they do? They basically assessed these models to differentiate KD from other acute febrile illnesses. And this is what is our dilemma at most of the times. Basically 20 studies with 10,000 participants. And they said that there was concordance, that is KD actual and what the machine learning predicted of as high as 89%. I think this is a very, very promising result, and sensitivity of more than 90% and specificity of more than 80%. And so another study was where coronary artery lesion prediction had also had a very good pooled concordance of around 78%. I think we are getting there with AI. So a lot of meta-analysis are being done in KD for diagnostic purposes. This is a ray, kind of a sun ray diagram, which shows that most commonly studied parameters in those 20 studies was CRP, neutrophils, white blood cells, platelets, lymphocytes, hemoglobin, and so on and so forth. You have so many parameters that have been studied, and this is what differentiated Kawasaki disease from the other acute viral illnesses, and most of the illnesses were viral in this. And now what about the coronary artery lesions? Again, the most common studied were C-reactive protein, IVIG resistance, age, and what was the duration of fever before the illness occurred, and so on and so forth. So ethical consideration, I think Dr. Akash was presenting something about AI from Bhatinda. So ethical concerns are going to be many. And ICMR, I think, has once again proved that they are they are with the times. So they've taken out these ethical guidelines for application of AI in biomedical research and healthcare. So what are the ethical principles? First of all is non-discrimination and fairness, optimization and data quality. The data that you're putting in, that has to be regulated. See, we all know in PubMed, right? Garbage in, garbage out. If you do not give the right data, you're not going to get the right results. If your question to your chat GPT is not specific, you will get random answers and you'll say, oh, this is worthless, it doesn't work. Let's just go back to our textbooks. No, we probably need to train it well. We probably need to use small language models, and we probably need to formulate our question, our questions in a proper manner. What exactly do you want? See, it's not a human. It's not going to understand the subtext or the emotion. If I'm saying something angrily, it is not going to work faster. Right? So it's not going to be the professor is shouting on the round so the PGs become more efficient. I'm sorry, that's not going to happen with the AI. It's going to work at its own speed. है ना, वो जल्दी नहीं करेगा, वो उसी से करेगा, and it will learn what you make it learn. So that's very, very important. Accessibility, everyone should have an access to this. It should not be that we have beautiful models, it is patented, and then, you know, poor people do not have access to it. Risk minimization and safety, collaboration, autonomy, data privacy, accountability and liability. If you treated a patient based on AI, so if in medical legal case, do they sue you or do they sue the AI? So that's going to be another dilemma. So trustworthiness, data security, and all that, you know, I think as we keep making these models. So these are ethical checklists that I think you can go through the document. And artificial intelligence in cardiology is being used in a big way. And even there are many other fields which I did not do much of a research. So what are the challenges? The challenges, like I think I have gone through it: incomplete data, bias, black box nature, lack of transparency, overfitting, you're trying to fit in your diagnosis, limited standardization, integration with existing system. There might not be acceptability. See, young generation may be very happy accepting technology, right? The older ones may not so much. Middle ones, maybe, I don't know, with time. So future ahead, enhanced diagnostics, personalized medicine, drug discovery and development. I think Dr. Akash went through this, so I'm not going to go ahead. So doctors not using AI, this is Atul Gawande, a renowned American surgeon writer. He has said that doctors not using AI may end up getting replaced. I think it's I don't think that's true, but I certainly believe that a doctor with an appropriate AI, with knowing the limitations of AI and not letting go of our own human intelligence, we combining with the artificial intelligence, we will become much greater than what an average doctor would. Thank you very much.
Thank you, ma'am, for the solution talk. And so basically, artificial intelligence is coming in a big way, and possibly it's a holy grail of this century, because we have to learn how to use this and where to use this. So in the interest of time, I'll take one question or comment.
Yeah, please.
Excellent talk.
Okay, thank you.
Just I want to make only 2 comments. One is that age has nothing to do with the curiosity. I still said that knowledge is mostly proportional to ego, or ego is mostly proportional to
Absolutely, absolutely.
ego is not there. I mean, I'm 58 and
Oh my.
I was the first one in the department to start AI, and recently I had an action course with the new joinees, and I taught them about AI. And
Wow.
nobody had heard of ChatGPT, Gamma, Perplexity, so I made them aware of that.
Amazing, ma'am. I think a big hand for ma'am. Amazing, yes.
My father is 83 years old. He does all the Aadhaar card ko pen se kaise karna hai, that job. He's that
Wow.
excited. So excitement, curiosity,
Yes.
that should keep you. That is one thing which keeps you alive.
Yes.
Human is not growing; is the human who's dying.
Absolutely, ma'am. Absolutely.
And learn
Absolutely.
So I think that is one comment I want to make. Second idea, that is very, very important comment. The insecurity that it will replace.
Yes, it won't.
Pediatricians, we are safe. Physicians are safe.
Yes.
Surgeons are safe. Only people who might be replaced are radiologists, dermatologists, pathologists.
Okay.
I agree, they are the best.
Yes,
You don't
ma'am.
need to have history, I'm the pathologist, kindly correlate clinically, kindly meet personally. You have seen 1,000 cases of one disease, and one slide comes, you will say, I don't need any history, this is this diagnosis.
Absolutely,
But
ma'am.
AI is like super PGI, PGI 10x, because that has gone through all the textbooks.
Yes, ma'am. Absolutely.
So we cannot replace AI, but doctors without knowing AI will be replaced.
Absolutely, ma'am. We need to embrace this technology.
Statement at the end is that doctor with AI is going to replace doctor without AI.
Absolutely.
So when we kill our egos and start learning AI.
Start learning. Yes, ma'am. Thank you, ma'am. Thank you. Thank you, everyone.
Next one, Dr. Amita.
Thank you, ma'am, for showing us the clinical utility of artificial intelligence in day-to-day clinical judgments. What more AI holds for us in the future? So, to chair the next session, we invite Dr. Priyankar Pal. He's the professor and head of the Department Pediatrics and unit head of Pediatric Rheumatology at the Institute of Child Health in Kolkata.
Dr. Jini Sachdeva. Speaker, Dr. Sachdeva.
So, continuing with our venture into artificial intelligence, the next speaker is Dr. GIAN Sachdeva. She is an associate professor at the Electrical and Instrumentation Engineering Department, Harvard Institute of Engineering and Technology, Patiala. So she has a lot of achievements, technical papers in 24 SCI journals, amazing number of citations, 933. She has done some sponsored projects, 3D MRI data processing using deep learning, completed a grant amount of 44.83 lakhs by ICMR, and ongoing is AI-based CAD system for 3D segmentation and classification of traumatic brain injury on CT and CT angiography. So 5 patents have been done. She has received honors the Image RT Fellowship in 2008 and 9 and National Doctoral Fellowship 2009 to 2012. I invite ma'am to come. Thanks.
Good morning, everyone. Thank you, sir. Now, ma'am has covered much of the things. That is about the artificial intelligence and artificial basics. I will be continuing the same things with the introduction, because when I deal with the doctors, when I have an interaction with the doctors, they basically ask me what is artificial intelligence, what it actually does, how the images, how the data is being trained, how you analyze the data, what are the parameters, what are the specificity, sensitivity, what are these parameters, how they help us and you to know the evaluations. Now, as ma'am has already told, that is, it is the automating process of computing, enabling computers to work efficiently with incomplete, complex patterns. AI systems are designed to think like humans, they act like humans, but they are not going to replace humans. Think rationally, they can act rationally, but both on supervised and unsupervised learning. I would be covering those topics as well. Now, this is Sophia. This is one of, ma'am has already told that, sorry. This is a bit of repetition I was not doing. That is Sophia, and she is the first humanoid robot, and she has been granted Saudi Arabia citizenship as well. Now, what are the fields where AI covers? It covers cognitive learning, computer vision, deep learning, genomics, natural NLPs, machine learning as well. In imaging, I have made a certain stepwise procedural setup so that doctors can know what exactly what is going to happen in these things. Though it provides automation, it provides accuracy, but with the input, that is computer-aided detection systems quantitative tools, I've marked skill-based, rule-based, knowledge-based, and expertise. These are going to be side by side. These are going to be an inputs to the AI systems. That is, skill of the doctor as well of the engineer, rule-based, certain rules in the coding which we have to associate, and also your inputs, that this is the certain limit of something that beyond this limit, you cannot set your algorithm, some certain levels of biomarkers or something. You have to provide us that data. Knowledge base is that the initial knowledge which the AI has, it starts from very basics, that is bias and weights. The bias and weights knowledge base means initial weight. So suppose you have a biomarker, what weight you want to give it? Is it a very high on your list? The weightage depending upon how it is affecting your calculations, but obviously your expertise. CAD use computer algorithms and machine learnings to analyze medical images, assisting doctors in detecting and evaluating abnormalities, potentially improving diagnostic accuracy and efficiency. Such as I have given one of the examples, that is how to differentiate between different tumor types, malignant or benign, or it can be glioblastoma multiforme or other lesions, and segregating this infiltrative tumor boundaries. Now, we also have decision support tools for detection and quantification, along with electronic health records, pathology reports, and other patient records to assist with the diagnosis. Now, ma'am has told about the supervised and unsupervised learning. I'm just letting you know what these basics are all about. That is, labeled data. Deep learning cannot work without annotations. जब तक deep learning आएगा, आपको initial data annotize करके हमें engineers को देना ही पड़ेगा. This is the basics of that. That is, for having an accuracy on a trained data, how that accuracy is being measured. The markings, the annotations done by you are basics of our ground, are the basics, are the ground truth for us. And if we map those with our learnings of the algorithm, then we say that this is the source. Or if you say this particular feature, this is of no use. So then we have to remove that particular feature, and this constitutes our supervised learning. That is, supervised learning is when we teach or train the machine using data that is well labeled. Some data is already tagged. Their internet is having the internet repositories where there is a lot of data, but many of that data has poor quality. They have got noise, or they do not have the annotated data sets. We cannot go, the engineers cannot go without annotations, and they cannot test the data without these supervised learning things. This algorithm is completely opposite to the supervised. The unsupervised ones, there is no complete and clean label data sets in supervised learning. It learns from very small basics from the patterns by itself. And then it is they self-organize themselves. Its main aim is to explore the underlying patterns and predicts the output. Now, what is machine learning in imaging? That improves any computer program that improves its performance at some task through experience to produce an algorithm that can learn patterns inherent in a data set to perform some specified task. So what we do is we extract features. What type of features? Radiomic features. What are those radiomic features? These are first order statistics, second order statistics. First order statistics, simple from mean to standard deviation. And then we have second order statistics. Then we say gray level co-occurrence matrix, gray level recurrence matrices. That are the imaging, depending upon the image pixels. What are the combination of different pixels? Then we classify those, these parameters are being fed to the system, and then we classify based on the input features, and we get the desired output. Now, where this machine learning in healthcare is being used, how it affects the healthcare? It can optimize hospital processes such as resource allocation and patient flow, identify the patient groups for personalized and precision medicine, discover new medical knowledge, automate the detection of relevant findings in pathology and radiology, improve quality of care and population health outcomes while reducing healthcare costs, model and prevent spread of hospital-acquired infections. There are the various things where the machine learning algorithms in healthcare can be used. Now, this is a very generic flow diagram of machine learning, where I have summed up all the inputs which can be given to a computer program, to a machine learning program. Data collection is one of the most important steps, including the ethical clearance. Ethical clearance is what we need at the present hour. There shall be collaborations, but this is the main point, where the hospital data includes the laboratory examinations, image data, generic data, e-medical, that is electronic health records, patient characteristics, treatment repositories, follow-ups, histories, and also clinical lab reports. Now, the second thing is data pre-processing. The data which you give us is not normalized at all. You have different systems where you collect the data, you have different imaging modalities, even the setting of the parameters is also very much different. Also, in the e-medical records, there is some, what we say is, there is some data lagging and imbalanced data. If you give us similar type of diseases, to classify those diseases, then one of the most important thing is data imbalance. Data imbalance is what that for one disease, a similar disease, you have got 100 patients, 100 reports, and for the other one, you have only 20 reports. By this, the model is unable to train itself, because it is what is other thing is, what we say is overtraining, overfitting, underfitting. So these problems arise when we deal with the data imbalance problems. Then we have model selections after data pre-processing, that is bias correction. I'm repeating the data pre-processing steps. There are very much more important steps, that is noise removal. And then we have many filters in those. Those are totally imaging filters. And if we have 1D data, then we say it signal processing filters, where we remove certain set of highly noised data from the all over data sets. Then we go for the model selection, in which we have NLPs or machine learning, that is decision trees or random forests, naive Bayes, and finally we have the training of the model and evaluate the parameters according to the output of the applications. Now, the other thing what we deal with is the deep neural networks. You might have heard about the word CNNs. That is convolution neural networks. The convolution term in itself is convolving the information from the various steps. Convolution was firstly, we just read that thing in digital signal processing in very second year of our textbooks in engineering. Then they moved to 2D data, then the 3D data, and is a deep and wide, what deep neural network? It is a deep and wide neural networks, and these utilize algorithms that derive meaningful data using hierarchy of multiple layers that mimics the neural networks of human brain. If we provide the system tons of information, it begins to understand it and respond in a useful way. It can learn increasingly complex features and train complex networks, more specific and move general purpose than hand-engineered features. Why is deep learning useful? Manually designed features are often overspecified, incomplete, and take a long time to design and validate. Learned features are easy to adapt, fast to learn. Deep learning provides a very flexible, universal learnable framework, and it can work on both supervised and unsupervised learning patterns. This is what the traditional ML algorithms and deep learning algorithm accuracies have. In the recent past, the sensitivity is above 90%, even the specificity is above 90%. Now the data sets are being divided into 3 parts, that is training, validation, and test data sets. What I do in my algorithms is I literally train the data set with 60%, and I keep 40% as unrepetitive, unused data. I just really want to see how the regression models, how these all models are working on the data sets, how the data is being learned and how the output is being affected. Because when you go for the training, though there is a validation data set, what is this validation data set is? This is known as K-folds. That is, some data is being kept by the machine for testing purpose by itself. Now, if we keep the testing data set that is totally unseen, we can see the variations of the patterns as well. What are the basic things which are being learned and what things it is unable to detect, unable to learn the patterns. That is why it's very much important. Rather than go, if you will find the papers, if you will see the initial papers, you will find 90% plus papers, there is 80% and 20% of the divisions of training and testing data set. Try to understand if we are going for 80 to 20% ratios, but obviously there will be overfitting. That is, overfitting means overtrain. You're training the same type of data sets to the system, and it will behave accordingly. If I give you 10 sums of plus and the same pattern is being repeated in your end-sum test, but obviously if the same values are being given, you would perform better. That is why it's better to have 30 to 40% data and unrepetitive test data in the testing sets. This is what underfitting and overfitting is. That is, underlying patterns poorly are being captured by the model. It's too simple for the complexity of the data, insufficient training, and there is low variance. And whereas overfitting, they have irrelevant details, excellent performance on the data, but poor performance on new data. That is what I'm saying. Keep your data sets as when you are dealing with the engineers, tell them to have 60% of the training data set and 30 to 40, 60 to 70 of the training, and 30 to 40 unseen, unrepetitive data. Now, these are few of the evaluation matrices, that is accuracy, precision, recall, sensitivity. The sensitivity can reach up to 90 plus 95 to 98%, but specificity cannot. If you have 85 to 90% of the specificity, kindly go through these things as well, that this is much more efficient. This means, again I'm saying the same word, that your model is not overtrained. Now, F1 score is also known as a dissimilarity coefficient. It is being used when you have 1D data, laboratory tests, we generally go for F1 score, and the other naming is dissimilarity coefficient when we deal with the imaging data. That it is a statistical measure to evaluate the similarity between two sets of data to assess the overlap. Now, what is this overlap of the data is that what you deal with, your annotations. That is your supervised data, your markings when you give us the data. Now this is, I have got the few publications and the recent past where this is I have marked 3D imaging, 3D tumor imaging, and this is the view of the segmented 3 regions of the tumor, and this is what we made. This is the actual, this is how much coding and work we go through to reach the outputs. And it's very detailed versions where we convolve many filters, 3D filters, 5 windows, 3D windows, concatenate those layers, then we have max pooling layers, convolution layers, and finally we get the 3 boundaries, 3 whole tumor and those tumor boundaries in the image itself. This is how it looks when it is a 2D imaging, and this is what it looks in a 3D imaging. Now finally moving to explainable AI. Now this is the recent explainable and crystal AIs. Oh, just, okay sir, I will be. Now this is one of the diagrams what I'm saying, that we have in the machine learning, now the improved version of machine learning, that is explainable AI. Now it includes LIME and SHAP. This is what it generates local approximations and contribute most to the specific predictions, and these divide into segmenting the image into regions, and then these regions are being understood by the algorithm. And it also, the other one is SHAP. It goes for the Shapley features, and we have global and local explanations providing insights into the overall model, and it determines the contribution of each feature to the model prediction. Now, finally, moving to the cardiac imaging, we have image processing techniques that system aims to accurately segment and quantify arterial calcifications from cardiac OCT images. Now these approaches enhances diagnostic precision, reduces manual effort and support clinicians in early detection and treatment planning. This is from the literature survey where we have got the accuracy of 93.2%. See, here the DICE similarity coefficient is only 0.693%, and it is not bad. Seriously, overlap regions with the doctor markings, it's good enough. Now, again, there is one of the with a F1 score of 94%, and this is a sensitivity or specificity. I already told you it shall be from 85 to 90%. That means your algorithm is working good. You have not to go for higher ranges. It's good if you are having from 85 to 90. Your sensitivity or your accuracy can be 98 to 97%. So this is what we are planning to do for segmenting arterial calcification from cardiac imaging data. But obviously the problem is about the ethical clearance, and Rakesh sir and we are planning for the for clearing of those ethical commitments. And in the development of deep learning models for AI-based algorithms of flow dynamics and risk stratification in coronary artery aneurysms and Kawasaki disease using CT angiography. This is a project we are hoping to do. That is the impact of CAs on flow hemodynamics in children with KD, and using advanced computational techniques such as deep learning in AI to analyze flow dynamics in CAs using CT-CA image-based data. And can these be integrated to improve risk stratification and long-term outcomes in KD patients with CAs? Thank you.
Thank you, ma'am. So, I understand that it's a completely new area for us, and we must be having a lot of questions, but in the interest of time, we will move on to the next session. So, any questions, you can always discuss in the detail. Thank you.
Thank you, sir.
So the matter of the moment of this conference is Kawasaki disease. What predisposes one to get and what makes the other child not get. So we used to think our fate was in our stars, but now in large measure we know it is in our genes. So to chair the next session, I invite Dr. Professor Saji Philip. He is the founder president of Kawasaki Disease Foundation of India and Indian Society of Kawasaki Disease.
We are half an hour behind the schedule, and I request all the speakers to keep the time exactly what they look. Next talk will be on genetics of Kawasaki disease, a global update by Dr. Pgimer. He's a professor of immunology at Pgimer, and the area of research is on complement deficiency and primary immunodeficiency diseases. Various publications, and over to Dr.
Thank you, Dr. Saji, for the kind introduction. And the topic I would be talking on is genetics of Kawasaki disease, a global update. So when we talk about genetic variants in any disease, I mean, this is a useful figure to look at. So you have some rare or ultra-rare variants which are associated with a high effect size, and the Mendelian diseases, which is the Mendelian pattern of inheritance, would fall here. Whereas if you have common variants in common diseases, for example, diabetes or hypertension, you will be having common variants which are very common in the population, but the effect size, I mean the effect of that variant on the phenotype will be very little. So the common diseases with the common variants will fall here, and low frequency variants with intermediate effect will fall somewhere between, and that can be outliers in the both spectrums. You could have rare variants with very little effect, or you could have common variants with very high effect size. So the genetic analysis in Kawasaki disease has evolved over the time. Initial studies featured using candidate gene approach. The most common genes studied were HLA genes, because HLA has been associated with a lot of diseases, especially autoimmune diseases earlier. And non-HLA genes were also studied. And when the genome technology was made available, then we had genome-wide association studies, genome-wide linkage studies, and also now we have a few studies using whole exome and whole genome sequencing. So coming to the earlier studies, this is the first paper on the MSC associations in Kawasaki disease from Japan, where they found, they looked specifically at the MSC class 1 genes, specifically MSC class 1, HLA-A and HLA-B. And what they found was that certain alleles which have been boxed here were more common in Japanese children with Kawasaki disease, specifically HLA-B W22J, which is a specific HLA allele found in the Japanese children with Kawasaki disease. Subsequently, there were more papers on HLA antigens in Kawasaki disease from Japan, but also from New England in US, and also from the Korean population. These are some of the studies which have been highlighted in this table. So, this was done in different populations. Some alleles were common, but there were some which were specific to different populations and ethnicities. Non-HLA genes, as I've highlighted, also been studied, and you had earlier heard a talk from Dr. Vibhu. So this FC gamma receptor family genes have also been implicated both with the susceptibility to KD and also with coronary artery aneurysm formation. And this has also been studied in the context of susceptibility and formation of coronary artery lesions in KD. And this is the diagram to show the structural homology in the different FCGR genes. And also there are copy number variations which are very difficult to study by usual methods of sequencing. In the non-HLA genes, there are other genes also, most importantly the matrix metalloproteinases genes and also the chemokine receptors. And this table just highlights that. This was a large study from the US where they looked at familial occurrence of Kawasaki disease, and there were 18 families, and in families 1 to 9 there were 2 siblings which were affected, and the rest of the families, family 10 to 18, they showed what they called complex pedigrees where more than one generation or multiple individuals were affected. And in this, altogether in this family 10 to 18, there were 25 affected individuals. And this was another study where they looked at the candidate genes. This was a candidate gene approach, and they looked at, I think, 55 genes which were involved in both inflammation and cardiovascular disease. And with data analysis, they found that IL-4 locus, they first honed down to the long arm of chromosome 5, and then they found that the IL-4 was significantly associated with susceptibility to Kawasaki disease. But the first paper on the genome-wide analysis of Kawasaki disease was with Professor Onuchi, Yoshihiro Onuchi from Japan, where he showed that there was a linkage to a locus on chromosome 12. Following this, this was the landmark paper in Nature Genetics, where again from the Japanese cohort of Kawasaki disease, where they showed that a polymorphism in the intron 1 of the ITPKC gene. ITPKC stands for inositol triphosphate 3 protein kinase C, and this is involved. This is a negative regulator of T cell activation. And this particular aneurysm was, this particular SNP was associated not only with the Kawasaki disease susceptibility, but also to the formation of coronary artery aneurysms. And this figure here shows the ITPKC SNP in the intron 1 of the ITPKC gene, and the effect of this SNP on the splicing. And this figure here shows that the ITPKC gene is a negative regulator of T cell activation, and this SNP resulted in increased inflammation that was seen in Kawasaki disease. Another paper which was again published from the Japanese group by Professor Yoshihiro Onichi was in the ORAI gene. This gene is important in calcium channel signaling, which is important for T cell activation. So these are some of the genes which are associated with different pathways in KD. So you have got genes which are involved in the calcium channel signaling and T cell activation. ITPKC is a negative regulator, ORAI1 and STIM are positive regulators. You have got genes involved in B cell signaling, the CD40 gene, the BLK, the B linker gene, and also a locus on the immunoglobulin heavy chain. And then you've got others like TGF-beta signaling and caspase-3, which is involved in apoptosis. So there are multiple genes involving different pathways which have been studied in different populations and ethnicities. So this was a replication study of this ITPKC and the caspase-3 polymorphism in the Taiwanese population, where they're trying to see whether co-occurrence of these two polymorphisms was associated with coronary artery lesions or a responsiveness to IVIG. Though they were able to show that the co-occurrence of these two polymorphisms in a given patient increased the likelihood of a coronary artery abnormality, but it was not significant enough for the data was not significant for the IVIG responsiveness. This was again a paper from the Korean group where they showed that this SNP in the high mobility group box protein 1 was associated with both coronary artery aneurysms and also resistance to IVIG. So this was the data for the coronary artery aneurysm, where you can see that the risk allele GG in the homozygous form or in the heterozygous form was associated with significantly associated with the risk of development of coronary artery aneurysms compared to the wild type allele. And similarly, the same polymorphism in the this HMGB1 gene was associated with resistance to IVIG as well. And these are some of the genes which I have highlighted which are associated with the resistance to IVIG. This was one paper where they have used whole genome sequencing to look at genetic variants in patients with Kawasaki disease. This was a Afro-American family from the US where 2 of the 4 children were affected with KD, and they did whole genome sequencing in the parents and also the 4 siblings, and they found compound heterozygous rare variants in the TLR6 gene in these 2 affected siblings. And in addition, they found other SNPs in the TLR6 gene in this family. This was the pipeline they used to come to these 2 variants. And they did some functional analysis also, and it showed that the genotype, this particular allele was also associated with transcript levels of interleukin 6, which is a pro-inflammatory cytokine. This was a study, this was a multi-center study where data was to develop a diagnostic test for KD. As we know, there is no pathognomic diagnostic test for KD. So in this, they looked at a cohort of KD patients from Japan, from US, from Europe, and what they did was a gene expression array. It was not RNA sequencing, it was a gene expression array where they looked at 30,000 genes with around 47,000 probes, and they came up with this 13 transcript gene signature which could classify the patients of KD from other diseases. These 13 genes include some genes which are regulated to immune pathways like the CD163, the interferon alpha inducible protein 27, but there are some other genes also like the zinc finger proteins, the reticulon, the S100P. So these were the 13 genes which they shortlisted from this transcription array study. And when they compared this, so this is KD. So there were 2 sets, as has been highlighted earlier. This was the discovery set. This is the validation set. In the discovery set, they had KD. They have got definite bacterial, definite viral, unclassified, GIA and HSP. As you can see that it was able to discriminate KD from other causes, and also in the training in the validation set also it was able to, this 13 gene signature was able to discriminate KD definite or highly probable from other causes which may mimic KD, like probable KD, definite bacterial, definite viral, or undefined etiology. So the new, what has been new in the recent years, so this is the study from the European cohort. It was from US and Europe and also UK, where patients of Caucasian ancestry were enrolled for the study. And they found this novel intergenic locus on chromosome 20, which was associated with coronary artery aneurysm. And also they validated other SNPs which have been already reported, like the ITPKC and also the SNP in the FCGR2A gene. So this is a Manhattan plot here, which shows that this is the Manhattan plot showing the GWAS for coronary artery aneurysm. And as you can see, there are variants in the intergenic region of chromosome 20, which has been highlighted in the regional plot here. And these are the ones for the susceptibility to KD. And then again, the regional plot showing the different SNPs which were found in this study. So to conclude, the genetic susceptibility to KD can involve different genes. It can be just KD susceptibility. It could be genes associated with aneurysm formation, or it could be genes which confer resistance to IVIG. And this could be genes which influence the immune system, or it could be other genes. And then there are some genes which are involved in T cell signaling through the calcium channels involved. So you've got genes like your ORAI, STIM1, which are involved in, which are calcium channel regulators, or ITPKC, which is a negative regulator. And then it causes the SNP in this causes the activation of T cells, or you could have other regions which influence the immune system like CD40, TLR6, IL4, BLK. But the problem with these studies is that there are some genes which have been validated in different cohorts, like the ITPKC, the FCGR2A has been validated with different cohorts. But there are others which are specifically found in one population, like the immunoglobulin heavy chain locus is found only in the Asian population, specifically the Japanese, and it has not been validated in other cohorts. So I think probably it's true. I mean, it would be wise to think that there is a genetic susceptibility, which may not be monogenic, but a polygenic inheritance, which predisposes the individual, and upon an environmental insult or trigger leads to the KD. Thank you very much. And this mnemonic for KD I found while I was preparing for the lecture. So it's called CRASH, and it was crash and burn. I don't know, the burn is for Jane Burns, because it was coined by a house staff at the Rady Children's Hospital. So it was crash and burn. Thank you very much.
Thank you. I think the next topic also on genetic of Kawasaki is the Indian scenario. Then after that, maybe one or two questions can be from the floor.
Thank you, sir. For the next talk, I invite Dr. Rakesh Kumar Pilania, Associate Professor of Pediatric Allergy Immunology Unit.
So for next talk, I invite my colleague and friend Manpreet Aliwal. She is an Associate Professor in Pediatric Allergy Immunology. So Manpreet, stage is yours.
Next talk.
She will be talking on the genetics of Kawasaki disease in Indian scenario. So where are we in the genetics of Kawasaki disease?
Okay. Good morning, everyone. Thank you, Dr. Rakesh, for the introduction and for calling me your friend. So, any talk which you have to give after Professor Rawat, it really stresses me out because the bar is set so high, but I'll try to do justice to the 15 minutes that have been allotted to me. So, I've been asked to cover the genetics of Kawasaki disease in the Indian scenario. So what I'll do is I'll just talk about all the work that's been done in India, but before I move to that, I'll just like to drive a point which probably the audience is, already well versed with, that the probable acute infection because of this family of viruses in a host with the genetic predisposition can lead to an aberrant immune response and finally leads to development of the constellation of symptoms that we know as Kawasaki disease. So this is the model which is, mostly accepted. And so this triad of infection in the background of genetics leading to an aberrant immunity is what defines KD. And today I'll just concentrate on the genetic component, and this has been really nicely described by Amit sir. So this is just to let you know that these are the main genes which are known to be involved in the genetics of KD, and I'll concentrate on this few of these genes on the studies that have been done in India. So as I've driven this point earlier also, why talk about genetics? The main 3 points would be the skewed epidemiology that we know, and the fact that the incidence in Japan is similar to the incidence amongst Japanese settled in Hawaii, and the fact that the occurrence in sibling is also reported. So this all kind of hints towards a possible genetic background to this disease. So these are some of the papers, but what I've done is I'll probably walk you through these papers one by one. But before that, let me just overwhelm you with this really complicated picture and also tell you that this is how diversity operates. Do not look at the penguins, they all look the same, but diversity in our genome is at different levels. It can be at the level of DNA, RNA, or at the level of protein. And the interesting thing is this diagram is not new. This is from 2013. So even in 2013, we knew that, diversity can happen at all these levels. But what we've kind of really concentrated at in India is looking at just the different SNPs which can be involved in the pathogenesis of KD. So other than this, there is so many other things which are waiting to be discovered. But I'll just talk a bit about our experience in Chandigarh. This is the first study which I'd like to highlight, more so because this really drives home the point that looking at genetics is important, because the alleles reported in this study were taken from a study in Japan, and where it was found to be significantly associated. But as you can see that in our center, we only found a significant association in one risk allele. So this really drives home the point that these studies are needed to be performed in different ethnicities and in much larger groups to really understand what is happening and what are the significant association between the different risk alleles. So this another paper from our center talks about the single nucleotide polymorphisms in the caspase-3. Amit sir has already told us about the role of caspase-3 in the pathogenesis. But so in this study, we aim to look at the association of this alleles in this caspase-3 gene. And we found that there was a significant association between this risk allele with the development of CAAs in patients. Orivan, which is known to be involved in the calcium signaling, and this is another important gene in the pathogenesis of KD. And sorry, I skipped a few slides. And in this, we found that there was no significant difference in our cohort. But again, these are very small studies and have to be extrapolated to much larger groups. So another study by Dr. Pratap Patra, who is already sitting here, he has looked at the role of the CD40 gene polymorphisms. Although he could not find a significant association in the genetic polymorphisms, but he did report the higher expression of CD40 in patients with Kawasaki disease as compared to the control group. So Dr. Ankita decided to look at the role of thrombomodulin gene. So the role of this gene is a gray area even in the global literature. Truly speaking, whether this gene influences the plasma levels of thrombomodulin is not clear. But in her study, she did find that there was a correlation, but the role of polymorphisms with the development of KD or the CAAs was not found to be statistically significant. Next, I think this is one of the earliest studies from our unit, and in this, Dr. Costa decided to look at the role of the RANTES or the CCL5, the polymorphisms reported in this gene. So in this, again, he found that patients with CAA had a higher frequency of the minor allele. So this basically is involved in the recruitment of the different cells such as the T cells, monocytes, and the granulocytes, and also in the immunomodulation by polarizing the response because of the M2 macrophages. So this is a recent study by Dr. Manish. He looked at the association of the single nucleotide polymorphisms of TGF-beta, which is known to be a cardiovascular, involved in cardiovascular remodeling. So in this case, he did find some significant, polymorphisms in his cohort. So this is just a really, very simplistic view of the work that has been done. But again, this brings us to the question that what more can be done. So recently, the collaborative effort by Genome India, they have published this database of the 1,000 Indian genomes. So this is a very interesting group. And the call is already open. If you wish, you can have access to the data. If you give them a big proposal about how you will save the data and you will keep the data sharing policies in place. So from this, we can actually build the reference genome for the Indian patients. And again, this can be then, used to look at the polymorphisms and, revisit all this data in the context of the Indian population. So this initiative is by India, but many other countries have already published, and, this data keeps on getting updated regularly. And now we've really looked at the DNA. So what next? So this is just the tip of the iceberg. This is really interesting because other than DNA, there can be variations in RNA. RNA can also be involved in looking at the genetic complexity in these patients. So RNA can be of different kinds, as we know, microRNA, long non-coding, so on and so forth. But the work that we've done in our group is to look at the differentially expressed genes to delineate common pathways involved in KD. So this paper was published from my unit, and this is just a simple reanalysis which I did to see which neutrophil genes are involved, and by drawing this string interacting network, we could see that the genes involved in neutrophil regranulation are actually, significantly important in patients with KD. So Dr. Abarna decided to, take this up as her DM thesis, and she actually validated a number of big gene sets using real-time PCR in the lab, and she found many upregulated and downregulated genes which were reported from the bioinformatic analysis. So this is just a reanalysis of her data to look at how the interacting networks operate. So other than this, we've also looked at the role of microRNAs in Kawasaki disease. This is from the global data, and they've reported a number of microRNAs which have been implicated in pathogenesis of KD, and they're significantly higher during the acute stage. And they're also associated with IVIG resistance. But in our unit, Dr. Himanshi has actually evaluated these two microRNAs, 145 and 320A, in our cohort and compared them to the febrile controls, and she found a decreased expression of these two microRNAs, but no difference in this microRNA. So once we've moved on, we've looked at the DNA, the RNA, so what else is left? So there can be epigenetic variations also. Although we've not really studied this work in detail, but a review was published from our center talking about the role of epigenetics in KD. And from this review, certain genes have been shorted out which could have a role in KD because of the different methylation pattern in these genes, and they may be associated with the formation of CAAs. So this is an exciting avenue which can be explored in future studies. So just to summarize, since we're already running short of time, I tried to be as fast as I possibly could. So, there are many directions which genetics can take us. We can look at, as Amit sir has already described out, the whole genome. Sequencing, epigenetics can be looked into more detail. This can lead to more personalized therapies, and obviously, precision medicine can be another takeaway from this, and also we can develop some polygenic risk scores, because till date Kawasaki disease is not a monogenic disorder. So finally, with the advent of this 10,000 genomes, I feel like the call of the hour is to really have some collaborative, multicentric studies, a big cohort of these patients, evaluate them by using all the cutting edge tech which is available now, and really understand the different genes and their polymorphisms, or try to understand the genetic basis of this disease. With this, I thank you for your time, and I think Amit sir will take up any further questions.
Thank you, Manpreet, and both talks are open for the questions or comments. I have your questions.
mentioned that many genes are associated with the KD, which you have showed the slide. So when you send for the gene sequences sample, whether you have to mention that particular gene to be overlooked, or the entire genes will be analyzed by the genetist, or practically how it will.
So, sir, when you will send any patient sample for example, exome sequencing, if you will tell the disease phenotype, if it is a monogenic disorder, then their medical geneticist will give you a report. But in KD, because we do not have a monogenic cause, so you will get the file from them. It's called an annotated or an unannotated variant call file, VCF. So that file, we can open it in the Excel format. And we do have a list of genes which we know are important for KD. So we can actually screen those genes and look at how, what is the polymorphisms, because what are the variants in those genes, sorry. And so that we can do that in-house. We do that routinely for our PID patients, but that same approach can be used in KD also.
Excellent talks by both of you. What I want to know is, since I am from dinosaur age, when I was doing PG, we did not see these cases. I don't think so we missed it, because those patients would have cardiac complications now. So what do you think, why this is increasing in India? Because last few years, we are also presenting a paper on 50 cases. Every month we are getting one case, and we may be missing many atypical.
Sure.
So what mutation, is there a mutation which is occurring? Number two question is that most of this is like an autoimmune disorder, right? Is it like an autoimmune disorder?
Well, I mean, it's a vascular.
All vasculitis are bodies reacting against. That's why IVIG is given, because something is wrong with the immune system. Most of the autoimmune disorders are common in females, 4:1 ratio. But somehow Kawasaki is more common in males. Is there any scientific reason for that? These two questions. Thank you.
Sure. I think for the first question, Rakesh, would you like to comment on why we are diagnosing more cases? This is something which we hear a lot, wherever we do go and present our data. I mean, even in our institute, we are questioned as to why are we picking up more KD. I think Rakesh will be the best person to answer.
For the question, basically the incidence of Kawasaki disease is increasing in the Asian countries, like Japan in last 3 decades has reporting almost 7 to 8 times. The recent update, which has came last year only, has the incidence data is more than 400 per 100,000 students, which means that the incidence is worldwide increasing. But the more important in our setup is possibly ascertainment, because the recognition has also gone up high, and so in our setup possibly the several factors are there, and possibly the most important factor would be the increased recognition, and because now we there is a increased recognition because of acknowledgement, and the pediatricians who are know about the disease, so that's why the incidence is increasing. But it's multifactorial. It's not because in Japan, despite everything, they are reporting more and more patients. So, but reasons that why incidence is increasing, nobody knows possibly.
Probably the triggering factors also increasing, because this is a circulating immune complex vasculitis. The triggering factors or infectious agent or some other factors, those factors also increasing. So could be one cause the incidence is very high.
Just one quick question, that is, have you encountered the disease in siblings? Sometimes we do encounter it in siblings, but those have been very few. So any particular time you have seen any particular gene that was there in those siblings?
We have not performed in siblings the genetics, but we have 10 families with siblings has been affected in our cohort. So there is a data to suggest, and Amit sir has also presented a study in review about the siblings and the genome analysis. So possibly there is in one of them there is a defect in the TLR pathway was also highlighted. So possibly there is a reasons to believe that because of the sibling occurrence in the sibling this disease, the genetics has played a role in it.
Recently we had two monozygotic twins developing KD at the same time.
Mhm.
And we did a biofire also for any organism. Both were negative. And incidentally, when we took the history, the mother was a nursing tutor. So the cousin of these affected children developed KD pre-COVID around 2018. So some genetics is there. So we couldn't do anything else. We will. Thank you.
Thank you.
Thank you, ma'am. If we collate building the human to a building of a house, Amit sir always says, if genomes provide the blueprint, the building material furnishing, everything is provided by proteomics and metabolomics. So it might have answers to unanswered questions. So to chair the next session, I invite Professor Amit Rawat sir, Professor of Allergy Immunology Unit. His key areas of research is on complement deficiency and primary immunodeficiencies.
Next talk we have Dr. GIAN, who is Associate Professor in Pediatric Biochemistry Department of Pediatrics, and he will be talking about recent insights and advances of proteomics and metabolomics in Kawasaki disease. Over to you.
Thank you, sir, for introduction. Good morning to all. So I am presenting recent advances in proteomic and metabolomic studies in Kawasaki disease. So first I will discuss about metabolomic studies and then followed by proteomic studies. This is a basic pipeline workflow for metabolomic disease, where we started collections from the sample, biological samples from patients and controls. Then we need to extract metabolic extractions. Then data need to be acquired in the instruments like liquid chromatography, coupled with mass spectrometry or gas chromatography or mass spectrometry or NMR. So depending upon that nature of metabolite, we have to select. So for example, for small molecular weight metabolites, we need to choose nucleic magnetic resonance method, where they are very sensitive for this type of low molecular weight metabolites. It's also very advantageous, very high reproducible in NMR. Suppose we want to look for something like lipid metabolites, then or organic acid, then gas chromatography coupled with mass spectrometry will be a good option. We're coming to the liquid chromatography with mass spectrometry. It is a very good instrument. It can detect wide range of molecular weight, whether it can also detect both polar or non-polar. Any metabolite can be detected using this technique. So using this instrumentation, we can extract the data acquisition. Mostly it is giving the data in terms of peak based on the mass by charge ratio. So once this metabolite based on this mass by charge is separated, it gives peak. Then software which will compare this peak intensity and peak height and width, all those things, with online softwares available mostly in public or also in the company who are producing. So this software will identify what metabolites it is, identify this acquired by these instruments. Then this metabolites identification is a statistical happening. Most of them what used in metabolic studies is this past least square discriminant analysis. This is a type of machine learning part again. This is actually very much used in the metabolomic studies. Then finally, after identification of all the metabolites, biological interpretation is required to build a pathway network, which are the metabolites are highly elevated and down-regulated. Then finally, candidate biomarkers will be identified. This is just brief metabolomics pipeline workflow. I'll just come from the recent study which is published in 2025 this year. So here they recruited Kawasaki disease group and healthy group, and they did that metabolic studies using LC-MS technique. So again, they did various statistical analysis, including PLSD discriminant analysis and ROC curve. and heat map to identify the metabolite, differentiate between KD and healthy control. So this is a chart where they shown what is the differentially metabolites which is between the case and control. Some of the metabolites are elevated in Kawasaki, whereas some metabolites are decreased in Kawasaki. So here they shown that some of metabolites of bile acid metabolism were elevated in Kawasaki disease, whereas metabolites of tryptophan metabolites like derivatives like indole 3-propanic acid, lot of metabolites from tryptophan metabolism decrease in Kawasaki disease. Also some of the metabolites from TCA cycles also decrease in Kawasaki disease. Some metabolites they plotted for AEC curve, which easily differentiate between the Kawasaki and healthy control. Unfortunately, this study they didn't include febrile control or any other disease control. This is another study published in 2024. Again, they found that several amino acids are altered between Kawasaki disease and healthy control. So here, primarily, they found that methionine is very much elevated and decrease in Kawasaki compared to healthy control. But after IVIG is given, this methionine is elevated. Previously, it is depleted in Kawasaki, it is increased. So what they find out why this, what is the function of methionine. So methionine is primarily, it is a methyl donor for several proteins and other metabolites. So then they look at it's some of the epigenetic function. So methionine is methyl donor for several DNA regions in the cells. So that's why they look on to the various DNA methyl transferase. So here they use DNMT1 activity, DNMT3A and DNMT3B activities. So here they found that this DNA methyl transferase 1, which is elevated in Kawasaki disease, whereas after IVIG given, this is decreased. So this study embarked that there will be increase in methionine activity, that will be a primary methyl donor for DNA methyl transferase. So this is a lipidomic studies which they look in and the predictor for IVIG resistance. So all the samples are collected in Kawasaki patient before IVIG resistance. Then they did lipidomics using mass spectrometry. So here they found that several metabolites of lysophosphatidylcholine, lysophosphatidylethanolamines are very low in IVIG resistant patient compared with IVIG sensitive and intermediate sensitive patients. Some metabolites are increased in IVIG resistance patient, that including phosphatidylethanolamine and phosphatidylcholine. So they also build with like ROC curve comparing with IVIG resistant and IVIG sensitive patients. So again, this is very small study. If you've seen, there will be very small sample set, like only 5 patients only in that IVIG resistant. So further studies are required to validate this finding. We also working on this aspect. Probably sometime later of this year, we will also got some results. This is another lipidomic study from Japan. This is a multi-centric study where there were 3 cohorts. Here they found that some of the oxidized polyamines are highly elevated in Kawasaki disease compared to febrile controls and healthy controls. So oxidized phosphatidylcholines and oxidized LDLs are bind to scavenger receptor called soluble lectin-like oxidized LDL receptor, which is always called LOX1. So in this study, they measure this LOX1 by ELISA. LOX1 is expressed in myeloid cells, that including neutrophil, monocyte, and macrophages. So in this study, they use that antibody against LOX1 ligand containing apolipoprotein domain of this LOX1. So here they found this lab levels, which is very much high during the acute phase of Kawasaki disease compared to control and disease control. Lab levels are decreases during convalescent phase and during the chronic phase. Maybe it's maybe a marker during acute phase of KD. So this another study from 2022. Here they measured the metabolites compared between patients with coronary artery lesions and without lesions in Kawasaki disease. So here they found that palmitic acid is increased and several other fatty acids are increased in patients with coronary artery lesions compared with non-coronary artery lesion. So here in this study, they further take this palmitic acid to the functional aspect. So here they found that they incubated this palmitic acid with human umbilical endothelial cell line, where the palmitic acid increased reactive oxygen species, thereby induced cellular senescence. Same thing observation, they found that they incubated cell line with serum from Kawasaki disease patient, found that the same there will be increase of reactive oxygen species and cellular senescence of endothelial cells. So this showed that palmitic acid might be, and along with other fatty acids, may contribute to coronary artery lesions in Kawasaki disease. So this is like I can say the important study. Maybe they include both proteomic aspect and also metabolomic in the same study. So what they did, they recruited Kawasaki disease patients before and after IVIG and also healthy control. So in the serum sample they did metabolomics and they separate the leukocytes. So they lysed the leukocyte and did the proteomic in the intracellular proteins by mass spectrometry. So then they identified the differential proteins and metabolites. So what they found is that before IVIG there will be a lot of proteins, particularly S-centered proteins, which is otherwise called as alarm proteins, where they have identified S-centered A8, A9, S-centered A12. All these are calgonal proteins which are increased. There are most of these are neutrophil and again macrophage monocytes source of this protein. They identified several metabolites that include mysteric acid, cortisone, hexadecanoic acid, spermamine also. Some proteins of like CD84 cells and NK cells like granulase, granzyme, these are important for cytotoxic T cells. Those are very low in the Kawasaki disease patient before IVIG. So once after giving IVIG, so all these neutrophilic proteins are become less, whereas cytotoxic proteins are increased. Same way it is in the metabolites also. So I will move on to the next part of proteomic studies. So proteomic can be studied using three different aspects here. One is mass spectrometry. This is the same O-link study used in a different paper, which is paper published in recently in, this is from China. So again they validated this interleukin 17's increase in Kawasaki disease patient. They found that AEC of 0.87 and also sensitivity goes to 97% and the specificity of 76%. This is another paper published, this is also from China. It is also they shown that here they measure this proteomics by mass spectrometry. So similar observation, interleukin 17 signaling pathways enriched in Kawasaki compared with healthy control. Again, the other TNF signaling also increases. When compared with Kawasaki disease pre and post IVIG, complement coagulation cascade proteins are increased in pre-IVIG KD patients and also net formations. Some proteins like Fc gamma or mediator phagocytis are depleted in low, but after post IVIG they are increased. This is a recent study from 2023 from GIAN Burns group from USA. So here they based on the phenotype of patient, they divide that KD patient in 4 groups. First one is the liver predominant group, and second one is high band neutrophil group. Third is cervical lymphadenopathy group, and fourth one young patient. So in that 4 group, they did the proteomic study using this SOMA scan, which is a targeted proteomic analysis. They found that amino cyclase assay, which is very much increased in the liver predominant group compared to other phenotypes. There is another protein which is interleukin 18 receptor alpha, which is again also increased in the liver involvement KD group compared to other phenotypes. This is a protein which is a soluble immunoglobulin interleukin 1 receptor. Actually, this is an antagonist to other interleukin 1 receptor pathways, that including interleukin 18 receptor alpha. So if you see that actually this is negative correlated with interleukin 18. This SIGAR is negative correlated with interleukin 18, whereas for the patient is very high here. It's nicely which is decreasing in from liver involvement to young patient and then controls. But this is again, it increases from liver to young patients. So this shows that in young patients there will be something is different compared to liver phenotype. Coming to the high band group, high band neutrophil group, they found this soluble urokinase plasminogen activated receptor increase. It is not observed, it is very less in the other groups like node group and young groups. So in this way the phenotype will tell like what are the biomarkers will, at least biomarkers will differentiate between this group. So I'll summarize here. So several metabolites including acetylcarnitines, hexonyl carnitine are increased in the Kawasaki disease. In the recent papers including methionine and S-adenosyl methionine, spermamine all increase in Kawasaki patients. The problem is here in the previous studies there is no febrile controls are increased. Some of these metabolites increase in the febrile control including sepsis. So maybe this may be a non-specific or need to be required further study to validate. One important aspect is the S-adenosyl methionine, which is an important methyl donor for other DNA and other metabolite. So S-adenosyl methionine, if it is studied, maybe homocysteine also to be studied along with, because both are involved in cardiovascular disease. The recent finding including oxidized phosphatidylcholines also need to be validated in further studies. So proteomic studies identified several alarm proteins including calprotectin and ascended A12 acute phase protein, alpha defensine, that differentiate between the febrile control and Kawasaki disease. So ascended maybe it's important during convalescent phase also because it involves calcification of vessels. Interleukin 17 ACB are shown that it involved the coronary artery aneurysms and the coronary artery lesions. So I will stop here. Thank you.
Thank you, Dr. Jayapal, for your talk. Since in the interest of time, we have maybe one question or one question. Then we'll close the session. Thank you very much.
Thank you, sir.
Okay.
Thank you, sir. We shall now break for tea, and we request everyone to gather back in 10 minutes due to the time crunch. Welcome back after the tea break. For the next session, it would be chaired by Dr. Puneet Olak Puni. She's the professor and head of pediatrics at the DAY2 Medical College and Hospital, Ludhiana. She's the director of PICO Fellowship Program. She has more than 30 years of teaching experience and she has more than 100 publications in the national and international journals.
Very good morning. Good morning. Being a teacher, I have to make you such an interesting interactions. It's my profound privilege to be part of the faculty, especially as a chairperson. And thanks to Dr. Sujit Singh and Dr. Rakesh and his team. So next is very, very important topic because it's not so near, but eyes will see what the mind knows. So we all need to be aware of this entity. And the systematic review and the meta-analysis will be done by Dr. Pratap.
Yes, ma'am.
He's MBBS MD DN Pediatric Clinical Immunology and Rheumatology from PGI Chandigarh. Presently, he is additional professor of pediatrics in charge Division of Pediatric Immunology and Rheumatology. And he's in AIMS, Patna, and publications are more than 70 in national and international journals. Over to Dr. Pratap.
Thank you, ma'am, for the introductions. I sincerely thank Dr. Rakesh and Professor Sujit Singh, sir, for giving this opportunity to speak on systematic review and meta-analysis. Although systematic review and meta-analysis are considered as secondary research, their contribution to science is immense. So to start with, I will share the story of Dr. Linus Pauling. And Dr. Linus Pauling was a famous biochemist, and he was awarded Nobel Prize twice, and he had a lot of fascinations with the vitamin C molecule. And he published a paper with a conclusion that daily or regular intake of vitamin C can prevent common cold. But these publications later on met with a lot of criticism from the scientific communities. So Dr. Linus Pauling, where he went wrong while published this review or published this work. So Dr. Linus Pauling probably unknowingly excluded the studies that had negative outcome, and he selectively included the study that showed the positive outcome. So this was a perfect example of selections bias that led to wrong conclusions. So today I'll discuss briefly about the systematic review, what is the level of evidence, what is the steps that is done in the systematic review, how data is analyzed in systematic review, and what is publications bias, and what are the limitations of the systematic review. So the systematic review and meta-analysis is a structured way of come and synthesize the research evidence in a comprehensive way. And this was first popularized by a biostatistician named Carl Pearson. He was from the UK. So in contrast to the traditional narrative review, systematic review collects the all possible studies related to a topic and review and analyze the results. And during the systematic review process, the quality of each study is analyzed, and finally the data from different studies are pooled, and that is called meta-analysis part. So systematic review may not always have the meta-analysis part, and if you look at the evidence, in the era of evidence medicine, the systematic review are at the top. So one should be familiar with the different terminology, systematic review and meta-analysis. And systematic review is the review part, and the meta-analysis is the statistical part. All systematic review may not have a meta-analysis part. And like to your original research, the systematic review and meta-analysis also has objective, which is either primary and secondary objectives. And the interesting fact about systematic and review meta-analysis are that they are reproducibles. And meta-analysis is the way that we pull the results from the different studies to get a report. So why meta-analysis should be done and what are the advantages of carrying out meta-analysis? So in the meta-analysis, what we do, we take the data from different studies, and when we are taking the data from multiple studies, so by that we are increasing the power of the studies. When your sample size to detect any particular effect is increased, then if there is an effect, if there is a difference, then you are going to detect that effect. Meta-analysis also help us to understand the size of the effect. So whether the effect size is big or it is small, and what is the evidence for that and the certainty around this evidence. Meta-analysis also help us to settle the controversy that arises from the completing evidence from multiple studies. So what are the steps of systematic review? So the first step for carrying out systematic review is to formulate research questions. Then you have to write the protocols. Once you write the protocol, it has to be registered in a particular database. Then you have to define the inclusion and exclusion criteria, do a literature search and select the studies, then assess the quality of evidence of each study. Then finally extract data, analyze the data and present your results. So while writing a review title, one should focus on these PICO. So what is PICO? PICO is populations, intervention, comparison and outcome parameter. And you should follow this while writing a review title. So systematic reviews are very, very important. Their contribution is immense. Especially when you are planning to take any decisions in this major health problems or the situation which is controversial or conflicting, where the studies say outcomes are very difficult to conclude whether the effect of all these studies are suggesting only one directions or in opposite directions. So once you write the protocol, the next step of systematic review and meta-analysis is that you need to register this protocol in a website, and a priori one should define the primary and secondary outcomes. So most of the most common site where you can register your protocol is the Prospero. So once you register your review in the Prospero will give a registrations number, and this number has to be mentioned while you send your review for the publications. So what next step is of systematic review and meta-analysis is the literature search. And before doing that, you should have inclusion and exclusion criteria. You should have clear idea what type of studies that are to be included in the systematic review and meta-analysis. Apart from that, what type of studies, you should also define what language the studies should be searched, and you should mention about the time period during what type of studies and how many studies during a defined time period that should be included. So what are the databases or the common databases where you can search these studies for retrieval of the different studies? So these are the 4 common databases: PubMed, Embase, Scopus and Web of Science. You also can search in Google Scholar to retrieve these studies. And always perform a broad search using Boolean operators like AND or OR, and use appropriate keywords. And it is always better idea to look at the Cochrane review database, and this is the most common and one of the largest database that you can get the systematic reviews. And it is very important to identify the published as well as the unpublished and ongoing studies while you do the literature search. And once you collect the studies from the different databases, the next step is the remove the duplicates, or this is called deduplications. So once you select the studies, you need to screen all the studies that you collect. Okay? Then this screening should be based on the abstracts. So once you you screen the abstract, you will include some studies for your systematic review and you will exclude some studies. And the final selections if you plan which the studies that are to be included, that studies detailed full text has to be retrieved. And it is very important to also maintain a log that all the excluded study with reasons. And this process is not a one-man job, and two independent investigators must carry out this process. And why this is carried out? Because it is essential for the reproducibility of the literature selections. So for the data extractions, one can use Excel chart or you can create a table, and it is carried out by two independent investigators. And so in systematic review, it is not always possible to combine the data. When the data is very much heterogeneous, then you can only write the review, that it will be a systematic review, but without meta-analysis. So various various artificial intelligence tools or websites that are available that can help you to for the data extractions, and these are the two most common used tool, and that is a web-based tool that you can use. The first one is GIAN and second is Pico Portal. So once you collect all the studies, the next step is to assess the risk of bias. So in this example, what you can see, the risk of bias has been carried out for 6 studies, and these studies have looked at the association of the coronavirus with the Kawasaki disease. So this is the risk of bias tool, and this is Newcastle-Ottawa scale, and this scale is mainly utilized for observational studies. So this was a case control studies, and the risk of bias assessment has been carried out, and in this domain, selections, comparativity, exposure, in this domain, there you have to score, and if the maximum possible score is 9. If any study score less than 5, then there is a possible risk of bias. Where score more than 7, then studies are of good quality with low risk of bias. So the risk of bias assessment for randomized control trial is different, and Cochrane collaboration tool is most commonly used for the risk of bias assessment on these following headings. So you have to assess these studies on sequence generations, allocation concealment, blinding, incomplete outcome of the data, selective reporting, and other biases. So this is also called a traffic light plot, and each study has been evaluated on these domains. And when you finally plot this, and you will have the summary of regarding the risk of bias of the included studies. So where you can see here in this figure, the studies that have been included, the overall risk of bias is there. Some concern is definitely there. So finally, once you extracted that data and you carried out the bias assessment, the next step is data analysis. And to combine these variables, the data can be either dichotomous variables, or data can be continuous one, or data can be survival or time to event data. So for dichotomous variables, the outcomes will be mentioned in odds ratio, risk ratio, or risk difference. For continuous variable, the data will be presented in mean difference and standardized mean difference. And survival or time to event data will be represented as hazard ratio. So this is, once you carried out the analysis, different softwares are available. RevMan is the most commonly used software for doing this data analysis. And this is a typical forest plot you can see here. And this is also called blobogram. Okay? So this is a case control studies. And you can see here, looking at the association of the coronavirus with the Kawasaki disease. So this is each study's confidence interval. In the center, you can see here, this is the blob, and blob size depends upon the sample size of the study. So larger the sample size, the blob will be, the size of the blob will be more. And this is the, when you pull the data, this is the final estimate that is represented as diamonds. So in this studies, it is favoring the occurrence of Kawasaki disease and with the coronavirus. So Before doing the data analysis, two type of model that are used for creating this forest plot. One is fixed effect model and another is your random effect model. So fixed effect model is used when the data are homogeneous, the studies are similar, where random effect model is used when the studies are different from each other. It is very important to wisely choose your statistical model, because you can see here two type of model has been used for the same data. In upper figure you can see fixed effect estimate or fixed model has been used. In lower your random model has been used, and you can see here in the upper graph. So you can see the intervention is favoring the experimental group when fixed effect model has been used, whereas in the lower graph there is no difference, because this is the two line. This is the horizontal line and this is the vertical line. So you can see here the diamond is touching the line of no effect. So it is very important to decide a priori which type of model are to be used in the data analysis, in the systematic review and meta-analysis. After that, once you carried out the meta-analysis, look at the forest plot, and there can be heterogeneities. So you can see here, how can you decide the forest plot, looking at the forest plot, whether heterogeneity is present or not. So look at the confidence interval. If the confidence interval of each studies are overlapping very much, then probably there is no heterogeneity. In this forest plot, you can see here, some studies confidence intervals lies here, some confidence intervals lies here. So this is a very much heterogeneous data. So you can look at the Cochrane Q test also, and this is the p-value that suggests there is lot of heterogeneity. Less than p.0.5 is considered to be, there is presence of heterogeneity, and it is very, very significant. And look at the I-square statistics. This will tell about the heterogeneities. So here I-square is 88%, there is lot of heterogeneity. Then once you carried out the analysis, there may be possibility of publications bias, and when there is a publication bias is present, it can distortion the outcome of the meta-analysis. And this is the most common type of bias that is used in meta-analysis. So how can you detect the publications bias that is present in a study or not? One can use advanced statistical state like Begg and Majumdar rank correlation test, and this is the funnel plot that one can draw by using your RevMan software. So this is the funnel plot. This is representing the each studies, and you can see here in the first figure the publication bias is absent because all these studies are within the funnel here. But in the second figure, you can see all the studies are not within the funnel, suggesting that there are publications bias. So after doing all this analysis, the next step is reporting of your studies, and that one guideline that has been provided is a quorum. So you have to adhere to this guideline, and these are the tab figure that has been provided by the Prisma, and according to this, you have to report your data in the meta-analysis. So what are the limitations of systematic review and meta-analysis? The systematic review meta-analysis, the quality of the review depends upon the what has been published in published literature, and if there is garbage in, then there will be possibility of garbage out. So data are also quite quickly outdated. So in these situations, you need to carry out updated review. So if a review has been published within last 2 years, it is not prudent to carry out a review on the same topic. So if studies has come up within the last 2 years, then one can do. And at times, the limitation of systematic review and meta-analysis that there may not be enough data or research to analyze. So in summary, systematic review and meta-analysis has the highest level of evidence in the era of evidence-based medicines, and it is help us to make the research literature easily accessible with increased accuracy. Good research questions and literature search are the key initial steps quality of studies included review have impact on the quality of review, and meta-analysis may not be possible in all systematic review, and because there can be heterogeneous data. So thank you for your attention.
Excellent presentation. I think this is must know for all the post-graduate students, all the researchers and all the doctors, especially in teaching hospitals. So did you do any systematic review and meta-analysis on treatment options or outcome related to KD or anything else related to KD?
Yes, ma'am. I have two meta-analysis. One is on exposure of coronavirus and association with Kawasaki disease. And second meta-analysis is long-term cardiovascular effect of Kawasaki disease that is published in Cardiology India.
You very rightly pointed out, ego we say is garbage in, garbage out, but gold in, gold out. So what you are putting into the AI is what you will get. Any questions from the audience? It was very clear. Thank you.
Thank you, ma'am. Thank you.
Next laser.
Our next speaker is Dr. Vijaya K. Pathi. Is it all right?
Yes, ma'am.
Because even my name is never pronounced right. I'm Puni PWNL, but PUNI is fine. That's okay. So he is Associate Professor at Pgimer, Chandigarh, postgraduate in Public Health, University of Nebraska Medical Center, USA, postdoctoral fellow, Jawaharlal Nehru University, PhD in Environmental Health. That's very good. And he's got 15 years of experience in academic research and treatment. Interest areas are social and environmental determinants of health, guideline development, climate change, and he's got lots and lots of awards and recognition, including from UNESCO, Young Investigator Award of Asia, Environmental Research, Junior Scientist of the Year, National Environment, World Association of Medical Editors. So big applause for you.
Thank you, ma'am.
Over to you, Doctor.
Thank you, ma'am. So I have allotted 15 minutes. I will try to finish my talk within that period. So this is the overall summary what Dr. Pratap explained very nicely. These are the different steps of systematic review meta-analysis, and I will explain with one of our ongoing systematic review meta-analysis on Kawasaki disease. So before that, those students present here, I will try to spend 2 minutes to provide some kicks why you should learn this technique and what benefit you will get. I will give my example. There are three stakeholders in this field in the area of research. One is the researcher ourselves. Second one is the journal. There is a big industry, publishing industry. They are more profitable than TCS, Infosys, Wipro, any other industry nowadays. The third one is the policymaker like Ministry, UNICEF, WHO. So all these three stakeholders are getting benefited from this systematic review and meta-analysis, and how. So I started my first publication in 2005. Okay, from 2005 to 2019, I used to get only 10, 15, 20 citations per year. Okay, so after 2019, when I started publish my first systematic review meta-analysis, and from 2019 onwards, so my H index, my citation, every year I am getting more than 500 citations. So look at last 10, 15 years and last 5 years. So this is the benefit, personal benefit that you will get as a researcher, as an academician, if you publish few systematic review in a year. Okay. The second one is, you can also publish reputable journals. Like me, I am a public health professional, so I cannot dream to publish Lancet Oncology, Lancet Microbiology, because I do not have that type of infrastructure resources. But I am publishing in those high quality journals. Okay, because for doing a systematic review meta-analysis, you do not need any infrastructure, not any resources. You need an internet connection, laptop, and 2 dedicated human resources. This is the benefit as a researcher I am getting. The second one, the journals. Every journal is strive to sustain their impact factor. Okay, so this is a very good area. The systematic review meta-analysis, if they publish, they at least get that number of citation. For example, if a journal having 5 impact factor, it means if the editor is published that one article in that journal, so in that year, that article should attract at least 5 citations. If it is not attracted 5 citations, it means it is a liability to that journal. So the journals will get the citations to maintain their impact factor. Third one, they can show the authority, and it can also resources for the other professionals like the policymakers. For example, if WHO wanted to make some policy, if there is an individual study is available and there is a systematic review meta-analysis available, obviously they will look at the systematic review and meta-analysis. So these are the benefits for both the researcher as well as for the journals. And fortunately, the ICMR, earlier there was a guideline in 2017 that all systematic review meta-analysis should go for the ethical committee review. But we thank to our current Director General, the day he joined, and he said in a meeting that I will ensure that I will remove this clause from these ICMR guidelines, and in January 2024, he removed that guidelines and provided an addendum. So this is a boost for the Indian researchers, Indian students who are taking a ICI ethical review, which takes minimum 6 months in our nowadays in our institutional ethics committee. So these are some benefits for the researcher, but still people are not able to publish systematic review meta-analysis. The reason behind is, it is your research question. If you are a novice researcher, first time you are conducting a systematic review meta-analysis, your research question should be very focused. If you ask such type of research question, then I don't think that you will be able to complete the systematic review within a year or two. Okay, so do not overburden yourself while you are trying to conduct a systematic review or meta-analysis. Try to ask a very specific research question as per the PICO. So this is a well established. Always focus your outcome. What outcome you are going to measure in your systematic review and meta-analysis? Because based on your outcome measure, all the statistical tests, whether you want to do a fixed effect, random effect, what type of analysis you are going to do, it will be done. So with this background, we are now conducting a systematic review and meta-analysis with guidance of Professor Singh sir. So this is our, we registered with the Prospero, and we are looking the CA among the KD cases. So this is our Prisma, as explained Dr. Pratap. I am not going to detail steps. So these are the three databases we looked. One is PubMed, MBase, and Web of Science, because these are the three leaders in the field. In the PubMed, since it is a medical field, we anticipate that all the articles indexed in PubMed, and MBase is the part of Elsevier, and Web of Science is a part of the Wiley. Okay, so these agency provide the impact factor, this agency provide the site score, and this is the free database. So 3 database is the minimum requirement, and at end of the day we landed in the 23 articles. We examined all the 23 articles and extracted our data, and this is the pooled prevalence of the CA among the KD cases. So if you look at, so these are the some statistics. Dr. Pratap already explained what this box means. It is basically the weightage given to the sample size of the study, and this is the lower limit of the confidence interval, and this is the upper limit of the confidence interval. So and this diamond represent the pooled estimate. Okay, look at the pooled prevalence, which ranges from the point estimate is 15%. It means among all these studies, some studies, whatever they reported, like this study reported 4%, this study reported 25%, 24%, 19%. So our pooled estimate is 15%, which ranges from 9% to 23%, which this diamond shows that data. However, there is another statistics recently used. You will never find these statistics before 2024. So this is called the prediction interval. What does this statistics means? If similar another study will conduct in future, what is the likelihood it will fall? It means that this prediction interval shows that it can range from 1% to 41%. So if a similar type of study based on this data, so they did some prediction analysis and they provide the statistics which ranges, if a similar study in future will publish, it can be range from 1% to 41%. So this is our data, and there are some other statistics like I-square is the, since this is all observational studies, so there is a high heterogeneity. Okay, 99% is the high heterogeneity, because it is the inherent heterogeneity, it is not RCT studies, all observational studies have the heterogeneity, we need to deal with the heterogeneity. Then the second one is chi-square within the study variance, we do not need to go details. And the second also we look at the prevalence of dilation among the KD cases. The same, it is 9% we found in our study. These only 4 study reported this outcome. Then we also look at the giant CA among the KD cases. There are 5 studies reported and which ranges from, it's very less. Look at the diamond, it is not appropriate shape, it's very less number. This is the again pooled prevalence of medium CA among the KD cases. Only 3 study reported and the diamond is not so solid. Then the prevalence of small CA among the KD cases. Only 2 study reported this data. Then we look for the publication bias. There are usually people use the funnel plot. So if you look at this funnel plot, this will not provide any conclusion. Okay. So ideally, we should not go for a funnel plot if we are doing a meta-analysis based on the proportion data. And if the number of studies is less than 10, so here the total number of studies is 8. So we comment many studies published in Lancet, JAMA, the editor acknowledge our letter and they publish, because in proportion data one should not use the funnel plot. So instead of funnel plot, now the new statistics they call the DY plot. In the DY plot, look at, it provide a quantitative estimate. Okay, like looking at this, it is the LFAK index is 11.9 and it says that if the LFAK index is between greater than 1 or less than -1, the range should be -1 to +1, then there is no publication bias. So if you look, by looking this, you will say, since this is a proportion study and there is high publication bias in our meta-analysis. So this is new statistics, it is nowadays used for the publication bias. We have not done the risk of bias assessment. Also, while I am attending the session, one participant asked whether the proportion is higher among male or female. So we have to do a subgroup analysis to see all these published data, whether this is also true in case of the CA cases is among the male higher or not. So with this, I acknowledge the guidance from Professor Surjit Singh, Dr. Shankar Pinja, Dr. Rakesh Pilani and the review team. So thank you very much. If you want to learn this technique, we have a journal. The name is The Evidence. Here all the step-by-step guidelines, how to use doing this meta-analysis. We published 2-3 articles, methodology articles. You can scan this QR code and join this journals group. And I will invite if you have any question because we have less time. So I'll be happy to answer your questions.
No further questions. I'll just go on for the next.
Thank you.
Thank you so much.
To chair the next session, we invite Professor Surjit Singh. He is a professor and head of the Department of Pediatrics, the unit head of Pediatric Allergy and Immunology unit. He is the founder president of Indian Society of Kawasaki Disease. He is the man and the motor behind everything we learnt about KD, from early diagnosis to treatment, and he has pushed every research in KD done in our unit.
Good morning. So we now have Dr. Pal. So he would be talking on epidemiology of KD worldwide.
Good morning. So over the next 10 minutes, we'll just have a brief overview of the epidemiology of KD. So KD has been documented in more than 60 countries and across all ethnicities. And mind it, the disease is only about 58 years old. So if you look at the global incidence of Kawasaki disease per 1 lakh children, less than 5 years, of course, Japan is the topmost, but this is a little old data, and followed by South Korea, Taiwan, Hong Kong is not far behind, Singapore, and there's China, and then there's almost a plateau in the USA, Canada countries, and then we are going down, and India features somewhere down the line, but I think Rakesh will be speaking something exciting about the Indian epidemiology. So one of the drawbacks of doing an epidemiological study and finding the exact incidence is the diagnosis, because that is a limitation, because we all know that KD is a clinical diagnosis. With the presence of a proportion of incomplete or atypical KD cases that have no standard criteria for their diagnosis, which is more of an expert opinion. So that remains the confounding factor, that we may not be diagnosing the exact number of KD that we are supposed to diagnose. So that is one of the limitations. Now let us have a look at the epidemiology where it all started. So in the word of Professor Burns, the most significant controversy in 1960s in Japan was whether the rash and fever symptom complex described by Dr. Kawasaki was connected to subsequent cardiac complications in a number of cases. Pathologist Dr. Tanaka and pediatrician Dr. Yamamoto disputed the early assertion of Kawasaki that KD was a self-limited illness with no sequelae, and this controversy was resolved completely in 1970 when the first Japanese nationwide survey documented 10 autopsy cases of sudden cardiac death after KD. And this is, we learn about this epidemiology mainly through the National Epidemiological Service of Japan. So this started somewhere in 1970. So there's a beautiful booklet, summary of the 1st to the 27th Nationwide Epidemiological Survey of Kawasaki disease. March 2024 it came out. And in the words of Dr. Kawasaki, let us see how it's all started. So 6 years after the submission of the original article to Allergy in 1967 were the most concentrated periods of my life on a single purpose, both physically and mentally. There was a controversy about whether this disease was Stevens-Johnson or not, and the uniqueness of KD was temporarily denied. But then a series of case reports followed. Dr. Kosaki ordered me to apply for a research grant from the Ministry of Health and Family Welfare. It failed in 1969, reapplied in 1970. And then I caught the attention of Dr. Kakurai, the scientific counselor in the Minister's Secretary of Ministry of Health and Family Welfare. So he advised me to consult Dr. Shigematsu, who was the director of the Department of Epidemiology at the National Institute of Public Health. And this resulted in a fateful meeting in 1970 between Dr. Kawasaki, the clinician, and the epidemiologist, Dr. Shigematsu. So Dr. Shigematsu said, it's interesting and let's start. So a research group on infantile mucocutaneous lymph node syndrome funded by the Ministry of Health and Family Welfare was started in 1970. And the first diagnostic guideline of Kawasaki disease was created, and it was done through a collaboration between a clinician and an epidemiologist. So let us look at the global scenario. So the incidence is lowest in the Scandinavian countries, and if you look at the other group, North America, they have around 70 to 21, maybe around 25, less than 1 lakh children, less than 5 years. So again, a significant number of patients, these ethnic variations with a markedly high rate among the American Asians supporting the genetic background of KD. So European country, it's less than 16 per 1 lakh. Again, the ethnic variations come up with higher incidence in the children of Eastern Asian descent. In Australia, the incidence is between 8 to 10 per 1 lakh, and it's not determined whether the incidence has plateaued or is still increasing. But the most interesting is the Far East. They have more than 50 per 1 lakh children, and the number continues to increase. The highest rate, Japan, 264, and possibly it's around 400 now. And mortality was less than 0.02%, and resistant to IVIG was 17%. South Korea is the second, as we saw from the first graph, reported the second highest incidence, about 135, and Taiwan around 83 per 1 lakh children less than 5 years. But interestingly, if you see that the reported coronary complications in Taiwan is around 5.4% of cases. The China, it's again varying in intensity because incidence, because of reporting from different parts of China. So it varies between 7 to 55. So Beijing, I think, has the highest incidence of this. Middle East and Sub-Saharan Africa. So there are very few studies except from Turkey and Iran, and limited data have been from the Middle East countries. So we have very limited data from there. So India, so this was a write-up by Professor Singh himself. So Kawasaki disease, issues in diagnosis and treatments. This was in 2016, where he has written that after 1990, KD has been reported in almost all regions of the country with incidence data of 4.5 cases per 1 lakh children less than 15 years. So this was in 2016, and I will let's have a look at this data from Dr. Rakesh, who will be speaking next. So where you can see that Chandigarh itself has incidence of 10.6 in 2019, and I think it's again increasing. So if I look at this data, that category 1, the red, Japan, Korea, and Taiwan, the incidence rates of 80 to 350. So we saw that Taiwan has the least, and Japan has the most, and they continue to rise. Then there's a plateau region of Europe, North America, Australia, and New Zealand. It's around 15 to 30. And India and China, nationwide data is not available, but again, in China, city-specific incidence that Beijing has the highest. And Chandigarh, I think Rakesh will be telling in the next slide. So this was happening till 2019, and in 2020-21, we had the times they were changing. So another confounding factor came in, that we had the ongoing enigma that was Kawasaki disease, and now it became tangled with the appearance of something which was known as MISC. So we know that the origin was in April 2020 when NHS first gave the first alarm of the multisystem inflammatory syndrome, which was, they were not very certain, possibly linked to SARS-CoV-2, they said. And then over the next couple of months, we had case reports from different parts of Europe and America stating that we are encountering something which is MISC or PIMS, and which had some similarities with Kawasaki disease. So this was the first Indian publication, May 2020, hyperinflammatory syndrome in a child with COVID-19, which was successfully treated with IVIG and tocilizumab. So this was from the south. We had a lot of papers on this, and in fact, you can see that we had a publication which compared, this is from our center, we compared the first and the second waves. So there was a lot of patients who had actually KD-like symptoms, especially in the second wave. And now we know that MISC and KD definitely were two completely different entities, although they had some clinical overlap. So what happened in Japan? Because in the initial days, there was a lot of controversy how we are going to treat MISC. I sent a mail to Professor Sudha asking how you are treating, and she mailed me back that we do not have any MISC in Japan. So that was very surprising for me. A country which tops in KD, they do not have any MISC. But subsequently, I think they had some MISC. This was a 2024 publication, nationwide survey of MISC in Japan. So overall incidence, you can see it was 1.5. And 80% of cases occurred possibly during the Omicron variant, when possibly that guards were little laid down, so it was not very well, and 72% of the children with MISC met the CRADI criteria, and MISC cases showed comparatively less severe clinical features. So overall, the incidence was low, and the clinical features distinctively exhibited a more KD-like phenotype. So this was from Japan. We know that seasonality. Of course, KD definitely is a very, very seasonal thing from most global publications. And Japan and South Korea had reported distinctive seasonal patterns, peak in July and a winter peak in January. US and Canada, Europe, and the temperate regions of Australia, they also reported seasonal peaks, which has, especially in winter, occurring in the winter season. In our part of Eastern India, we see two seasonal peaks, one in spring and the other is in autumn. We are now having KD, almost a lot of KD. So this is a slide, I think, which has come up yesterday also, factors implicated in pathogenesis. So genetic polymorphisms, we have already gone through that. So let us see again the Japanese, what they have to say. The proportion of cases with a positive family history is around 1%. So within 1 year after the onset of the first case in a family, the rate in a sibling is 2.1%, a relative risk of 10-fold compared with the Japanese population in general, and approximately half of the second cases develop within 10 days of the first case. And risk of concordance in identical twins is 13%. So this again, possibly there's a genetic predisposition. And rates of recurrence in Japan is around 3%. And what they have said that the reported high risk of developing coronary artery sequelae with the recurrent episode, regardless of the sequelae developed with the index episode. And the case fatality in Japan is around 0.015%, and peak mortality is after 15 to 45 days. And a recent study showed that the standardized mortality rate beyond the acute illness was elevated for all patients with cardiac sequelae, thus stressing the importance of long-term surveillance. And this is my final slide. You can, again, from the nationwide epidemiological survey. So what we see, the annual trends in the frequency of cardiac impairment from 1997-98, which was around 20.1 at first visit, it has come down to 8.1 in 21-22. But what we see in our patients, a cardiac involvement in about 35 to 40% of the patients at diagnosis, and I think Rakesh also said something around in the tune of 40% yesterday. So that is, I think, a very interesting thing that not only we are seeing numbers increasing, but we are seeing a more severe form of KD over the last couple of years. Thank you.
Thank you, Priyanka. So the essential messages from Dr. Priyanka's talk are that there are 5 countries in the world that have an incidence above 50 per 100,000 children below 5. So China, South Korea, Japan, South Korea and Taiwan, Hong Kong and Singapore. So these 5 countries have incidence figures above 50. All others have incidence figures much below 50. The other important message that we get from Dr. Priyankar's talk is that in Japan the incidence of serious cardiac sequelae has come down significantly. While in our country, we still have a lot of sequelae following Kawasaki disease. So, especially if you take the incidence of medium-sized to large-sized aneurysms. So this is still a major problem for our country, while Japan and other developed countries have been able to, although their incidence rates may be high, but they've been able to control that aspect of management. So this is where we need to catch up with the rest of the world. So if there are any questions on Dr. Priyanka's talk.
Is the high incidence of cardiac disease maybe because the patients are diagnosed late? In India, we are still not able to diagnose at earlier times. Because we get referred to DMCH, where the patients are there admitted in various nursing homes, going from one hospital to another, initially starting with ceftriaxone, then meropenem, then vancomycin, then cholesterol, and after 2 weeks, fever is going up, CRP is rising, TLC is high, patient is very irritable and they refer to DMC. First thing we do is do the echo and it shows actually aneurysm. So maybe we are missing in the periphery and early IVIG is not given, that's why we are getting more coronary. So if we are more able to sensitize the pediatricians with the conferences like that, maybe our coronary, the cardiac incidence will increase.
Definitely, that must be one of the reasons. So KD awareness and belief in KD that still are lacking in majority of the population. But that may not again be because we have seen patients also with diagnosed day 5, day 6, day 7 with big aneurysms. So that has also been observed.
So how long does it take, after fever, how long does it normally take for the cardiac system to be normal?
Usually, if you go by the literature, around 10 days, in fact, Dr. Sudha also showed some slides yesterday that the aneurysm starts forming around 10 days.
No, the dilatation.
Dilatation can be before that.
Usually first 7 days there are no changes. First 7 days there may be no coronary changes. So it is incorrect to say that this is not KD because coronaries are normal. And that is a mistake which occurs time and time again. Dr. Saji, what has been the experience in Kerala? Kerala is one state where KD is diagnosed very early. And I think we need to learn from the experience of Kerala because there, even small hospitals, even in the government setup, small district hospitals, they are all primed up for KD. So, what has been your experience over the last 30 years as far as the incidence of coronary complications is concerned?
Yeah, the recent the incidents are not much higher, especially the coronary involvement. And even the myocardial infarction also, we are not seeing at all in the because they are taking care of with anticoagulant, antiplatelet and all regularly. And all the pediatricians in the village setup itself, they are well aware and the awareness towards any rashes, they think about KD and they will call us, and so the awareness has increased in Kerala. So that early treatment may be the another reason. The coronary means the aneurysm changes or giant aneurysm cases are much less actually. That's why yesterday I couldn't give the answer to the surgical point of view because nowadays we are not sent any case for a bypass so far.
I remember Dr. Cassidy Dr. Cassidy when he had come here in 2001. So he said that previously he used to say that when you suspect KD, you treat KD. He said now we teach our fellows, when you think of KD, you treat KD. So the dilemma whether this is KD or not, that dilemma can continue at the bedside. But once the possibility of KD arises and you think there is some reasonable chance that this can be KD, one should immediately treat, even though the final diagnosis may not be KD. But you can't take the risk. So if you delay the treatment over 4 or 5 days, that is all it takes to damage the corneas, and that damage can be irreversible. Sir.
Australia, there is no price. Look at the population stratification there. And South Korea, Taiwan, Singapore, and Hong Kong, there is price. And the migration of people, every 4 person in Australia is migrated. And migration takes place from that area. But they are not increasing. There is no increase in the percentage of cases in hospital. When the next student I am asking, is there any relation, is the doctor getting harmed or in protocol that this is if you look at the population stratification of the Australians, every 4th person is migrated
from the Eastern Asia.
From this part of it, and this part of the globe. But their experience is not going up.
I think what he said, if I read the slides correctly, what he said was they don't know.
There was
Their last study
There
was
is no change in the percentage.
But their last study was several years ago. They don't know. In Japan, Korea and Taiwan, they have, I think these are the only 3 countries where they have updated data, especially Japan.
That may be a point. I don't know, that is my question.
Because US, Japan, they update their data very regularly and we have very reliable data. In other countries, they may not have updated.
Very good state. Those states are very good. Expected there, I'm not sure whether they are updating their data or not. But their population stratification is like.
Dr. Amitabh?
Sir, you are absolutely right, sir, that the treatment should be started as soon as possible. One of the main hindrances, which is very practical, suppose one of the main ingredients is IVIG. So as soon as diagnosed, we give IVIG, and sooner the better, so that it at least prevents the formation of the coronary artery aneurysms. One of the main things is the cost. In the government sector, it is free. And in our state also, in the government sector, it is absolutely free, but it is very difficult to get a seat in the government sector for that particular period, for that particular time. If so, then the patient or the child and the family has to take help of some either semi-private or private ones. But the cost is still out of bounds for most of the people, if not the majority, but most of the people, they still find it slightly difficult to pay for that one. Nowadays, the cost has come down quite significantly, but in some sectors, the cost is still prohibitive. So that is one of the reasons that people think twice or maybe thrice before subjecting the patient to that one. That is one of the main reasons, I think. But apart from that, as you said, the awareness and the mentality of the pediatricians to act very quickly have gone up significantly over the past 10 years. And they act very, very quickly, if not within the first 2 or 3 days. Even if the echo is not available or the echo is negative, on the clinical grounds as well, I think they want to give the medications as soon as possible. I think you are also noticing several sectors across our state, the mentality here and the perspective has changed quite a bit as of now.
Dr. Devadan.
That the pediatricians are now quite well aware, and they are doing the echoes, asking for the echoes, and then they are treating the kids. But once the echo, which is 7 days, I find them asking for echoes at 3, 4, 5 days also. But once the echoes are normal, we need to stress on the fact that they might, if they are suspecting KD, they will need a repeat echo. Even if they the echoes are done around 6-7 days or so. So I think that needs to be more emphasized.
I would emphasize the fact that for diagnosis of KD, we do not need an echo. Echo can give you some subtle features in the first 7 days, like brightness of coronaries, like loss of tapering of coronaries. That is all that echo will, but to get a pediatric cardiologist to do the echo, in most parts of our country, can take you several days. And that report may or may not be reliable, because the concerned cardiologist may not have enough experience. Very few cities in our country have enough pediatric cardiologists. Most places, it is a cardiologist who does it. And adult cardiologists, unfortunately, do not have the wherewithal to give you a reliable. Echoes quite frequently delay the diagnosis. So only yesterday, one patient that Dr. Suda saw, this was a doctor's child. A doctor's child admitted in one of the most prestigious hospitals of our country. And the child had fever, several courses of antibiotics, admitted, they suspected KD, ruled out KD because echo was normal. And they have told the mother, this is not KD because echo is normal. And by the time the diagnosis of KD was made, the baby had disease. So echo is, yes, it's very important to follow up, it is very important to assess KD, but diagnosis of KD, just like diagnosis of acute rheumatic fever, does not need a cardiologist. If you have a cardiologist, yes, by all means involve him. But if you do not have a cardiologist, it should not stop you from diagnosing KD. Dr. Puneet.
Yeah, absolutely right. Only thing is that it is because of the treatment. In acute rheumatic fever, we have been treating like when I was doing PGs, it was the commonest cause of acquired heart disease, which we don't see now. The treatment was penicillin, which is the cheapest drug available. Problem with KD is again because of immunoglobulin. I am in a private hospital, although it is charitable, but the cost comes to around 30,000-40,000. And that is why once echo is normal, then we feel okay, we are giving IVIG primarily to prevent the heart disease, it is not involved, so we can able, and if there is coronaries are involved, parents are very easily convinced that IVIG is indicated, they are totally convinced. Otherwise they think doctors must be getting something from this very expensive injection. So all those mistrust is there. That is the reason why these cases are delayed, because we want to treat all the patients with IVIG, but the convincing is great. It's like 100%. Once on echo, there is some change in coronary. That is the main handicap. Once IVIG is as cheap as penicillin, I think lots of children might get it, and we might prevent the heart disease at all.
But the problem is that the first change on echo will appear 7 days plus.
Yes.
Dilatation or the softer signs of echo, most adult cardiologists may not even be able to pick up.
100%. We get patients nowadays, as somebody was pointing out, that pediatricians are going towards that direction. Fever, rash, okay, and platelets especially very high, could be KD, and they get the echo done. And majority of the echo is negative. When they are transferred to DMC, they have large aneurysm. The adult cardiologists have not even heard of the term KD. When I was taking a duty leave to my cardiologist as the HOD, the principal, he said, I am going to attend 5 days KD. He said, what is like KD? Because they don't see KD. They are seeing the consequences of KDs. We are getting very young people having diffuse coronary disease needing bypasses. So we have to make aware adult cardiologists also to be involved in, because it's a pediatric disease.
What I am saying is based on our own experience and unpleasant experience, very, very unpleasant experience. So because Dr. Rakesh had presented a paper at the Yokohama conference, that what is the reason for development of large aneurysms. So we grouped medium-sized and large aneurysms together. We didn't use the term giant aneurysms. And the main reason was
delays in diagnosis. So the practice of getting an echo before starting IVIG, I think that has to be reviewed depending on where you are practicing. If you are working at the Institute of Child Health, they will be able to get the echo there and then. But even in many tertiary level hospitals in our country, getting an echo for a child with KD, getting a reliable echo is not there. And that is precisely the reason that in our unit, our echoes are done not by the cardiologists, they are done by these fellows. The echo machine is right in the ward, they don't have to go to the cardiology department. We have done this because of our experience. So these DM fellows, they do the echo and they do it on a daily basis. They sometimes do it twice a day. And every clinic day, they end up doing something like 10 to 15 echoes. Because, and their reports are reasonably accurate. Because we compare them with what Dr. Mansoor shows later on CT. But I again would emphasize that diagnosis of KD does not require a cardiologist. The earlier you do away with a cardiologist, I seek your apologies, Dr. Devdatta, Dr. Amitabh and Dr. Sari. We need your help for assessment of KD, not for diagnosis of KD. Yes, by all means. You need their expertise, their skill. But for diagnosis of KD, we do not need them because it will result in delays. And then what happens is, the parents say that echo is normal, why should I treat? And convincing that parent is virtually impossible because he has more faith on a person who has a higher degree than on a person who is a poor MP. So that is a practical problem that we have.
Out of 20, sorry, I'm taking more time, out of 20, we may be having lots of cards. Only one person is trained. Even in our Hero Heart Center, only one person has an eye for coronaries. Rest of them missed, even in DFC. So what I would suggest is a request also, can you start some observership for the pediatricians to train in your centers?
That is exactly why we are doing this meeting. And that is the reason why at the last Kawasaki disease conference at Patna, we had an eco workshop. Okay, so with this we go on to the second talk, which will be taken by Dr. Rakesh Pinania.
Thank you, sir. And thank you, Priyanka, sir, for giving me a stage after your epidemiology you have given enough. So I will just focus on what is happening in KD in India actually. So what we have learned is that the global epidemiology of KD, which if you see, there is a paradigm shift in last 3 decades and the incidence of KD is increasing, and in the developed world, rather I would say now in developing world also, the KD has replaced acute rheumatic fever as the most common cause of acquired heart disease in children. And KD is also now being recognized in 2 most populous countries like India and China. And but what we have problems is like as sir has also highlighted that because the reliable data comes from the Japan and Taiwan and Korea only, because they have a nationwide data. We have only city-based city-specific data in both in China and India and also in other countries. So, but the emergence of KD as the commonest cause of acquired heart disease is now engaging the focus of healthcare administrators throughout the world, because this is the possibly the most common cause of like adult coronary artery disease, like a young adult coronary artery disease in the coming future. So this slide has been shown by Priyanka sir that what we have is that the differences of incidence is that Japan, which reports around its has incidence has almost increased from 6 to 7 times from last 3 decades, and what in China and India is we have a city specific data only. So the incidence, the KD reported from India is that before 1990 there are only 3 reports of 3 case reports, 3 cases were reported in India, and this is the first patient where IVIG was given in Kawasaki disease in India. So this was reported in June 1994, and this patient was treated in June 1994 and reported in Indian Pediatrics in 1996. These are the first two series which was reported from the Trivandrum, Kerala by Noel Narayanan group, and one case series was reported from our group also. So these are the case series which has been reported in 1997, and these are possibly the first series of the Kawasaki disease cases in India. So, but what is the incidence of Kawasaki disease in India? That we are missing actually. So, like we know the figures of incidence of Kawasaki disease from the 3 well-defined incidence data countries. But over the last 3 decades, what we have observed, and I will show you in next 10 minutes, that the incidence because of increased ascertainment or increased awareness of the Kawasaki disease in India, there is incidence has increased. But however, there is a paucity of nationwide data. So this is the first time we have attempted how to calculate the incidence data. That it was done with the help of Professor Jane Burns. She has suggested, sir, that whether we can have some incidence data from Chandigarh, because Chandigarh has some peculiarity that this is a union territory, and PGI is situated in such a situation that most of the patients, whether they will directly come to our institute or for a second opinion, will come to. But this would be the least incidence data, because basically it is possible that we have missed, or maybe other patient may have went to the other hospitals also. So, but possibly this is the least possible incidence data which is for Chandigarh, and based on this, over the 1994 to 2008, the incidence figure has shown that the incidence has increased, and it started from just 0.5 per 100,000 children. So worldwide we see the incidence of Kawasaki disease is less than 5-year-old children, less than 5 years. But here we, in initial data what we have done is that incidence was calculated up to 15 years, because there were very less patients below 5 years of age, and we have to do for an incidence data of less than 15 years of age, and it is possibly also related that so mean incidence of KD, which was so with age specific incidence, if you will see that incidence data is also more in the children like 6, 7 to 8 years of age, which is contrasting from the Japan and US, because you see the mean age of Kawasaki disease in Japan is around 2 years or 3 years, but we see a mean age of incidence at that time was around 7-8 years, which is contrasting, and possibly that is the reason that we have not seen many patients with less than 5 years, and possibly that is the reason that we are missing these patients. And we have also seen the seasonality in the in peaks in May and October, and there are consistent nadir which we have still seeing in February, and coronary artery abnormalities were documented in 5.8% during that time. Then we have, next time we have published from data from 2009 and 2009 to 2014. Dr. Sagar has compiled this data, and again the incidence has increased from the previous, and this incidence data is at less than 5 per 100,000 children, and the incidence has raised ranging from 3.0 to around 9, but the mean incidence in these 5 years were around 5.35 per 100,000 children. So the incidence was gradually rising during these years. And this is a monthly distribution. Again, there is a nadir you can see in February, and the peaks are in again May, June and October. So and CAs at this time was documented around 12.9%. So again the incidence of CA, which was Professor Priyankar Pal also highlighted, that we are seeing more coronary artery abnormalities. Possibly it's we'll discuss the reasons behind this also. And the median age at diagnosis was still at 7 years. So which is something which is different from the Western world and like Japan, because again I'm highlighting that possibly we are missing the children less than 5 years, and which is the most common age of the diagnosis of Kawasaki disease. And again male-female ratio suggesting of 3.9:4:1. Then we have compared the data of 2015 to 2019, which we have recently published, and the incidence figure has again increased to it is almost touching to the 10 per 100,000 children, and which is like similar to the figure which we see in Europe and North America. So North America reports around 15 to 30, while Europe reports around 10 to 20 per 100,000 children. So we are almost touching to that incidence data, but what we see in Japan is almost 40 times of this. So that the current incidence data suggests that Japan reports around more than 400 per 100,000 children. And again monthly distribution suggested that there was a distinct peaks during the May and October, and the nadir was seen again in February. So this is a trend of Kawasaki disease cases at Chandigarh from 1994 to 2022, which has shown that there is an increase in the incidence of new fresh cases at our center, and this you can all observe, and this possibly you have observed everywhere, that during the COVID-19 pandemic we have seen that dip in that. Again it's coming, and recently we have just analyzing our data till 2024, which is showing that incidence data is now in 2024 is almost touching to the pre-pandemic levels. So this is again to highlight that incidence of which has started from just 1.4 to has rose to around 9.72 per 100,000 children. So incidence of KD has increased from 1.4 to 9.72 in last 26 years, and which is almost 10 times of the incidence data which has been when we have started seeing these patients. So this is possibly multifactorial, as we are discussing, that is possibly due to true increase in incidence which we are seeing in countries which are well versed with the diagnosis of Kawasaki disease also, and more likely an increase ascertainment, because in our setup we have several challenges in diagnosing this disease. So this is a paper we have published recently in a Lancet, that incidence of Kawasaki disease among children in Chandigarh. What we have done is that we have then studied the incidence of Kawasaki disease during this period, and we have also done the trend analysis, and to show we have also compared the acute rheumatic fever data, because this is still in a mind of everyone that acute rheumatic fever is the most common cause of acquired heart disease in children, but which is not true, and we have to refute multiple times. As a pediatrician, it's our duty that we should refute this as early as possible, because otherwise that too much resources are just allocated to that, and we have to highlight these issues. So what we have done is that linear trend analysis again suggested that the incidence is increasing in Kawasaki disease, and what we have compared the incidence data of acute rheumatic fever as a nationwide data. We don't have a acute rheumatic fever data from. So what we have done is that it's part of a project which is published as part of ICMR's project. The incidence data of acute rheumatic fever we have calculated from there, and what we have shown that the incidence of Kawasaki disease is increasing while rheumatic fever incidence is decreasing. So this is a data from Chandigarh. I have also took data from Priyankar sir and Jigna regarding the epidemiology of Kawasaki disease at ICH Kolkata. So which is again a hospital-based study, and what this study suggests that from 2009 to 2022, around almost more than 13 years, the Kawasaki disease cases were 229. While in just 2 years, they have seen 54 patients, new patients, and again in next 1 year only, almost 1.5 years, they have seen 80 cases. So the incidence, the true load of the patients is increasing. So this is just a hospital-based data to suggest that case load is increasing And again, to suggest that they have also seen the IVIG resistance and coronary artery abnormalities, and what we were discussing is that IVIG resistance, if we can see, is almost 8%, while giant aneurysm figure is almost same, or rather it is decreasing, but the true coronary artery aneurysms are increasing from 21% to 33%, which is a significant figure to note. Again, age distributions to suggest that in patients, it's a more than 5 years group is around 5.6% or 6%, while infantile group is almost 1/3 of the patients in their group. So this is an extremes of the age, because we know that less than 1 year and more than 5 year children may have more chances of developing coronary artery abnormalities, more specifically in infantile age group, and so which suggesting that at this center we can see that almost 1/3 of patients are infantile, and possibly that is one more reasons that we are seeing more coronary artery abnormalities at your center. And incomplete KD figure has also rose from like 20% to 30% over the years. So what we have seen is that this is the available data from India, but good part is that we are able to diagnose these patients, and the centers in India with experience in diagnosis and treatment of KD is increasing. I know that we have to add many more pictures here, but this is possibly related to that because there is increase specialized and specialty and expertise at the several centers, and because of these availability of these specialists, we are able to diagnose more patients in these regions. And there is an exponential increase in the publication of Kawasaki disease in India, which is like before 2000, you can see now it's in 2023, we have almost 60-70 publications per year in last 2-3 years, which suggests that the awareness and incidence of this disease is increasing. So this is possibly related to the several things, because awareness has increased amongst pediatricians, internists and cardiologists. Diagnosis, there are always concerns of underdiagnosis and overdiagnosis, the disease which has a clinical diagnosis, and we were discussing that if you wait for echocardiography to diagnose this disease, then you are mistakenly taking this. So again availability of echocardiography, although it's not ideal, but again there are several improvements. So in next one and a half minute what I will show is that if we are seeing that incidence data is increasing, what are the prediction, analysis and public health perspective of this disease in India? So if we see the global epidemiology trends in the Kawasaki disease, and so what we see in the United States, KD in 1990s were 4.5 per 100,000 children, while in 2020 its incidence data is almost 20. While in Japan you see acute rheumatic fever in 2020s it's more of 90s. In acute rheumatic fever in Japan is almost anecdotes. They don't see. KD in 1990s were 90 per 100,000 children, which is like in 2020 is 350 100,000 children. So the incidence is worldwide increasing, and so Japan with a population of 130 million reports more than 15,000. Now the recent data suggests that this figure has crossed 15,000, and so corollary to this is that 1% of all children born in Japan develops KD before age of 10. So why should we will be different? Because we are also having in the same regions Asian descent. So if we extrapolate our KD incidence data of Chandigarh and to our Indian populations based on our calculations, if you see the total population is around 1.4 billion now, and approximate population of children below 15 would be around 426 million. And if we extrapolate the Chandigarh data to Indian population, the estimate number of children will be affected is around more than 20,000. I don't think that we are diagnosing this much of children in India. So, and CA would likely to develop in 25% if you don't treat. So we are accumulating this much of missed Kawasaki disease in India. So at least more than 5,000 children with significant CA due to KD are being added year by year in India. And so what we have done is the prediction analysis based on our trend analysis of incidence data to predict the incidence of Kawasaki disease at Chandigarh over next 5-10 years from 2019 to 2030. So what we have seen that incidence of Kawasaki disease is likely to increase at least up to 2030, and this figure, based on this figure, we have come to that 1.7% per month incidence case burden is possibly will increase in Chandigarh. So if you project this, because if you see the incidence of Kawasaki disease in Japan is 350, Korea 134, Japan and Taiwan is 84, Shanghai reports almost 107, Hong Kong is 74. So mean Asian KD incidence is around 150. But in Chandigarh we report just around 10. So if we have to take, because the Asian descent, there is a genetic predisposition to this disease, and possibly that we have more similarity to the Japanese than the US or Europeans. So based on that, possibly we are missing at least 15 times of, based on these projections, the mean Asian KD incidence, 15 times more cases would be there. So that means that the incidence of Kawasaki disease in India is grossly underestimated. So to conclude, that KD is now the commonest cause of acquired heart disease in children, and which has having overtaken acute rheumatic fever, and the prediction analysis which we have done over 2020 to 2030 indicates a continued rise in KD cases, with an estimated monthly rise in around 1.7% in children less than 15 years, and with increasing awareness and increasing diagnosis, we have to improve that what can be done for a better surveillance and better intervention to address this issue. Thank you.
Thank you, Rakesh. This talk is now open for questions.
Is there any particular community prevalence for the KD patients who have in the Chandigarh?
So we possibly you are asking regarding the community. So we don't have looked into that perspective, and this incidence data is calculated based on that the patients who are resident of Chandigarh, and the denominator is the population of the Chandigarh. We see patients from several part of the India, mainly from Himachal, Haryana, Punjab, Chandigarh, and then part of UP and Rajasthan also, and several other patients. But in the incidence data which we have calculated is the patients who are resident of Chandigarh only, Union Territory Chandigarh, not even Mohali and Panchkula also. So that based on that we have calculated the incidence data. Possibly this is an underestimated figure, because few patients will be treated in two major government hospital also, and few private sector hospitals also. But this is possibly the at least minimum incidence of Kawasaki disease in Chandigarh. Yes, ma'am.
Excellent presentation. I wanted to know was that these are the cases who were based primarily on the criteria?
Yes.
Echo was majority of times normal, because you said few had coronary dilatation.
So basically, ma'am, you are asking that the diagnosis of Kawasaki disease based on American Heart Association statement, and if I will talk to regarding the coronary artery abnormalities, the coronary artery abnormalities in latest paper is around 17% of the patients has developed coronary artery abnormalities in these patients. So which is if we see from the previous data which we have published in 2000 up to 2008, it was 5.8%, 2009 to 2014 was around 11%, and now it is around 17%. So CA incidence has increased over the time.
And regarding the Z scores and the size of the coronary, is it related to population, or are we taking, what is the standard by which we are comparing our scores?
And this is a very important, yes.
So I think we now conclude this session, and I would ask
To chair the next session, we welcome Professor Tapas Kumar Sabui. He is a professor of pediatrics at the Shantiniketan Medical College, Bolpur, West Bengal. He's a president of Indian Society of Kawasaki Disease, past president of Pediatric Rheumatology Society of India.
Next talk is.
National Cerebral and Cardiovascular Center, Osaka, Japan. She has awards she received Outstanding Research Award in Pediatric Cardiology, American Heart Association 2002, Kawasaki Award 2003, Japanese Society of Kawasaki Disease, Research for Memory and Efficiency, Dr. Terry Memorial Foundation at America 2017, Kawasaki Award 2021, and she is members of the Japanese Society of Pediatric, Japanese Society of Kawasaki Disease. She has extensive experience, wide experience in Kawasaki disease, coronary artery changes. She has followed the 30 years. And let's Dr. Sudha to speak to the subject. Madam, please.
Thank you for introducing me. Mr. Chairman, ladies and gentlemen, I am pleased to speak at opportunity to speak at this section. The first talk is detection of CAA by 2DE. The upper picture shows the proximal portion of normal right coronary artery by a right parasternal approach. The lower picture is the proximal portion of the left anterior descending artery. As shown in this slide, the left parasternal approach with the patient lying in a left lateral position is useful in detection of LAD in the older children. This picture shows a patient lying a left lateral position. As shown in this slide, the right parasternal approach with the patient lying in a right lateral position is very useful in avoiding missing aneurysm of RCA. This picture shows a patient lying a right lateral position. Coronary aneurysms complicate the acute phase and are best visualized by screening the coronary circulation by two-dimensional echocardiography. These basic sections by 2D are optimal for screening the segments of each major coronary artery. In our 1980 study, the slide shows characteristic of coronary artery in the acute phase by two-dimensional echocardiography. 5 days, increase of echo enhancement. 9 days, slight dilatation. 11th day, coronary artery aneurysm occurred. These are two-dimensional echocardiography takes on the 9th illness day. Coronary artery walls are in both are highly echoic and the vessels are slightly dilating. These are typical findings in the acute phase. The coronary arteries are more clearly seen in the acute phase compared with an ordinary examination. The proximal portion of both coronary arteries can be shown by a left parasternal approach. In the right picture, both coronary aneurysms can be detected. In the left, we can see pictures of the 2D and the coronary angiogram on the right. Aneurysms of the proximal portion of left anterior descending artery and left circumflex are detected. These pictures are the bifurcation of the left coronary artery. Direct coronary artery is detected by 2D and CAG. Sorry. As shown in this slide, the right parasternal approach with the patient lying a right lateral position. An aneurysm at the distal of the first segment can be detected by a right parasternal views. This slide depicts 2D at 1 month after the onset of the coronary angiogram, at 2 months after the onset of KD are shown. The aneurysm displayed in the distal portion of the first segment of the RCA could not be detected without a right parasternal view. As shown in this slide, the left parasternal approach with patient lying a left lateral position is useful in detection of distal RCA in the older children. The pictures show the proximal and distal portion of RCA. The picture shows proximal and distal portion of RCA and CTA imaging. Important is that distal portion of the right coronary artery can also be detected in a left parasternal view. The picture shows proximal and distal portion of left circumflex of regression of moderate size coronary aneurysm is quite frequent. In the left, showing the finding of 2D and CAG in 1 month after the acute phase. On the right, those in 1 year after the onset are shown. In 1 year after KD, small aneurysms are detected by 2D. On the other hand, it's almost normal coronary artery. Although there is irregularity of coronary artery wall, there is a slight discrepancy in the regressed aneurysm between 2D and CAG. We can see the outside of coronary artery by 2D and the inside of vessel CAG. These pictures are left coronary artery of the same patient. 1 year after KD, a slightly dilated coronary artery is detected by 2D and CAG. Thrombus in coronary aneurysm of the left coronary artery was detected by 2D. Thrombus in coronary aneurysm of the right coronary artery was detected by 2D. Thrombus in coronary aneurysm of right coronary artery was detected by 2D and CAG. RCA was occluded due to thrombus. These pictures are LLE and LCX 3 months and 1 year after KD. The diameter of CA was decreased in the late period. These pictures are right coronary artery at 3 months and 1 year after KD. The diameter of CA was decreased in the late period. These pictures are right coronary arteries 2 months and 1 year after KD. The distal CAG shows the distal small CAA was digressed after 1 year after KD. In other patients, CL changes of aneurysm are shown 55 days and 1 year after KD, and 2 year, 3 year, and 4 year after KD. Coronary angiogram was shown in the same patient. Localized was found 4 years after KD. CTA imaging was shown in the same patient. Localized stenosis is speculated. Morphologic changes in coronary artery aneurysm are shown. Localized stenosis can occur many years after regression of coronary aneurysm. However, it to detect by 2DE. It's important to detect an aneurysm in the proximal portion of the RCA. The giant aneurysm wasn't diagnosed in this patient. She was referred to our institution at 1 year after acute KD because of dilatation of the RCA. Abnormal Q wave is detected in the electrocardiogram. She was asymptomatic. CTA shows the occluded giant aneurysm. CAG coronary angiogram also shows the occlusion of the RCA. Collateral arteries from the LCA to the distal RCA. In the previous institution, giant aneurysms of RCA had not been realized in 2 months after the onset of KD. Myocardial ischemia was detected in technetium myocardial perfusion imaging. Coronary artery lesions caused by KD is shown. In stenotic region, there are localized stenosis, segmental stenosis, and occlusion. As shown in this slide, left parasternal approach with patient lying a supine position is useful in detection of proximal LCX. However, it isn't easy to detect the left circumflex by two-dimensional echocardiography. It may be detectable if there is dilated region in the LCX. Professor Sinha in Chandigarh reported an assessment of the LCX by CT angiography. It's useful paper. It isn't easy to detect the left circumflex by two-dimensional echocardiography. he came to our hospital 2023. This picture shows coronary aneurysm of the left coronary artery is detected by two-dimensional echocardiography and coronary angiogram. However, it may be detectable if there is a dilated region in the LCX. The second talk is changes in coronary artery aneurysm within 1 year after KD. Acute vasculitis can often lead to coronary aneurysm. The changes in the maximal internal diameters of CAAs over 1 year after the onset of Kawasaki disease were investigated by two-dimensional echocardiography and coronary angiogram. We classified the changes in coronary artery diameters based on the degree of coronary artery involvement immediately after acute Kawasaki disease by 2DE. 195 coronary artery aneurysms in 84 patients after KD examined by 2DE were reviewed from 1995. The changes maximal diameter within 1 year after KD by 2D in patients with coronary artery aneurysm was evaluated. CAA was defined as either diameter more than or equal to 3 mm or Z-score more than or equal to 2.5. In the left, we can see pictures of 2D, the coronary angiogram on the right. Aneurysms of the proximal portion of the left anterior descending artery and the left circumflex are detected. In the same patient, serial changes of left coronary artery by 2D are shown. Coronary aneurysms have regressed. Aneurysms distal of first segment can be detected by right parasternal view. Aneurysm, serial changes of coronary aneurysm 1 month, 3 months, and 1 year by 2DE are shown in the same patient. Coronary aneurysms have regressed. The x-axis plots the maximum diameter of CAA and the y-axis in the days after onset of acute KD. A black circle indicated as CAA. A white square was regressed CAA. The smaller diameter, the earlier the regression of CAA. Z-score of coronary artery in Japanese children was reported from multi-institutional study. The growth of normal coronary artery is shown. Classification of coronary artery lesions in Kawasaki disease in Japanese guideline is shown. If the body size are different in patients with CAA, it is difficult comparing with absolute diameters. This graph shows the relation between the absolute diameter and Z-score depending on age. A CAA of 6 mm in patient within 6 months, Z-score is 10. On the other hand, in a CA of 6 mm, in patient more than 5 years, Z-score is less than 10. In this study, CAAs were evaluated using two classifications, the absolute diameter classification and Z-score classification. Time to CA regression based on maximum diameter and Z-score of the largest CA within 100 days after KD is shown. CAA regressed until about 200 days. This graph shows the relationship between the maximum diameter of the largest CA within 100 days after KD and its diameter at 1 year after KD. 1 year after KD, the maximum internal diameters of most of CAAs of less than 6 mm within 100 days after the onset of KD decreased. In 4 CAAs of the older children, the maximum diameter after 1 year are larger than those of the largest diameter with 100 days after the onset of KD. The third talk is changes in CA diameters after KD from infancy to adolescent by two-dimensional echocardiography. We clarified the changes in coronary artery diameters based on the degree of coronary artery involvement immediately after acute KD by 2DE. 216 coronary arteries in 85 patients after KD examined by 2DE were reviewed from 1995. The evaluation of coronary arteries by 2DE in patients with coronary artery lesion was performed at 2 months, 1 year, 3 years, 10 years, and 15 years after KD in our institution. Median duration of fever was 10 days. IVIG resistance was found in 80% of patients. The detection of the largest CAA within 100 days after KD was investigated retrospectively. The time when most of CAAs reached their maximum diameter was around 30 days. Shear changes of CAAs are shown in this slide. The maximum diameter coronary aneurysm at 2 months is 5.1 millimeter. 1 year, it is 3.7 millimeter. At 3 years and 10 years after KD, they are 3.3 millimeter and 3.7 millimeter respectively. In the same patient, the CT imaging at 2 months and 1 year after the onset of KD are shown. The diameter of CAA was decreased at 1 year after KD. In this study, CAAs were also evaluated using two classifications based on the CAA diameter 2 months after KD. The absolute diameter classification and the Z-score classification. In the medication of the early period, warfarin was used in 64% of the patients. In the late period, it was 16% in 60%. Its outcome of CAAs asymptomatic occlusion occurred in 6 CAAs of RCA. Acute myocardial infarction occurred in 2 CAAs. CABD was performed in the 3 patients. We can see CA diameter, the time from the onset of KD to cardiac event, and the medication about the cardiac events of CAAs. Z-score of all CAAs were larger than 10. Acute MI occurred within 1 year. CABG was done from 7 to 15 years after KD. Asymptomatic occlusion was found in patients who had taken warfarin from 3 to 7 years after KD. The graph shows the mean maximum coronary diameters in the rate period in each group based on the absolute diameter classification. There was a significant relationship between the maximum internal diameter at 2 months and subsequent changes in the maximum diameters after KD in the rate period. Maximum diameter of coronary artery aneurysm more than or equal to 8 mm at 2 months didn't change significantly after 1 year. However, the maximum internal diameter of CAA was significantly smaller in the rate period. Coronary artery without dilatation at 2 months after KD grew normally. In Z-score classification, it was also found that a significant relationship between the maximum internal diameter at 2 months and subsequent changes in the maximum diameter after KD in the rate period. Coronary arteries without dilatation at 2 months after KD grew normally. The left graph is absolute classification, and the right graph is Z-score classification. In the absolute classification, CAAs in M and L group at 2 months after KD persist in adolescence. In the Z-score classification, CAA in ZM2, ZL1, and ZL2 group persist in adolescent. In the next, absolute diameter changes of CAA based on BSA were investigated. Left graph is BSA less than 0.5, and right is BSA more than or equal to 0.5. CAAs in M and L groups at 2 months after KD persist in adolescent. The change of CAA diameters based on the Z-score classification by BSA were investigated. The left graphs are BSA less than 0.5 and the right is a BSA more than or equal to 0.5. In patients with a BSA less than 0.5, CAA in ZL1 and ZL2 group persist in adolescent. In patients with a BSA more than or equal to 0.5, CAA in ZM2, ZL1, ZL2 group persist in adolescent. CAAs of ZM2 in those those with a BSA less than 0.5 were included in regressed CAAs, and those with a BSA more than or equal to 0.5 were included in persistent CAAs. Next graph shows the Z-score change of CAA in late period based on Z classification in the late period. CAA with a maximal diameter Z-score more than or equal to 7.5 at 2 months after KD persisted in adolescent, whereas coronary arteries with diameter Z-score less than 7.5 were within normal range in the late period. CA with maximum diameter more than or equal to 6 mm and Z-score more than or equal to 7.5 at 2 months after KD persisted in adolescent, whereas coronary arteries with diameter less than 6 mm and Z-score less than 7.5 could be within normal range in the late period. Thank you for attention.
Thank you, Dr. Sudhakar, for sharing your wide experience with echocardiography. Extensive follow-up. Any questions from the audience?
Thank you so much. Is there any minimum age at which you can do CT angiography?
Yeah. First, our institution, coronary angiogram in all patients in 1990s, but in now CTA and MRA is performed. Coronary angiogram is performed in case with indication of CABG.
Lowest age group where you have done CT angiography, any age limit?
The CT is infant is okay, but MR sedation is needed. Therefore, MRA in 6 years, MRA is more than 10 years, but it is needed case MRA in perform small patient.
If the patient has already developed aneurysms, do you still give IVIG? Because the failure rate was very high, 68% resistant to IVIG.
Yeah. The patient in this study, most of 1990 to 2000, and to the total dose of IVIG less than 2 grams per kilogram per day, not used in these days. And IVIG resistance, number of patients with IVIG resistance was large percent.
Why did you take the 2 months assessment for the predicting the long-term fate of the aneurysms? So, studies with the maximum initial diameter also has some outcome data, but we do the size of the 2 months to have a correlation with the long-term growth. So, there is something to do with our counseling with the patient also. What was your reason behind taking the 2 month data?
But in adult, detection of coronary artery obscure, and to adolescent is okay, but in adult it is detect to coronary artery difficult.
His question is why you have taken 2 months as a cutoff time. 2 months echo as a cutoff time.
Yeah.
Why you have taken 2 months, not 3 months, 6 months? His question. He's asking that question.
Yeah. Sorry. Sorry. Yeah.
Thank you again for the wonderful talk. And just mentioning in the older children, adolescents also, or young adults, did you get a chance to see the inside of the coronaries by OCT or any other technique?
Yeah. To
see the inside of the coronaries.
Yeah. Yeah. Inside coronary into severe calcification. With severe calcification is case in MRA is performed, and to not slight calcification in CTA performed. CTA is performed inside to detect inside coronary artery.
So if there is no question, I should end the session. Thank
To chair the next session, we again invite Professor Surjit Singh, the head of the Department of Pediatrics and the unit head of Allergy and Immunology Unit, PGH Chandigarh.
So for the next session, this is on Z scores. We start with a talk by Dr. Vignesh Panderajan, whom all of you I'm sure know very well. So he is the additional professor in the Pediatric Allergy and Immunology Unit, and he will be giving a talk based on a few years' experience of trying to develop some Z scores for India. So this work has extended over several years. So this is the first attempt at developing some kind of Z scores.
Thank you, sir, and thank you, organizers, for this opportunity. So I'll be talking about ABC of coronary artery Z scores. So three important things which I would focus on in my talk. First, I would go through history why coronary artery Z scores are important and how coronary artery Z scores are calculated. And third, our experience in deriving the coronary artery Z scores. So moving on, so this is my disclosure. I have used artificial intelligence. We have heard the talk in the morning. So I have used it to augment the presentability, not the contents. And no conflicts of interest. So Z-score, we know it's a statistical measure that describes how many standard deviations your data point is from the mean of a data set. So it is useful for standardizing the different data sets, comparing values across distributions, and identifying the outliers. So this is the mathematical formula for any Z-score, that is x minus mu by sigma. So the x is your data point, mu is the mean, and sigma is the standard deviation of the data set. And this is also the basic thing which we should know, that 0 is exactly at the mean. More than 0, it means the data point is above the mean, and less than 0 means the data point is below the mean. And plus 1 means it's plus 1 standard deviation above the mean, and plus minus 2 means 2 standard deviations below the mean. Okay. So coronary artery Z-score. So the concept of coronary artery Z-score, it evolved as a method to normalize the coronary artery measurements for body size, primarily in children, because children, they grow over time. So before Z-scores, the absolute coronary artery diameters were used, but these values did not account for the differences in the body size. So it all began in the 1990s when the researchers began using the body surface area as a scaling factor for coronary artery dimensions. So this is the first such study, to the best of my knowledge, published in 1989 from Germany, where the pediatricians have shown that the coronary artery dimensions, it increases with age, both the left coronary, right coronary, also the left anterior descending. So, and we had the 1994 guidelines for the long-term management of patients with Kawasaki disease. We have several cardiologists in this paper. So in this paper, they have mentioned that aneurysms are classified as small, medium or giant depending upon the size, small less than 5 and medium 5 to 8 and giant more than 8 millimeter in diameter. The important point which they have mentioned in this guideline is patients with Kawasaki disease and no coronary artery abnormalities on echocardiography at any stage of illness may be discharged from the follow-up 1 year after the onset of illness. So this statement has probably triggered Dr. Jane Newberger, and because there is no proper definition of what is coronary artery abnormality. We have the definitions for aneurysms, but if this aneurysm is less than 3 mm in size, does it mean the child does not have a coronary artery abnormality? So let us see. So this is the first such study on Z-scores by Dr. Jane Newberger and group. So in this study, she has taken around 89 children with Kawasaki disease with controls. And what she showed here is the 27% of patients classified as having normal coronary arteries by the Japanese Ministry of Health criteria would have had at least one coronary artery abnormality if the BSA adjusted coronary artery dimensions are used. So this is the conclusion of the study. The Japanese Ministry of Health criteria may underestimate the true incidence of coronary artery dilatation in patients with Kawasaki disease, and a revised BSA specific criteria should be used. So this is the trigger point of coronary artery Z scores in Kawasaki disease specifically. So this is followed by multiple other studies. Murugan will be discussing it subsequently. So now moving on to the second part. So what are the prerequisites for calculating a Z score? So step 1 is to gather the patient data, the age, the height, weight and the BSA, body surface area. Step 2 is the coronary artery measurement. Step 3 and step 4, these are automated. We have online calculators these days, but the step 3 is using a Z-score equation, and step 4 is finally calculating the Z-score for a given dimension. So the Z-score calculations are usually based on the body surface area, often using the Haycock's formula. So you don't have to remember this formula, but this is the standard that is used for calculating the BSA. The important point here is the accuracy of BSA. Accurate height and weight are crucial for calculating a coronary artery Z-score because they directly affect the body surface area, and BSA is the primary scaling factor in the Z-score equations. Why does the accuracy matter? Because BSA is the reference standard. Even a small error in height or weight can miscalculate the BSA, leading to incorrect predicted artery size. And Z-score formula, it depends on your body surface area. If the body surface area is overestimated or underestimated, the predicted diameter will be incorrect, shifting the Z-score. And it has an impact on clinical decision making. A small change in BSA can shift a Z-score, and I don't have to explain to this audience what a shift in Z-score can have an impact in the treatment decision. So, what is the impact of height and weight impact on Z-score? So let us assume a child's actual body surface area is 0.73 meters squared. But due to an error in height measurement, if you incorrectly calculate it as 0.8 meters squared, and if the predicted coronary artery diameter was originally 1.92 mm, but increases to 2.05 mm due to a wrong BSA. So what happens? The Z-score decreases, potentially misclassifying an aneurysm as normal. Conversely, if you have underestimated the BSA, it could inflate your Z-score, leading to overdiagnosis. So this is one important thing which we should bear in mind. So what are the best practices for accuracy? So the height and weight, it has to be a proper standardized way using a stadiometer or a infantometer for measuring height or length, and using a calibrated scale for weight, and validated BSA formulas, Haycock, which is commonly used, and to prefer online Z-score calculators to minimize the errors. Now, step 2, coronary artery measurement. Dr. Amitabh Chattopadhyay has touched upon this yesterday. The dimensions are recorded from the inner edge to the inner edge of vessels during the diastolic phase of cardiac contraction in the parasternal short axis view. So the parasternal short axis view, I hope you people would be familiar. Dr. Suda has shown in her last presentation. The measurement of LMCA should be done midway between the ostium and the bifurcation of LAD and LCX. The measurement of RCA and LAD should be done 3 to 5 mm distal to their origin. So this is just a pictorial way of showing where exactly the measurement has to be taken. So this is also the figure published by Dr. Jane Newberger and group in the year 1998, the initial study on coronary artery Z-scores. So now using our what is the next step is you use the Z-score equation. So using a validated formula. So this is the Dalar and Dada, the largest sample for any coronary artery Z-score study. So the predicted LAD is calculated based on this formula. This is based upon the regression analysis that they have done. And also the standard deviation is calculated. And then you have the Z-score formula to derive your final Z-score. So these are the steps in deriving a Z-score. So now our journey on developing a coronary artery nomogram, how we did this study and what all the difficulties we faced when establishing a coronary artery nomogram for the North Indian population. So this is a compilation of 5 MD theses spanning over the period of almost 7 years. So 503 healthy children were enrolled, and 41% of them were female and 59% of them were male, with a mean age of 53 months, and the age varied from 1 month to 12 years. And this is the overall distribution of the age. You can see the predominant population is between 10 to 20 because we had 2 theses, one with less than 1 year and the second between 1 to 3 years. So you have a lot of population here. So this is the scatter plot for correlation with the body surface area, the LMCA Z-score, the RCA Z-score, as well as the LAD Z-score showed a good correlation with the body surface area. So we were happy. Now, when we went on to derive the Z-scores, this happened. So for the LMCA, the data almost is okay, but when we had a look at the RCA data, you can see the curves are crossing, so which should not happen if your sample size is adequate and if there is no big error. And also here in LAD, the major error is the crossing. This has overlapped here, but here it crossed. The Z-score curves are crossing. So basically the first analysis what we did was actually it was a Box-Cox power transformation for the regression analysis. Probably that didn't work. So then we had Professor Shankar Prinja helping us. So we tested the model that best fitted the relationship between the independent as well as the dependent variables. So we tested the linear, logarithmic, quadratic and cubic polynomial models, and he suggested that the natural logarithmic transformation was performed to be the dependent variable to account for the error, and this was the preferred predictive model for all 3 coronary artery measurements. So basically, the thing is we didn't get the parallelization, so we did a logarithmic conversion and regression analysis was performed using this equation, and the coefficients needed to create the Z-scores were then derived using the logarithmic models for all 3 coronary artery measurements. And the Z-score was calculated using the following equation, and this is what based upon the current statistics. So we have the data for left coronary artery, the right coronary artery, and the left anterior descending. So the curves are more or less fine. So this is what we have done for the 503 children enrolled in our study. So this is all I have for you today. So with this, I acknowledge the thesis students who have performed the analysis of these, the data of these children, Dr. Raviteja, Ritesh, Shruti, Chaitanya and Robin, and Dr. Manful Singhal from the Department of Radiodiagnosis, Dr. Shankar Prinja from the Department of Community Medicine, and also all the DM senior residents and the faculty of Allergy Immunology Unit. Thank you.
Thank you, Vignesh. These are definitely very early days to be, before we can call these as Indian Z scores. Although Dr. Shankar has tried to fine-tune the Z scores to the extent possible, but we are more than aware that it would require many more inputs before we are able to say that yes, these are reliable Z scores, but this is just an attempt, work done over several years, and Vignesh has been working on the mathematical calculation for more than 6 months now, taking the help of Dr. Shankar Prinja. But we have something in place. We have something in place. Z-score calculations throughout the world, these have been very, very controversial, and at the last International Kawasaki Disease Symposium at Montreal, so there was a full presentation on how a given coronary artery dimension can have different Z-scores depending on which calculation you have used. So this is a tricky issue, and within India also, I'm quite sure that once we go into the details, the Z-scores developed in Chandigarh may be different from the Z-scores developed in Kerala, in Calcutta, where have you. So, but something has been done, and I'm sure we can build on this. So, any questions on Dr. Puneet?
Great effort. Only thing is, different observer was doing the echo, so observer bias.
So the students were different, but the echo was done by, actually the entire measurements were analyzed by me as well as Dr.
Yes, there is a problem of selections bias will be there because it is a single center studies. So it will be better to include the patient from the or healthy children from the different area of India.
Yeah. Yeah. So this is North Indian and healthy children. Yeah.
We did similar like PFR study, took the spirometry to various schools and did more than 5,000, and that is whenever there is some PFR from India or North India, that study is always cited. So maybe something can be done by taking echo to the various schools, because we do not know what are the normal dimensions. And even South India, North India, the dimensions are different. So everything is like we need to do at a mass level by taking an ICMR project or involving the Ministry of Health and Family.
I just want to make this comment on your comment on the schools. It's technically very difficult to take a high-end machine which can assess the coronaries.
That's the main issue. Spirometry would be taken
in India because of the PNDT issues. It's very difficult to take that high-end machine which can adequately and reasonably detect the coronary measurements to schools. That logistics needs to be.
It's virtually impossible. It is virtually impossible.
Observer variation change the result.
So we took the average. So 3 independent measurements, 2 different observers, and an average was taken.
But if you do the study in the entire country, will it make definite changes, or will it make minimum changes, will not make any at all changes?
You're talking about the inter-observer variations?
Yes.
Probably that needs to be taken care of. I think during the methodology we should be clear that how those variations are needed to be tackled upon. So probably 2 different observers in 3 different measurements and having an average, probably that we thought that's an ideal.
Or maybe the PDA becomes a training institute for all, and then you are all connected. Start training us, start training their issues.
These issues have been there in all Z-score systems throughout the world. So it's a big problem. So with this, thank you Vignesh. We go on to the next talk, which will be given by Dr. Murugan. And
able to document on different Z-score systems.
Thank you, sir. Without wasting much time, I shall move on to my topic, which is different Z-score methods for the assessments. So the history was also briefly outlined by Vignesh sir. So this was before the Z-score era, the coronaries were being assessed by the absolute diameter in 1980. Health criteria, which was this one. So you take either less than 5 year, the size more than 3 mm. If it is more than 5 year, the size was taken as more than 4 mm. Or you measure the adjacent normal segment, and if it is more than 1.5 times, then it was considered as an aneurysm. However, the limitations were that they also did some risk stratification, like the bigger the aneurysm, they need additional therapies like thromboprophylaxis, like that. So they stratified with dimensions itself, which was, as Vignesh was saying, that they had a small, medium and giant aneurysms based on the diameter. This was from 1994 AHA. However, that was also not satisfactory, and we had another size-based classifications by AHA 2004 and JCS 2008. So the real introduction of Z-score was proposed in 2004 AHA, but they also took the stratification with the diameter. So these are all the work which was done before the Z-score era. And the limitation with them is that they didn't account for the patient size, like the patient size varied across ethnicities, and it underestimates the aneurysms, like you cannot applicable a diameter of a 1-year-old to a 5-year-old, which may be normal in a 5-year-old. If you take the 5-year-old, it may be aneurysm in an infant. So that's how they come up with the idea of Z-score, which was discussed already. And this is the first study, like a group from the Newberger. So they put forward the hypothesis that we have to introduce the Z-scores in the coronaries. So with that thing, later they had many proposals from 1998 to the latest one in 2017 by Lopez. So we have McCrindle from a group from Canada, and Oliveri, Delan, Kobayashi, and then Lupus. So we'll see what are these changes, why do you need so many scores. So if you see the first study from Boston, 1998, they took 18 normal patients, and these are all the various methods of body surface area calculation, and these are all the regression methods to normalize the size of coronaries to the expected proportion. So these methods do vary with the depending on the type of coronary Z-score method. No one of the method is superior to the other method, and at that aspect they still have many controversies. And if you take the other parameters, like the number of patients, the largest one is from Dallaire data in 2011. They had around 1,000 patients from Canada, and Kobayashi score used around 3,800 patients. And Lupus, they used, it was a multi-institutional study in North America. They used around 3,500. So this scoring method has included multi-ethnic population also across many centers in North America. And these are all the methods that they used. The real advantage of Dallaire data and Kobayashi is that they included the Z-scores for the LCX, which is not there in any other model. So this is about the various Z-score methods that we do have at present. So what are the real uses of the Z-scores? Like it has been emphasized already. I will quickly go through these slides. They increase the diagnostic accuracy, and as KD, incomplete KD, we need an echo to diagnose often. And the real difference comes from what is the frequency and duration of follow-up that do require the follow-up echoes, and the time required for the thromboprophylaxis, prognostication based on the Z-scores, and the needity for the long-term follow-up studies. So these are all has been covered in 2017 AHA guidelines. It was not there prior to that thing. So if you take this systematic review from again a Toronto group that was published in 2022, so the size of aneurysm matters a lot. Like if you have a giant coronary aneurysm,
So over a 30 years follow-up period, the regression rates are not quite happier. Only 50% will go for regression, rest 50 will have some adverse event. But if you have a medium to small aneurysms, at least 95% of them do quite well over a 30 years of follow-up period. So that's the utility of devising them based on the Z scores. This is another study from the same group that the acute events like thrombus, the risk of thrombus are at least 50% of them, if they develop thrombus, they do develop in earlier months rather than the subsequent years. So this kind of assessment was also possible by the risk scoring with the Z scores, and the risk is more with the higher Z scores rather than a lesser Z scores. If you take the regressions,
Which J score you suggest you to use as?
you are using Delar and Dana, sir.
So like DD can use the layer or
Yes.
because that is, but like in CMC also you use.
Yes, yes, sir. So there are more studies from China, Taiwan, and all. They also found useful with the Delar and Dada. They do perform well across multiple countries. So I think it is better for us also to use Delar and Dada. Yes, yes, yes.
Thank you. I think with this we'll break for lunch, and since we are running late, I would request everyone to have their lunch quickly, and we should try and be back by 2 o'clock. The next session is starting 3. Good afternoon, everyone. So we start the post-learning session. So for this session, we have Dr. Supreet Basu, who is an assistant professor in pediatrics at IPGM ER at SSKM Hospital, Kolkata. So he is going to talk on the importance of accurate weight, height, and body surface area for score assessment and case-based discussion.
So good afternoon. Already most of my slides have been covered, so I will again re-emphasize the importance of accurate weight, height and body surface area for Z-score assessment, because this is the first step of a diagnosis of coronary artery aneurysm by echocardiography. Because if we falter in the first step, if we take a wrong height or weight, then the subsequent body surface area will be different and the score and the abnormality will be missed or overdiagnosed. So why do we need Z-score? So measurement in normal children are affected by body size, age, sex and ethnicity. And Z-score standardize the coronary artery measurements, and it helps to classify the severity, whether it is a no involvement, only dilatation, small aneurysm, medium aneurysm or a large or giant aneurysm. And subsequently the treatment will also change according to that. We have multiple Z-score systems available. The commonly what we use is the DAY2, and the app we use is the paid Z-score, which gives the DAY2 2011 data. So suppose we have taken this patient who is a 6-year-old female with 25 kg weight and 120 centimeter height, and for the same measurement of the coronary arteries, we will see how these two, first is the Dallaire et al. And this is the Kobayashi et al. How these two changes. In case of the Dallaire et al., the 3.6 millimeter LMCA, the Z-score is 2.34. Whereas in case of Kobayashi, the same comes as a 2.73. So that comes in a small aneurysm. So the dictum is, whatever Z-score we are using, we should use the same Z-score in every visit. And as in the paid Z-score, the app that we use, the Dallaire et al. 2011 is the Z-score that they are taking. So why accurate measurement is necessary? Because weight, height and body surface area directly influence the Z-scores. Incorrect measurement may lead to misclassification of disease severity, and which impacts the treatment decisions and follow-up. Because a small aneurysm, medium aneurysm and giant aneurysm or a large aneurysm, the follow-up is different, the treatment is different, primary treatment intensification, uses of anticoagulants, everything will depend upon your categorization of the Z-scores. So, and what are the risk factors that lead to a measurement error? The most common measurement error we see was in the infants and toddlers. And when I was doing residency here, what happened in acute KD, the patient when came first, the height or the length of a 1-year-old child was 79 centimeter. And when in follow-up he came, the same height was 76 centimeter. So the height cannot regress. So there was some fallacies while taking the height in the first stage, because at that time the child is irritable, and in the winter season also there will be so much of layer of clothing and the weight will be erroneously high. So I will be discussing some 3 cases as I came to know about this topic. So prospectively what I did is, initially the body weight and length or height in our hospital is measured by a nursing official whenever the patient is admitted. So they have measured, and then I personally have measured the length by infantometer or height by the stadiometer and also the weight. So this was a case 1, it's a 5-month-old boy. It was a clear-cut case of Kawasaki disease, infant, and was diagnosed with aneurysms, already received IVIG from a government medical college, peripheral government medical college, and was referred to our center because infliximab was not available free of cost there. So the body weight was 4.5 kg, the length was 65 centimeter, and this was the coronary dimensions. So LMCA 6.47, LAD and RCA was almost giant, but it was below the 10 Z-score. And the height and weight they measured was 4.5 kg and the height was 65 centimeter. And when we measured the height by an infantometer, So the height came as 63. So only a 2 centimeter change in height, you can see already the Z-score has crossed the 10. So it's a large. So if we see the simple 2 centimeter change miscalculation in height can occur at any time if the child is irritable, or if the child is wearing anything, means cap, and you have not removed the cap. So this is a very common problem, and what is results is if it's a giant aneurysm, you are going to give anticoagulants. If it's a medium aneurysm, we are not going to start anticoagulants. So optimization of therapy and follow-up plan will change according to the Z-score. This is another child who was an 11-month-old boy. It was treated as a case of scarlet fever. PUO, scarlet fever, and a call was given to me as a different unit patient, and they suspected a case of incomplete KD or scarlet fever because they found a sandpaper-like rash, and the weight and the length that was measured from previously was 9 kg and 78 centimeter. Echo was advised, and echo was this 2.2 this, and the Z-score was like that, 1.92 and 1.99. And the treating team said, no, it's echo changes are not there, it's only not all dilation, it's within normal range, and we will not give IVIG. So again, when we recalculated, again recheck, so the height was 75 centimeter, and only a change of 1.1 meter square of body surface area change, you can see the Z-score as from normal, it has become dilated. And we could give IVIG to the patient, and the patient is now doing well. And then the third case is a 4-year-old boy diagnosed as a case of complete KD. The weight was 14 kg and the length was 100 centimeter. And we have this 1.5 Z-score, 2.45 and 2.14. All are dilatations. And again, when we recheck it, the weight was only 13.9 kg and the height was 98 centimeter. And we found that the LAD Z-score was more than 2.5. And what we did, we gave additional makes a significant difference in Z-score, and accurate weight and height should be measured at each visit to avoid errors in measurement that may lead to over or underestimation of coronary artery Z-score. Thank you.
Thank you, Supreet. So now the talk is open for questions, comments. So, any challenges you have experienced in calculating weight and height of an irritable child with Kawasaki disease?
Practically, sir, it is very difficult.
Yes.
Most of the time, the height and weight is not accurate. Most of the time. And the machine, there are so many factors.
Another thing is, once you give IVIG, once the baby stabilizes, then you can take a good height and weight. But another thing what we do now is, we do the echo myself in the PICU. There is the echo machine is there. So we give a bit of sedation, pedicloryl. So once but still it's difficult because we cannot take the infantometer inside the PICU. There is no infantometer inside the PICU, and once you manipulate the child, he or she will get awakened and then again cry.
So whenever we get the earliest marker clinical parameters of KD, we treat the patient
Yeah.
and wait for the child to get settled at least so that we can get a basic Z-score in a proper way.
I know there will be heated debate is coming, and Dr. Bagre has to say that Z-score should not be used. But what is important is that whenever we are measuring weight and height at the baseline, we are repeating echo every time. Possibly at that time also we should measure weight and height.
Every time we are doing an echo, before that we have to measure height and weight.
So because that would be an issue, because during the acute phase child is irritable, and most of the time we will not be able to take height, and it will be just a length by some measuring scale. So measuring tape. So once everything is stabilized, possibly we have to take accurate weight and height, possibly something like that. We have to send a group there so that they can take accurate weight and height.
And the same person has taken 3 minutes. 3 are different. Which one will be accepted? three measurement, three are different. Then how to come to conclusion? Which one is correct?
Average.
Average is, the question is that it has to be universal.
Basically, sir, weight, I think, no.
5 kg, 5 gram, 50 gram, 10 gram difference weight machine is there. It's again if it is battery operated,
Huh.
if the battery being weak, then the weight will also change. So much practical problem is there. Calibration.
Calibration. So, weekly calibration is a must for any weighing machine.
Every time more. That's the biggest problem.
Hmm.
I mean, the person who is doing eco, he will have to do those things. One is
Yeah, in my situation, I do myself in my room because they are sending to us for calculation now. So definitely in my OPD room, I have an inventometer, anthropometer, and a weighing machine. I myself take. That's a training given from the CMC Ludhiana. I never get trusted the nurses. So I myself take and then only do the echo.
Thank you. So we now move on to the heated debate. So we have debate topic that is Z-score based system is the way forward for coronary artery assessment in Kawasaki disease. So this is true, and we have to go for the Z-score based system. For this, we have Dr. Archan sir. So he's going to talk for coronary artery based Z-score based coronary artery dimensions, and followed by the field of coronary artery. First, I will ask Dr. Archan to speak on coronary disease.
Good afternoon, one and all. So, already there is a lot of discussion on Z-score. So, there is no doubt. I will start with the saying that there is no doubt that Z-score based system is the way forward for coronary artery assessment in KD, and why I will explain in next 15 minutes. So, there is no conflict of interest, and this is the overview. So, common sense. So, what is Z-score? Statistical definition. Z-score gives you an idea of how far a point is from the mean. And so, it's a measure of how many standard deviations a particular value is from the mean or median. So, this is the age-old conventional teaching in statistics. So, this is the bell-shaped curve. As the coronary artery diameter is a continuous variable, just like weight and height. So we don't depend on absolute value of weight and height. We calculate Z-score. So coronary artery diameter is no exception. We'll have to calculate Z-score. Otherwise there is no meaning. And it changes in children, it changes with body surface area. So yes, the answer is yes, definitely we should calculate the Z-score. So initially there were Japanese guidelines and they used to measure the coronary artery dimensions by absolute diameters. The diameters, I will not go into the details because this has been described time and again. So then they shifted to Z-score. So less than 2, anything less than 2 Z-score is taken as normal, 2 to 2.5 dilatation or ectasia, 2.5 to 5 mild, then 5 to 10 moderate, and more than 10 giant aneurysm. So what is the fallacy? Let's look at an example of a 6-month-old boy presented with persistent fever for more than a week. Examination revealed red cracked lips and erythema and peeling in perianal and perineal area. So when we did echocardiography, this is the score that we use, this is the PedZ app, and so when we did echocardiography of this child, look at the diameter of left anterior descending and left circumflex, 1.9 and 1.8. So if you don't use Z-score, there is every chance that you are tempted that these are normal diameters. But when you calculate Z-score, this will come under small or mild aneurysm. So the management will change. The primary intensification will change. The agents that we will use will change. Now come to the guidelines. What the guidelines have to say regarding the Z-score. So Japanese Circulation Society guideline 2008, initially there were absolute diameters. So less than 4 millimeter that was considered normal, and this relative diameter was also very fallacious. This is very subjective. In a child of more than 5 years of age, when you consider relative diameters, that is 1.5 times as compared to the adjacent segment. So there is a lot of subjectivity in it. So then also Japanese Circulation Society also moved from absolute diameter to Z-scores. Now the definition of coronary artery lesions as per Japanese Circulation Society 2020 guideline is described as Z-score from more than equal to 2.5, and it has been written in guideline that it is recommended to give priority to using this definition based on Z-score. So this was the guideline, and look at the language. Usually coronary artery internal diameter should be evaluated using the Z-score measured by echocardiography. And if it is difficult to evaluate the Z-score, then only evaluation by absolute diameter may be used. So these are the language. AHA from the very beginning, from the 2004, they have stressed on Z-score because of simple common sense. So use of Z-score better allows for evaluation of the severity of coronary artery dilatation by correcting for body surface area. Normalization of dimensions for body surface area as Z-scores based on regression equations allows for standardizations. And because this is a continuous measure, as I have already mentioned, and it is easy to compare within a classification system and allowed for comparisons across time and populations. So these are the different Z-scores. This has already been discussed, and the latest AHA 2024 guideline states that measurement of coronary artery luminal dimensions are normalized to body surface area using Z-scores. So routine use of coronary artery Z-scores has brought a level of standardization to quantification of coronary artery size, accurate weight and height measurements. Yes, we will have to measure weight and height, and there can't be any excuse. You are saying that child is irritable, then you are doing echocardiography on an irritable child, then coronary artery diameter may be also faulty. So height and weight are simple things. You will have to measure in an irritable child while you are doing echocardiography, and while you are measuring internal diameter, you are supposed to measure weight and height accurately. Otherwise echocardiography may be, the diameter of coronaries may be faulty. So this can't be any excuse. And look at the management and follow-up. The entire thing is dependent on the Z-score measurement. So we'll use dual antiplatelet in cases of moderate aneurysm, and we'll use anticoagulants, LMWH or warfarin in cases of giant aneurysm. So entire guideline, entire thing is dependent on Z-score. Now literature, what does literature suggest? So this has been described, this is the evolution of Z-score system, and they have mentioned that because of various body sizes of children with Kawasaki disease, coronary artery diameter requires normalization to the body surface area as Z-scores. So these they compared the Z-score system with the Japanese criteria, which is mainly dependent on the absolute diameter. So in this study from Japan, they took a huge sample size of 31,059 patients. They divided into 3 groups. One where Z-score was used always, the other group was sometimes Z-score was used, and the third group where Z-score was never used. What did they find? So the detection of coronary artery dilatations as well as aneurysms were more in the group who used Z-score always. So look at the adjusted odds ratio, which was more in the Z-score criteria, the group who used Z-score always. And so they concluded that the Japanese criteria, the Z-score criteria, were significantly more sensitive for the detection of coronary artery dilatations in all patients, regardless of age, and in coronary artery aneurysms in smaller children. The example that I gave, so in smaller children, especially less than or equal to 2 years. This is another article, improved classification of coronary artery. Here also they have shown that when they are using only Japanese Ministry of Health criteria, the detection of coronary artery aneurysm is much lower, especially in small coronary artery aneurysm group. Then the risk factors and scores for prediction of coronary artery aneurysm in Kawasaki disease. This was a monocentric study from Europe. So baseline Z-score they took as more than equal to 2, and here the same story, when the baseline Z-score was used as one of the risk factor, it could predict the development of coronary artery aneurysm at 1 month, 2 months, and 6 months. So patients with a baseline Z-score of more than equal to 2 are at higher risk for coronary artery aneurysm in the long term, so suggesting more and more use of Z-score based criteria. So this was again, they compared Z-score with the Japanese Ministry of Health criteria, and here you can see that when Japanese Ministry of Health criteria used, the detection of coronary artery aneurysm was much lower as compared to defined Z-score methods. So they concluded that JMH criteria underestimated the prevalence of coronary artery aneurysms as compared to the Z-score criteria. So quantitative assessment of coronary artery luminal dimensions normalized as Z-scores adjusted for body surface area should be recommended. And the highest variability in coronary artery diameter using Z-scores was by McCrindle criteria. So what is the clinical significance of Z-scores? Analysis of coronary artery aneurysm regression is also dependent on the assessment of Z-score. This was a multicentric study where 1,006 patients were taken, and you can see that smaller aneurysm, the regression rate was much higher as compared to the large aneurysm. So the regression rate for large aneurysm was only hovering around 20 to 30%. So coronary artery aneurysm regression was also associated with small coronary artery aneurysm, so which was measured by Z-score, age younger than 1 year, and onset of KD in the most recent period. Complications, how to assess complications, that is also dependent on Z-scores. 1,651 patients were included in this study from USA, and no complications were reported from children with small coronary artery aneurysms, and only 1 patient with medium coronary artery aneurysm experienced a cardiac complications. So this has already been discussed, I think. So all the complications starting from thrombus to coronary artery narrowing, the prediction of all these complications is dependent on Z-score. Now, importance of changing Z-score during the acute stage. We have seen in our practice here, when we used to do echocardiography on daily basis, change in Z-score can be an indirect marker for diagnosis of KD. So here you can see that Z-score, there was a Z-score change in LMCA almost 1. So this was had a statistical significant result. So mean interval between the initial and the second echocardiography was 1.8 days, and patients with greater intervals between the echocardiography showed a greater increase of coronary artery Z-scores. And though these Z-scores were well within the cutoff, but mere change in Z-score can predict the occurrence of coronary artery lesions. So of course there are limitations. So there are different studies going on, as we came to know today only. There are 3 different studies going on to develop Indian Z-score system, but as of now there is no published Indian Z-score system. But that can't be again an excuse for not using Z-score. There are a lot of Z-score system, we can use any one of them. So there is, yes, there is definitely an urgent need to develop Indian Z-score system, but till then we can use any one of the Z-score system. What we use, mostly we use Dallaire because of some reasons, because this has a very large sample size, and there are Z-scores for left circumflex also, unlike other Z-scores. So mostly Dallaire we can use because there is validation also. So we should use same Z-score in different follow-ups, and accurate weight and height measurements are necessary. So take home, should Z-score be used for assessment of coronary artery aneurysm in patients with KD? Yes. I hope there is no doubt after so much of discussion. Which Z-score to be used? The Dallaire should be used as it has values for left circumflex, sample size is more, and there is no specific Z-score for Indian population till now. The clinical significance of Z-score is limitless. Higher the score, more at the risk of complications. And importance of changing Z-scores during acute stage, yes. Changing Z-score in acute stage has immense importance as it can help in diagnosis as well as prediction of coronary artery lesion development. Thank you.
Arjun, that's a heated debate, of course. I think he has taken the debate topic to his heart. There are no prizes if you win. So, Dr. Arjun used So to speak against the motion, so we have Dr. Narendra Bagvi, who is an additional professor in the Division of Pediatric Rheumatology and Clinical Immunology at AIMS.
Thank you, Vignesh. Afternoon all, and thanks Sarchan for deliberating on the talk given. So I think I will dwell deep into this, and let me to specify how many of you are convinced with this is a panacea after Archan's talk. Some of might be, but let me go further. It actually is anathema. So to begin with, what is our goal of managing a child with Kawasaki disease? Probably we want early diagnosis, that's number one, and we want to reduce the cardiac morbidities and mortality. That is the goal for this. And we understand that this is at the extremes of age. By that I mean either younger kids, less than 1 year of age, or in older, even the kids who are greater than 5 years of age had more complications. And the group which is probably likely to cause this cardiac morbidity and mortality is giant aneurysms, and others probably are more disturbing for a while, create bit of noise but settles down eventually. So Z scores, I will dissect each of these, which my colleague Archan has just highlighted: diagnosis, therapeutic decisions, prognostication, follow-up. Okay, let me take to a ward. So Tanya was managing this case before she left this case to attend this meeting. So this is a 2-year-old girl who was presented with complaints of persistent high-grade fever, cough, coryza, some GI symptoms, lip cracking, and lymphadenopathy, and these were the figures. Fine. So you can see there was a edema, there was lip changes, there was persistent fever. So how many of you feel that this could be a possible Kawasaki disease? Perfect. Anybody want, forget about Z scores, anybody want echocardiography here? None. Convinced? Fine. Okay, so I want to reiterate the message that Professor Sujit Singh was giving, that for diagnosis of Kawasaki disease, it's absolutely a clinical sense, and there is no rocket science involved in this. And you don't need to bother Rakesh and come to PGI for that. So this is very, very important. That's absolutely a clinical diagnosis, and those who are not convinced, still we can have some of sets of lab criterion, because someone of you can say that it's an incomplete KD. And let's look at this. So if you could have looked at the investigations, this girl has anemia, this girl has hypoalbuminemia, ALT, WBC count of more than 15,000. Are you convinced with the diagnosis of atypical KD or incomplete KD? Let it call incomplete KD for surety. Dr. Devdatta? Perfect. Dr. Chattopadhyay? Thank you. Dr. Sajid Philippe, sir, are you happy with this? I want cardiologists to be around, but yes, as of now, they are. So I think we are happy with the label of incomplete Kawasaki disease. And if you look at the echocardiography, which probably Archan was highlighting on, Z score is only one parameter out of the few suggested things out of the echocardiography. Okay, so what I mean to say is that you may not always bank on the Z scores for evaluating echocardiography while evaluating a child for Kawasaki disease. Okay. Let's move on to, so I think everybody is convinced that for making diagnosis of Kawasaki disease, we don't need rocket science. It's absolutely basic MBBS level clinical sense, which is prevalent in everybody, which has to be. So there is no rocket science. Agreed? Okay. Now coming to the therapeutic decisions. What are you going to manage this child? IVIG, aspirin, and probably the age was a bit low. And as we understand that incomplete KD has a higher risk of developing more coronary artery aneurysms, some of you might think of giving or maybe intensifying your therapy at the first instance. Dr. Priyankar, your thoughts? Yes. Perfect. Okay. So for that, would you call your colleague Devdatta for that? Help you with Z scores, or would you use this? Perfect. Look at his fingers. So this is again very important. So look, I mean, as of now, we have diagnosed, we are managing the child, intensifying therapy, and this is for the intensivist. Ma'am, I think you are much worried about how to intensify. So as of now, it's very basic level clinical sense, okay? So no need of even for the workshops on echocardiography. Okay? So you diagnose the child, you classify them, severity, because the entire world knows there is a group of children who are likely to develop high aneurysms, and these are infants, and they are well validated scores which can probably guide you intensifying the therapy. Okay? Moving further. Okay, but I think since there is a lot of noise and the resident heard urchin, and I also got a bit swayed away and told her bring up with the Z scores. Is there any postgraduate around? Dr. Rakesh, your postgraduates I'm asking about. None. Perfect. Okay, in last 1 week, how many times you have used infantometer? Okay, how many of you have seen infantometer? No, be confident. It's a very important. No, I'm very serious. I'm making it in a jolly mood, but it's very serious concern. Because there are a lot of noise about this, but yes. Have you seen infantometer? When was the last event when you encountered that? Sorry? You are manipulating. Because every day comes within a span of 1 week. And I think the answer to this is don't get worried, because your consultant has already agreed that you are using the tape. Am I wrong? So now coming to this jokes apart, I think it's a very, very serious concern when using Z scores. We are often probably, and I think this has been highlighted by Vignesh and Archan and everybody, that this is very, very important, and that and it's really very tough, jokes aside, it's very tough actually to measure the height and the length in a child who is actually irritable. So probably, okay, most of the cardiologist view, any view of the cardiologist, how do we measure maybe in height or length? Yes, Dr. Devadatta.
I would definitely, as far as the height is...
No, I would know what exactly we are doing.
I tried in the OPDs...
Perfect, I got the answer.
Tried to take the height myself.
Perfect, thank you so much. But at the same time, I do understand that infantometer is a challenge. Dr. Tapas, would you agree with your vast experience? Okay, perfect. So this is the problem. So, but anyway, she wrote down these parameters, and I troubled her that I want Z scores or the Z scores, whatever you call that. Okay. So then, since I annoyed her, she brought this list, which one to use. So, if you look at this, the problem is generalizability. And I think there is a debate, and Dr. Vignesh has nicely highlighted that we cannot extrapolate everything. And those who might have done just since for the postgraduates, you might be knowing the charts used in nursery, the growth charts, intergrowth charts, and what's the name of that chart which starts from L? Yeah, so there is a huge variance in that versus the Indian, and the Indian charts which has been developed by Nodal Center at AIIMS, and maybe other centers have also used that, and they claim that probably you are over-diagnosing small for gestation age babies using those charts. The same thing holds true for the Z scores as well. The generalizability is an issue. So this is one thing that Dr. Vignesh was struggling with while he was trying to dissect his data. I don't want to, attempt trying this, but even this.
I deliberately avoided pronouncing.
Exactly, I tried, but that I tried half-heartedly so that everybody knows that this is the complexity involved in the Z scores. Okay, and in simple words, what this means. Heterodiscity is basically, you can see that when the standard deviation is too wide, and this happens particularly for more extreme Z scores and across a wide range of sizes. So this is very, very difficult, and I think we have learned this a lot from Dr. Vignesh, who is struggling. Actually, he's experienced this term. Despite that, he is not comfortable pronouncing this given the complexity of the Z scores. Okay, so now, let me give you some evidence that why there is a heterogeneity. So, relationship of echocardiography is definitely in this large series. They have shown that age, gender, race, ethnicity has a statistically significant effect. But some of you might claim that does it translate into a clinical implication? I will show you in a couple of slides. So for sure, there is a wide variability, and probably we are not convinced with the available Z scores or Z scores. That's why we are moving for developing new Z scores. Okay, so what are the challenges? So the challenge of the available Z scores. The Z score formula, as probably highlighted by Morgan and other colleagues, they are produced at various levels, and then the thing is that they produce the highest Z scores, for example, the Lopez one. And there are certain which does not give a credence to left circumflex and so on. So that's a real challenge. Okay, now come to the fact that, for instance, if the cardiologist is in a hurry, Dr. Amitabh, your views. Fine. So if you just miscalculate it by a mm, probably this is the reciprocation of this in the Z scores. Mm shift A in this would lead so much of change in the Z scores. Agreed? Perfect. Fine. So, and you also agree that you might be in hurry at times? Perfect. Thank you. Okay. So regression, now coming to, I have convinced you that probably it's very tough to do the Z scores, and to begin with, the fundamental problem is the weight estimation, and more fundamental problem is the length estimation, as told by my colleague Rakesh, how we are measuring the length. Okay, and this is universal. This is not restricted to this place. This is universal, including the resident which gave me the, Tanya, would you agree? How did you measure the length? Tell us honestly. So this is how we are measuring. So this is a serious problem. Now, okay, come to the overall, why do you want to engage in G scores or the coronary sizes? The end point is actually we want to look whether what is happening to these in future or down the line. So this is a regression. So if you look at the regression, it is post-primary intensification era, where we can see that in US cohort, they have shown that the regression rates of the coronary artery aneurysm has fallen from, prior to 2000 it was 50% or so, but with intensification of the therapy, it is rising to 91% or so. Okay. Okay. So now you can again see that again in 2010 and onwards, you can see all the small aneurysms are probably touching near normalcy, where the giant aneurysms, whether it was whatever 99 or so, I mean pre-intensification era, they are still persisting or may not achieve the normalcy. Okay. So now, what do you feel that, and now, for the postgraduates, whenever you read paper, this paper was cited by my colleague as well, Archan, but critical review of a paper is very crucial. So he showed this slide deliberately, showing that these scores are very important, but he probably deliberately missed this. You look at this. So the authors have classified the Z scores small, medium, large, but at the same time, there is another group, fourth group, unclassifiable, and they have specified the unclassifiable group as the group where Z scores are not available or the coronary sizes absolute diameter was given. And you can see that the overall regression rate was probably not much difference in either of the groups. Okay, so now this is complicated Z scores, and so over the time we have understood that there is an improvement in the outcome of the coronary sizes. So what do you feel? How many of you feel that the better outcome is because of better understanding of the Z scores, or because of the intensification of the therapy, or a better understanding of prior intensification of therapy, the first instance where probably we are taking some clinical parameters, for instance, age less than 1 year, for instance, using Kobayashi score, and we are keeping a threshold low for intensification of the initial therapy. What do you feel could be the cause of better outcome these days? Sorry?
Understanding high risk.
Perfect. Any other answer? Would you agree with her?
Just a thought that if I may.
Yes, sure.
Artery of 3 millimeter in an infant and in a 9.
I will come to that. Don't worry. Don't worry. I will come to that. I will come to that. Yes, exactly. Perfect. So don't go by the numbers. Now, yes, thank you for bringing this. So I will show you. So you know that Z scores are very, very important, but they are more important for the larger size vessels or the so-called larger aneurysms, okay? Because they are the ones which are really going to give you trouble. And just hold on for a few more slides, I will give you answer. Okay, so this is the fact. So small coronary aneurysms, whether it is 2.2, doesn't matter. Does it really matter in the real world? No, because at the end of the day, after IVIG, probably it will settle down. Dr. Priyankar, agreed? But what is bothersome is this one, the large coronary artery aneurysms. Okay, Dr. Suda, thank you so much. I will just summarize with your comments. Okay, Now, back to the case. The case 1, we saw that, okay, I told the resident that, okay, come up with the z-scores. So the problem is the variability, okay? And I'm talking about the variability based on the different z-scores which Morgan has already highlighted, okay? But I'm not touching upon the horrifying way in which she took the length or the weight, which all of us are agreeing. So negating that, if we take that in the standard way alone also, for instance, taking that in the ideal way, even then there is a huge variability wherein you may not treat the patient if this is the z-scores you are using, whereas you may aggressively treat if you are using this z-score. Agreed? So there is a huge variability in the z-scores which are on our table as on date. Okay. So now the diagnosis of the coronary artery abnormalities in Kawasaki disease, we use z-scores. Okay. The problem is, this is where I want to focus on, because the vast majority of the patients, I mean, once we treat Kawasaki disease, the diagnosis is absolutely clinical, agreed? And if we treat, the risk of coronary aneurysm is around 3 to 5%, okay? So, and among them also, only a chunk would develop into large coronary aneurysms. And this is the coronary artery aneurysms where probably we are more focused. Whether it is 3 mm, 6 mm, 8 mm, I am come in a while. Okay, this variability is greater, so the Z-score variability is more during the, they are less effective while assessing the large sizes coronary aneurysms. As shown by Dr. Suda's slide there, once the Z-scores are, absolute diameter is more than 8 mm, probably they sway more. So now look at this. So this is coronary artery aneurysm measurement and Z-score variability in Kawasaki disease. What they did is, the authors took two groups. Group 1, the RCA and LAD Z-scores were 1.5 to 3, wherein the group 2, the Z-scores were 1.5 to 3. There is some issues with this, sorry. So the calculated Z-scores is each of these three formula, whatever formula they use, were different in the clinical management. You can see that in the group 1, 22%, and group 2. Group 2 is actually which is more than 3. Sorry, there is some typo there. So the Z-scores which were more than 3, the variability in calculating the Z-scores were 50%. By that you mean it was just like tossing a coin. So, whereas in a small coronary group it was 22%, but we are actually not bothered in small coronary aneurysms. Reason being, as I have shown in the previous slide, that most likely they are likely to regress in times to come. But where do we need more accuracy? We need more accuracy in the giant aneurysms, and where probably this is 50%, like tossing a coin. So they are not doing great. Okay. And I think by this time, this slide is just to reflect that the effort is ongoing and we are not satisfied by the Z-scores which are available on the table as on date. And that is why we probably are searching for what Dr. Vignesh is doing. Okay. So, Dr. Archan would say that, okay, then why do the recommendations, and he will emphasizing on the recommendations. But again, when we read recommendations, we have to read the line. And I have deliberately not highlighted or underlined any point, because I want every line, every word to be read carefully. So as far as small aneurysm is concerned, I think everybody would agree that most of them would regress and may not be of a real concern. The real concern would be for the medium or the large giant aneurysms, and for that, if you read it carefully, they would say that you use Z-score and absolute dimension of less than 8 mm. By that, probably they mean that the word is and, not or. Mind it, the word is and not or. Reason being, they probably have given the due cognizance of the fact that there is a fair likelihood that this may be misinterpreted or erroneously underestimated, and that is why they are assigning here as and word. Whereas you come to the large, they are writing or with the absolute dimension of more than 8 mm. So this is the guidelines if you interpret it very meticulously. Moving forward, Japanese criteria. So this is what is important is, okay, Z-scores they have mentioned, as Archan was highlighting. I could not read the word, okay, it is difficult to evaluate by Z-score. If it is difficult to evaluate by Z-score, how many of you agree that it actually is difficult? You all were saying that it was difficult. No one has measured height properly. So actually speaking, it is difficult in all practical scenarios. Don't agree? Okay, fine. Okay, you will get your time. Don't worry. So actually it is difficult in all scenarios, and for that scenario we need to manage the child. And for managing the child, I think this is the best way forward. And this is the small aneurysm, simple, 3 mm, or inner diameter less than 4 mm, medium less than 8 mm, anything more than 8 is giant aneurysm. And then again it is important that Z-scores, it is overestimated if defined by absolute values in children with 5 years, but at the same older year, but at the same time we have learned that they are not, the Z-scores, available Z-scores are not doing great for older children or giant aneurysms. So there is a huge problem there. Okay, so I think I have discussed on diagnosis. We don't need Z-scores. For prognostication, as of now, everybody was convinced, reasonably convinced that we don't need Z-scores. We manage it. We can give infliximab. You were struggling with a Z-score of 9.9 and 10 Z-scores. I don't, honestly speaking, agree. Would the management change whether it is 9.97 or more than 10.2 in one of their first case? I don't think so. Okay. So now coming to the follow-up. Do we need follow-up? A very interesting paper. So what they have done is, in around 1200 patients, who had a baseline Z-scores of more than 2, and that is around 26%, meaning thereby that these patients, and at 2 weeks 5% had a baseline Z-scores of 2. What they did was they followed these patients 6-week echocardiography examination. What happened to them? So they were essentially those who had a score of 2 to 2.4. See this figure, 98.3 of these patients at follow-up at 6 weeks had essentially normal Z-scores. Okay, only 8 patients had some abnormality, and out of that, around at the last available follow-up, which varies from 6 months to a year, 99.7% normalized. So the message from this paper is probably in children with, I'm talking about uncomplicated Kawasaki disease, which is the most common one. I mean, which has a Z score, not giant aneurysms. They excluded the patients with giant aneurysms. But in the garden variety Kawasaki disease, most of the patients would benefit from the routine IVIG, and at 6 weeks echocardiography, usually everything is normalizing. So what is the key message? New abnormalities were rare at 6 weeks in the garden variety of Kawasaki disease, and there is a limited benefit of 6 weeks echocardiography imaging in patients with uncomplicated Kawasaki disease. So probably in one way, we may not actually go for a 6-week echocardiography given the cost constraints of the echocardiography with Z-scores in place. So that is one of the message from this paper. Okay, so summing up, diagnosis, probably we don't need it. Therapeutic decision making, we don't need it. Prognostication, follow-up, okay, just not to dishearten my colleague, we may use it. 3.5% will develop aneurysms if treated timely, only 3.5%. And among them, this chunk, I understand the fact that they can have a very disastrous course, so we have to be very meticulous in that. But that group will be only giant aneurysms. So, and for measuring that, the absolute size may be considered. Is good enough, is equally good or bad as Z-scores as on date. And even if you're not convinced, I've taken permission of Dr. Suda for this, and you look at this. Again, coronary artery aneurysms with the maximum size, diameter of more than 6 mm and Z-scores of 7.5 at 2 months. I want to emphasize the fact that the absolute size is equally good as compared to that. And those who were listening to ma'am's talk yesterday, the final summary was increased risk of coronary events were in the children who had an absolute size of more than 6 mm if the body surface area is less than 0.5, and in kids with more than 8 mm of diameter if the body surface area was more than 0.5. Can I have your concurrence on this? Thank you so much. Okay, so I will rest my case here. Yeah?
You agree body surface area is important?
No, yeah, absolutely. I agree, but I'm not taking G scores. Sorry? That's master's view. He has disappeared.
We had such a heated debate. So we have both the talks open for discussion now. So you want to give any rebuttal, Dr. Archana?
Thank you. So I think the topic was on Z-score is the way forward for coronary artery assessment. It was not regarding the diagnosis of Kawasaki disease and all. So I think my senior colleague has mistaken about the topic. The topic was on specifically mentioned the Z-score is the way forward for assessment of coronary artery, not for diagnosis of Kawasaki disease, not for treatment and all. And so ultimately he agreed that body surface area, and so ultimately everything was like round. So everything came back to Z-score. And he has told that for giant aneurysm, it was the Z-score was misleading. But the management will change if we miss the small aneurysm also. So one is intensification, one is no intensification. If we miss small aneurysm, then there will be no intensification. If we detect the aneurysm, anyway the aneurysm will regress, but some percentage will remain, and it will depend on the intensification. And giant aneurysm, at the most, it can be treated as medium aneurysm. So anticoagulant, there will be difference, but later on anyway, we'll do CT angiography. So it will cover the thing, and then later on we can add anticoagulation. You want to settle that? You want to settle on the CT? Yes. So giant. So now I think I have taken the topic very, very meticulously, and I have read the topic very, very in depth. The topic, I am talking about the topic. And topic is assessment of
Coronary.
coronaries.
Z-score is
Why do you
the.
want to assess? Not to bother everybody, not the patient. We want the outcome, we want the diagnosis, and that is where it's used. And I think in none of these, it is making great difference. And by using the absolute criteria, I think given the, and it's on a serious note, I will be happy to have comments from senior city hall, that where probably given the tactical problems, including initiation of the height measurement, and the ability of the Z-scores. I mean, if you want to spread the message that KD is common, first of all, if we play around too much about Z-scores and echocardiography, as Professor DC was highlighting in the morning, that probably it will create more of stress among the laity that, okay, we can't diagnose this can't happen. So make it simple, right? It's simple. So, and I think it makes sense, because else you will create an apprehension. First, you will create an apprehension by echocardiography, and the second apprehension by Z-scores. So, in simple words, if we can make the diagnosis, which is absolutely clinical, as would you agree, and for that, probably in realistic world, we should make the thing simple, and we should not, at least to begin with, should not give much weightage to this, though for a set of patients, I do understand that they would need intensification, which again can be decided irrespective of even echocardiography, because end game is to prevent the cardiac morbidities. And for those, unfortunately, who develop these probably serial echocardiography and cardiologists, of course,
Okay, so now we have take comments first from Dr. Rakesh.
First of all, we have a big round of applause for the both. Debate. This is very important because it's a debate we do where we have controversies. So there is a lot of controversies, and we deal with these controversies. And
do you have price for this?
Price will be in front of me, sir.
So one more thing is that because ASA 2024 scientific statement, when they have come with a score, sun score, and in that regarding the treatment intensification, one of the criteria is if G-score at admission or at initial evaluation is more than 2.5. So where the value of G-score is very important, because it may not be that whether it's a small aneurysm or medium-sized aneurysm or giant aneurysm, which would be there at 2 months, which Madam has also highlighted. That long-term prognostication or long-term evaluation, long-term severity stratification, but at baseline, more than 2.5 Z score would help in a treatment intensification. So the treatment intensification would be decided based on the G score based severity assessment. So we have to use G scores, but with lot of caveats, and possibly because the new Z scores where those have been done on a large population database and multi-ethnic populations, those we can use and with accurate weight and height measurement.
Dr. Devi.
Sir,
Please come to the
Sir, 2 points. Firstly, that I think we all agree that in the long term, what we all want to know is how the prognosis is, how is the outcome. So, when it comes to diet aneurysms, there are two categories. One is the ones which have a Z score of more than 10, but the absolute size is less than 8 mm, and the other category is the absolute size is also more than 8 mm. So, has anybody compared the outcomes in these two? Because from whatever we have learned from Sir, so this is that the ones which have an absolute dimension of 8 mm, more than 8 mm tend to do worse on follow-up, whereas the ones which have a Z score more than 10 may regress to normalcy, but the ones which have more than 8 mm will be very rarely regressing back to normalcy. So has somebody studied this? I want to ask both the sides. And secondly, sir, my question would be to Sudham also that Japan is a place where they have the maximum experience with tau cytosis. Why over there they are still stuck to the absolute dimension rather than Z score in their guidelines? Why they have over the years focused more on the absolute dimensions as compared to the Z scores?
Dr. Sudham, you want to comment? Do you use coronary artery Z scores?
Yeah, so we can ask ma'am. Do you use Z score or absolute dimension?
एक माइक है मैम को देना है वो वाला दे दीजिए
वही पकड़ा I think the question has to be
I prefer the absolute first.
Actually, they have given a difficult topic for me. So this various Japanese Z scores like Kobayashi was from Japan, Kurutobi was also from Japan, and other Asian countries like Taiwan, China, they also has continuously proposing new user scores, and there are discriminations and variability in each of those scores, but dimensions were same. So we are not settled with the uniformity of Z score even in their own place. That's a real trouble for the clinicians who practice. In that way, till now we are not settled with that Z scores, and I don't think so in few decades also we will settle these things effectively. And it has cumbersome like in measuring Z scores and all.
Do you use Z score or?
no, first ask high.
So I use Z scores as like Sir was saying,
Okay,
it's more important for infants.
Dr. Devadatta.
Nice discussion, and considering all the pros and cons, still I would say that if it is a small infant, since we are very worried about the infants having the KD and the sequelae, if it is a small infant, especially below 6 months, then we should use the Z-score because we can't depend on the absolute values. Even 2.5 would be a small aneurysm for a small infant.
Thank you. So now probably we can have a voting then. So how many would continue using Z score in children with coronary artery, in children with Kawasaki disease? Okay. How many would not use coronary artery Z score for managing patients with Kawasaki disease? Okay. Giving a difficult topic.
No, I think you are framing the question well. No, let me frame the question.
Yeah. I think the question should be, how many of you would agree that the Z score has to be used meticulously? That's the first question. Fine? There is no doubt. Okay. But how many of you agree that as on date, we don't have standard set in terms of the generalizability of the scores which are available with us and the way we are actually using it. What we are doing day in, day out. So I think everybody would agree that what we are doing is not the right thing. So in that context, given the complexities of this, I am not debating Z score, the end result is coronary dimensions. So how many would agree that assessment of coronary sizes is important for management of Kawasaki disease? I think everybody would agree on that. And sorry? No. So now, by Z score or by absolute diameter. To make it simple, again, I am emphasizing on the fact that you have mentioned that 2.5 is important, the baseline to intensify or less than 6 months, but in other way around also trying to make the life simple. And in that, if 6 month baby with Kawasaki disease comes to us, we would intensify irrespective of the Z scores. Would you agree? Sir, I will come the last comments from Professor Sujit Singh, but it's an important question, debate, that if we make the thing more complicated, probably we will missing the things too much. But if we use more of a clinical sense and the available scores, probably outside, even if in absence of echo also, with all due respect to cardiologists, we should not hesitate to intensify the treatment to prevent the long-term complications. That is the key, probably, conclusion from this debate. And the second, of course, if we are encouraging echocardiography, as it has been highlighted, there is a lot of problem. So at least let someone mention the absolute diameter also. So again, it can serve some purpose, if not the best.
Thank you, Dr. Nafi. Again, a round of applause for the wonderful debate.
So for want of time, we'll have to cut the discussions short, but thank you for the insightful debate on the Z-scores. And now that we've added a new word to our vocabulary, heteroskedasticity, we'll move on to another interesting talk. So for which, to chair this talk, may I invite Professor Sujit Singh, sir, our head and mentor, to please chair the session.
So from the controversies regarding the Z-scores for coronary, we now move on to another topic, and that is the involvement of the myocardium as such in Kawasaki disease. And Dr. Suda will first discuss the role of 2D echocardiography for myocardial assessment, not coronary assessment, myocardial assessment, something which is not often highlighted.
Mr. Chairman, ladies and gentlemen, I am pleased to speak on this subject at this session. Acute vasculitis due to Kawasaki disease can cause coronary artery lesion with short and long-term myocardial involvement. As you know, acute KD involved cardiac lesion selectively. Myocarditis with unconsciousness in the early days of acute phase occur in patients more than 4 years old. In a 5-year-old boy, his LVEF was decreased. Sorry. In a electrocardiogram showed tachycardia and ST depression of chest lead. The left ventricular ejection fraction improved within a week. Reference about cardiac valvular lesion caused by Kawasaki disease. TR was reported. At 1 month and 1 year after Kawasaki disease, the age at the onset of Kawasaki disease was significantly older in patients with moderate TR than patient with none or mild TR. TR may be related to ventricular dysfunction due to myocarditis. In the right period after KD, the outcome in patients after myocardial infarction is related to LVEF. This graph shows the survival rate in patients after coronary artery bypass grafting. The 5-year survival rate, depending on the preoperative LVEF, is shown. The 5-year survival rate in the poor group was 72%. It was significantly lower than that in the preserved LVEF group. I present the previous study use of two-dimensional SPECT tracking echocardiography. Echocardiography to evaluate left ventricular wall motion in patients with coronary artery occlusion due to Kawasaki disease by Tanabe and Hayama. Background is two-dimensional SPECT tracking echocardiography, 2DST, is used to assess global and regional wall motion and dyschrony of the left ventricle. We evaluated the utility 2DST for assessing left ventricular wall motion in patients with coronary artery total occlusion, CAO, or segmental stenosis due to Kawasaki disease. We reviewed the clinical features, 29 KD patients, male 21, female 8, with CAO who underwent 2DST in 2011. Age at the 2DST ranged from 2 to 36 years, with a median of 27 years old. Interval from acute KD, 1 month to 29 years, with a median of 22 years. 1 vessel occlusion, 60 patients, 2 vessel occlusion disease, 13 patients. Control is 12. 10 among the 29 patients had previous myocardial infarction, and 15 had undergone coronary artery bypass grafting. The Philips IE33 scanner was used for evaluation. We recorded the short axis view of LV at the level of papillary muscle and measured circumferential strain, CS, by using QLab software. To assess dyschrony, we calculate the standard deviation of the time from QRS to peak strain, time to peak in segments. Further, global circumference strain, GCS, is calculated as mean of each segment, and peak strain of GCS indicates the degree of circumferential motion. This picture shows the distribution of coronary arteries and myocardial segments. This is the result of normal pattern. Time to peak was almost same. Circumferential strain is shown in a 21-year-old male with localized stenosis of the LAD. GCS decreased and time to peak of each segment spread. circumferential strain is shown in a 23-year-old male with occlusion of the RCA and LCX. GCS is decreased and time to peak each segment spread. We see the result of peak strain of GCS. GCS decreased in the occlusion group. The number of occluded coronary artery was related to GCS. We see the result of ST of time to peak. The number of occluded coronary arteries was related to ST of time to peak. Longitudinal strain is shown in a 24-year-old male with localized stenosis of the RCA. GLS is decreased and time to peak of each segment is spread. We see the relation of time to peak and GLS, GCS in the RCA. Time to peak was delayed in the occluded group. We see the relation of time to peak and GLS, GCS in the LAD. Time to peak was delayed in the occluded group. In conclusion, this synchrony of the LV by 2DST was detected in patients with CAO due to KD. 2DST is useful in the non-invasive and objective assessment of regional wall motion after KD. In the last, I present a case presentation. An 45-year-old male had acute myocardial infarction and cerebral infarction. He was diagnosed as measles at 6 months old. After 2 weeks, acute MI and cerebral infarction occurred. Chest X-ray and his electrocardiogram are shown. CTR is 50% and QS pattern in chest rate was found. Two-dimensional echocardiography are shown. He underwent follow-up MRI. Segmental stenosis was detected. Accidentally, thrombus in the apex of left ventricle was detected. Warfarin was added to aspirin. The size of thrombus was decreased. Thrombus was also small in two-dimensional echocardiography. In summary, left ventricular ejection fraction affects the outcome in patients after Kawasaki disease. 2D echocardiography is a convenient and useful method of myocardial assessment with improvement of equipment. Thank you for attention.
Thank you, Dr. Suda. So, Dr. Suda's talk is now open for comments. Myocardial assessment is often not given the importance that it deserves, and especially when these echoes are done by a cardiologist who is not that familiar with Kawasaki disease. So if it is done by adult cardiologists, these are aspects which would generally not be covered. Dr. Dev.
Study showed that it was done in patients of Kawasaki disease with sequelae like an aneurysm or stenosis. But what is your experience of this kind of strain analysis in KD patients without any coronary artery disease in the follow-up? And secondly, in the acute KD cases.
Yeah. 2D dimensional echocardiography. Yeah.
Cases of acute KD.
Yeah.
Role of strain analysis or hypertrophy.
Yeah. Within 1 year, yeah, to 2 months and 6 months and 1 year. After that, each year until 5 years.
Have you found abnormalities in the longitudinal or circumferential strain in children with KD without coronary artery disease?
In the previous study, Tanabe and Hayama, I don't know about that. Sorry.
Thank you very much.
Thank you, ma'am, for your talk. I have a small announcement to make. Before we break for tea, after this discussion, we'll have a small group photograph quickly in 5 minutes, just before we break for tea. So for the next session, to chair the next session, I will invite Dr. Rakesh Pilania sir, who is a consultant in Allergy Immunology Unit, and Professor Amit Rawat sir, who is also a senior consultant in Allergy Immunology Unit at APC.
Pediatric rheumatologist at London Institute of Medical Science, and these are past alumni, and he will be speaking on the 2024 AHA scientific statement. What is the updates for us to remember? Johnson.
Thank you, Chairperson, for your kind introduction. Today I will be talking on the American Heart Association 2024 update on the diagnosis and the management of Kawasaki disease. So this update has recently been published in the month of November 2024. Previously, there was a scientific statement made by the American Heart Association in the year 2017. So after a gap of around 7 years, this update has been published. So what are the updates which they have made with this new scientific statement is the thing which I am going to talk in the coming few minutes. So Kawasaki as such is the leading cause of acute heart disease in children, particularly in developed countries, and nowadays we also realize that it may be the leading cause of acute heart disease in developing nations also. So they try to make some update regarding the diagnosis, various cardiac imaging modalities, and how we are going to manage in the long run a case of Kawasaki disease. As such, the diagnostic criteria remain unchanged. However, they made a very emphasis on regarding the early diagnosis of Kawasaki disease, which will really help in reducing the risk of coronary artery abnormalities. So Kawasaki disease diagnosis, we all know, fever for 5 or more days, along with 4 of the 5 clinical features. However, we should always try to make an early diagnosis, that is, by 4 days of fever, or if there is an expertise in this disease, then by 3 days of fever, particularly if the 4 clinical features are met out of those 5 clinical features. And when we suspect a case of Kawasaki disease, we don't have a diagnostic investigatory markers. However, we have to do complete hemogram, inflammatory markers like ESR and CRP, liver and kidney function tests, routine urine examination to look for pyuria, then ECG, and of course, echocardiography. Again, regarding the diagnostic criteria for incomplete Kawasaki disease, it remains unchanged. It's said that there has to be a prolonged unexplained fever. Along with that, there has to be 2 to 3 out of those 5 clinical features. And in infants, unexplained fever for at least 7 days, we have to think of Kawasaki disease. Along with these clinical features, if some of the investigatory finding, like high inflammatory markers with raised CRP and the raised ESR, with at least 3 of the following investigatory findings, then we should consider as a case of Kawasaki disease. So there has to be anemia, neutrophilic leukocytosis, thrombocytosis, hypoalbuminemia, raised ALT, and the pyuria. And when we do echo, we also can rely on the diagnosis of Kawasaki disease by doing the coronary artery, measuring the coronary artery dimensions. So if the Z-score of the left anterior descending or the right coronary artery is more than or equal to 2.5, then we can think that this is a case of Kawasaki disease. Just stop. Okay. Or if other features which are associated with Kawasaki disease, there is decreased ejection fraction, presence of mitral regurgitation, or presence of pericardial effusion, or Z-score is at the level of just dilatation, that is 2 to 2.5, then also we have to think that this is a case of incomplete KD. So all the cases of Kawasaki disease, we have to give intravenous immunoglobulin at 2 grams per kg over 8 to 12 hours, and we may go slower if there is a presence of shock or features of myocardial dysfunction. Along with that, we have to give aspirin at inflammatory dose. Nowadays, the moderate dose is more preferred as compared to the higher doses. So 30 to 50 milligram per kg per day, and change to antiplatelet dose of 3 to 5 milligram per kg per day after a febrile period of 2 to 3 days. But the real update is here. So we can risk classify as a high-risk Kawasaki disease, which are more prone for developing coronary artery abnormalities. So they have put these 2 conditions as a high-risk KD, who are more prone for developing coronary artery abnormalities. So child of less than 6 months of age, and the coronary artery dimension of Z-score more than 2.5 at the baseline echo in the LAD and the right coronary artery. So if these 2, out of these 2, if any of these 2 are there, then we should consider as a case of high-risk KD. In such scenario, not only the initial therapy, we have to intensify the initial therapy even before the development of all those aneurysms. So after giving your therapy, we have to keep on repeating echocardiography every alternate day or so. And also look for reappearance of fever after 36 hours of IVIG treatment. And if there is recurrence of fever or persistence of fever, we call that as a case of IVIG resistance. Now, if such scenario is not there, then we can discharge on antiplatelet therapy and follow up echo after around 1 or 2 weeks. And advise that no live vaccination for at least 18 months, 11 months. So how can we intensify the therapy, when there is a high-risk KD or in a scenario where there is IVIG resistance? Various anti-inflammatory therapy can be used. We can use prednisolone, initially IV for 5 days, followed by oral prednisolone, slowly taper over next 2 weeks once CRP become normalized. Either we can use methylprednisolone at intravenous formulation for 5 days, followed by oral prednisolone, and gradually taper over next 2 to 4 weeks. We can also use TNF inhibitors, infliximab, at a dose of 10 milligram per kg, or another TNF inhibitors, that is etanercept, can also be used. So any of these four anti-inflammatory therapy can be used for intensification of the therapy or for IVIG resistant cases. There may be some scenarios where even after intensifications or even after giving IVIG, your coronaries keep on dilating or fever is not subsiding. In such scenario, we may use cyclosporin, anakinra, IL-1 antagonist, or second dose of IVIG, or sometimes or very rarely we may use cyclophosphamide. So along with those anti-inflammatory therapy, we have to use antiplatelet therapy. Now, giving antiplatelet therapy depends upon the size of the aneurysm. So for small aneurysm, single antiplatelet therapy with low dose aspirin is enough, while for medium aneurysm, we can consider using dual antiplatelet therapy, that is low dose aspirin along with clopidogrel. However, for large aneurysm, we have to use dual antiplatelet therapy, and even beta blockers can be considered. Then we all know that in patients with large aneurysms, there is always a risk of thrombosis, both in acute as well as in chronic phases. So we have to use some anticoagulants. So we have been using warfarin or low molecular weight heparin for this, and warfarin as such very difficult to monitor and very difficult to maintain the INR at 2 to 3, particularly in infants, lots of food and drug interactions. And low molecular weight heparin, we have to give in 2 doses subcutaneously, so very cumbersome for a pediatric patient. So it has come a long way, and we know that direct-acting oral anticoagulants, that is DOACs, they have low risk of bleeding and also low risk of thrombosis. And we don't need to monitor much when we use DOACs. And there is also few drug and the food interactions. So there has been various studies regarding the drugs in pediatric cardiac disease, edoxaban. There is also use of apixaban, and they found that there is no such adverse effects of bleeding, and thrombosis was also well prevented by using the drugs as anticoagulant therapy in pediatric cardiac disease. So this is also recommended as an alternative to the previous low molecular weight heparin or warfarin in the case of Kawasaki disease. And in 2 scenarios, we are going to use anticoagulant therapy. The first one is the large or giant aneurysms, which is still persisting or is currently present. And in the second scenario, we can consider using anticoagulant, that is the large or giant aneurysms, which has regressed up to the medium aneurysms. So these 2 conditions, we can consider using anticoagulant. But if the large or giant aneurysm had regressed to the small aneurysm, then we have to stop using anticoagulant therapy. What about statins? They also, we all know that statins is an antioxidant and also have some anti-inflammatory effects, and so it promotes endothelial cell homeostasis and blocks endothelial to mesenchymal transitions. However, the use of statins, there is no such RCT regarding the use of these medications in acute phase to improve the clinical outcomes. So there was a phase 2 trial of atorvastatin used in acute Kawasaki disease, and they found that there is no such adverse effect, and the pediatric patients are well tolerated. However, the complete guideline regarding when to use, what to use, it has not been set in this update yet. Then coming to the long-term management, we know particularly the giant aneurysm patients with Kawasaki disease, they need a long-term surveillance. So we have been using echocardiography as the primary non-invasive method, and it has been always been emphasized by our previous speakers that we have to use the same Z-score equation, same Z-score classifications for the follow-up of our patients. The new thing which is really coming up for the long-term management is the use of coronary CT angiography. The advantage of using this coronary CT angiography is that they are able to detect both the proximal as well as the distal coronary artery abnormalities, and they will be very clearly able to detect the thrombus in the coronary vessels, and also it can also be used in acute coronary syndrome. Another mode of imaging is the cardiac MRI, where there is no exposure to radiation, and we can really evaluate the cardiac function using cardiac MRI, and tissue characterization is better as compared to coronary CT angiography. And lastly, the invasive angiography can also be used for the long-term management or long-term follow-up. But this, as being an invasive thing, we have to use only when there is a when we consider doing percutaneous revascularizations. So in the follow-up, when to use CT coronary angiography depend upon the size of the aneurysms. Larger size, we have to take the baseline earlier as compared to the smaller aneurysms. So large aneurysms take a baseline CT coronary angiography at around 2 to 6 months, then we can follow up more frequently. Now, as the size of the aneurysm regress, we have to follow the next suppose large aneurysm regress to medium aneurysm, then you can decrease your frequency of doing CT coronary angiography. Likewise, we have to change our strategy of follow-up. So similarly, how frequently we have to follow them up, how frequently we are going to do CT angiography, or how frequently we are going to do echocardiography depend on the size of the aneurysms. Larger the size, more frequent we have to monitor. So after 1 week, then 6 weeks, then every 3 monthly we have to keep on monitoring, particularly for the large aneurysms. Whereas if there is no aneurysm at baseline, then we can stop monitoring by around 4 to 6 weeks. And patients with coronary artery aneurysms, they are really at a risk of stenosis and obstruction in the long run. Particularly, it holds true for Z-score more than 10. And in the 10-year follow-up, luminal narrowing occurs in more than 50%, whereas thrombosis occur in around 18%, and major cardiac complications occur in around 14%. So we need to assess the inducible ischemia. The most common thing which we can do is by doing stress cardiography. So stress cardiography can be done by doing an exercise-induced stress echocardiography, or if the cell is very small for doing exercise, then we can use dobutamine medications. Another way of assessing inducible ischemia is by cardiac MRI stress imaging, where we don't use any radiation, and it's also helpful, particularly in the child who are too young for doing exercise. So two things can assess inducible ischemia. Similar to the frequency of doing CT angiography, inducible ischemia assessment also depend upon the size of the aneurysm. Larger the size, more frequent assessment is warranted. So to conclude, this 2024 American Heart Association scientific statement really emphasizes on the need for the early diagnosis, even though the diagnostic criteria remain unchanged, and they really classify that some patients, particularly those less than 6 months and dilated coronaries, which we have to consider as high risk, and we have to give an intensification of therapy. Then direct oral acting anticoagulants, they can be considered if it's having a real problem with using low molecular weight heparin and warfarin in the large coronary artery abnormalities. And at last, long-term surveillance is really necessary, particularly with those patients who have large aneurysms. With this, I would like to conclude my talk. Thank you.
Thank you, Dr. Johnson, for this talk. So basically, if I can summarize 2 or 3 things out of your talk, that we can diagnose a KD on day 4 of fever, and day 5-day fever is not 100% nowadays, because as per the guidelines, if there is a complete KD is there, that you can diagnose in a day 4 of. Second thing is that regarding the treatment, so it is in second line what we use, because in second line previously it was that second dose of IAC, infliximab or cyclosporine or steroids. But in 2024 American Heart Association statement, possibly they have more preferred anti-TNF therapy or steroids than second dose of IAC, because he has shown that if it is refractory to infliximab or steroids, go to second dose of IAC. So which we are doing, I think, in India from some time, because of the several reasons, and one of the reasons was economic reason, because second dose of IAC would be more cost effective than using, would be less cost effective than using infliximab. And third thing is, if I can take from this guiding statement, is that CT coronary angiography, they have given a weightage and
first time they told that CT coronary should be used more frequently, and they have talked about the distal coronary aneurysms in this aspect. So and if there are any comments or questions, we can take one or two.
Is there any particular age cutoff they have
Use
kept?
micro, because it's recorded.
Is there any particular age cutoff they have kept for the use of drugs in the patients or other cases?
They have not mentioned the age limit. They just now this is also in study in Kawasaki disease. Post-marketing surveillance is still going on. So they don't mention directly that we can directly start using drugs now. Maybe in the next upcoming statement, they will be able to be very bold enough to say that drugs can be used instead of warfarin and the low molecular heparin. No such age cutoff has been mentioned for time being. Thank you.
Can I request everyone to come near the stage so we can take a group photograph?
इसके बाद
इनका ये
इनका सर का
हाँ,
सर
उनका।
आगे चेंज कर
एक मिनट इसका कहाँ गया? ज़्यादा पीछे चला गया। डॉक्टर अमन गुप्ता वाला है।
यस सर जस्ट आफ्टर टीवी
किसका चेंज करना?
वो जो पहले हमने डाला था ना
किसमें?
केडी डोएक ने डाला था जो
नाम बताओ किसका है, नाम किसका है?
अविनाश सर का।
अच्छा इनका सर का है।
अविनाश सर ने
रखा है मैंने, इसको मैं निकाल देता हूँ पहले।
इसको हटा के आई थिंक द बेटर वंस आर इन जमान सर
इसको कर दो कॉपी। कौन सा है?
मेरा नहीं है, मेरा तो इसमें है।
तो ये किसका है अभी? आपने
ये सर को चेंज करनी है अविनाश सर की।
अविनाश सर तो ये खड़े हैं,
नहीं,
इनके
मैं
तो
नहीं।
इनके हाथ में
नहीं,
है।
मेरा नाम
अच्छा
अमन
सॉरी
है।
आप तो अमन है। सॉरी अविनाश सर।
ये है ना सर का।
हाँ, तो ये पहले था।
लगाना है। अरे
अच्छा
उन्होंने कुछ चेंजेस
चेंज किया होगा।
सर
डॉक्टर अविनाश तो है, मैं भी कहाँ कंफ्यूज हूँ। अच्छा, आप दे दो पहले, आपको आप तो कहाँ पंचकुला में है ना?
पीस उनकी प्रेजेंट वो है।
एक मिनट में चेक कर लूँ, दो मिक्स होगी आप में कौन सी? जरा कॉपी कर दो।
आप रखना मैं
हाँ ठीक है, कौन सी है?
सबसे नीचे, सबसे नीचे। हाँ जी बस। इसको मेरे नाम से ही सेव करें ना, शायद पता लगेगा ना।
देखना है आपने?
हाँ जी,
चेक करना है या?
आपने ओपन कर ली, हो रही है।
ओपन तो हो रही है, ठीक है।
ठीक है, थैंक यू।
कॉल किया क्योंकि एकदम से ये बंद हो गया।
वो जाता है बीच में, कोई दिक्कत नहीं, कोई फर्क नहीं पड़ता है। वो जाता है कभी कभी बीच में।
सर की पेन ड्राइव, वो रेड कलर की पेन ड्राइव
यही है शायद। वो बीच बीच में कभी मिस करता है वो। अब बंदा वॉशरूम कहीं तो जाएगा। यहाँ थोड़ी बैठा है, कोई टेंशन नहीं है।
वो एकदम से बंद हुआ तो सब मेरी तरफ देखने लगे। मुझे
वो
पता
मुझे
नहीं
ढूंढ
था
रहे होंगे,
कि
आप
कहाँ
देखिए।
हाँ।
मैं बाहर ही था।
एक्चुअली आपको ढूंढ रहे थे बट मैं ही उधर बैठी थी।
सेल खत्म हो गया उसमें।
I will request Professor Surjit Singh sir to please come on to the stage.
Good evening. So we start this session. This is on therapeutics, and we will be discussing one component of therapeutics which is sometimes very complicated, and that is anticoagulation. So the first speaker is Dr. Aman Gupta. Aman is a product of PGI. He did his MD and then he did his DM in Pediatric rheumatology from here. And he is based at Chandigarh. Aman.
Good evening, everyone, and welcome to this part of the session where we will be discussing about the anticoagulation in children with Kawasaki disease and coronary artery abnormalities. I'll be predominantly speaking on low molecular weight heparin vis-a-vis warfarin and other direct oral anticoagulants. So first of all, a brief review about what is the need for anticoagulation and the natural history of coronary artery abnormalities. So the coronary artery abnormalities in Kawasaki disease, they start with dilated vessels. The normal vascular tissue is damaged by the panvasculitis in coronary artery. The coronary artery is then expanded by its internal pressure, resulting in the formation of dilatation and aneurysms. So over a period of time, these aneurysms may persist, which over time can develop thrombus formation. They can be occlusion, resulting in formation, ischemia and infarction. And in some cases, due to intimal proliferation, the vascular diameter may become normal. So an interplay of endothelial injury, hypercoagulability, and abnormal blood flow results in the formation of thrombosis. In patients with large coronary artery abnormalities, there is a risk for luminal thrombosis in both acute as well as the chronic phase of Kawasaki disease. So, according to the American Heart Association update on the management of Kawasaki disease 2024 guidelines, during the acute phase, patients with rapidly expanding coronary aneurysms with Z-scores more than 10, systemic anticoagulation with low molecular weight heparin or warfarin in addition to low-dose aspirin is usually reasonable. But the damage is not limited to the acute event. There is a long-term risk of myocardial ischemia because of the various factors that we have already discussed. So, the long-term thromboprophylaxis is indicated with either warfarin, low molecular weight heparin, or direct oral anticoagulants in patients with giant aneurysms, either current or persistent. So how are these recommendations different from those that were there in 2017? The latest 2024 guidelines say that systemic anticoagulation may be considered in patients with giant aneurysms that have regressed to medium aneurysms and may be at risk of thrombosis. The lumen of the vessel may become normal because of thrombosis, in which case anticoagulation is required. So this is the difference between the AHA guidelines between 2017 and 2024 with respect to anticoagulation. So coming on to the choice of anticoagulation, there are no specific recommendations for the use of anticoagulation in clinical applications. Because there are no randomized controlled trials, warfarin till date is the most widely used anticoagulant, and there have been several studies indicating the beneficial effect of warfarin in addition to aspirin versus aspirin alone in children with giant aneurysms associated with coronary artery abnormalities. But a recent international survey, recent international survey, the choice of anticoagulation was most often warfarin, followed by low molecular weight heparin. Warfarin was used more frequently than low molecular weight heparin, both in infants as well as in older children. So despite achieving optimal control of INR levels, some case reports have indicated a risk of thrombotic events. Warfarin inhibits matrix gamma carboxyglutamate protein, which regulates calcium phosphate levels in tissues, thereby predisposing patients to vascular wall calcifications. Also, there have been several animal studies which show that warfarin induces endothelial calcification. Recent studies have also shown a proportion of patients with childhood Kawasaki disease experience coronary artery dilatation in adulthood when using warfarin as a long-term management strategy. So, low molecular weight heparin may be considered for chronic thromboprophylaxis in patients with giant coronary artery aneurysms, particularly for young infants or those with expanding aneurysms early in the course of their illness, or as bridging for patients between unfractionated heparin and warfarin. The mechanism of action being potentiating the inhibition of factors 12A, 11A, 10A, 9A, 2A by antithrombin. In a retrospective review of KD patients at the Hospital for Sick Children, Toronto, 38 patients out of a total of approximately 1,300 patients received systemic anticoagulation. 25 of these patients received low molecular weight heparin, while 13 received warfarin from the onset. So what it showed was the frequency of thrombotic events was similar in both these groups. Severe bleeding was more frequent in patients on warfarin compared to those who were on low molecular weight heparin. Patients on warfarin were at greater risk of under anticoagulation or over anticoagulation than patients on low molecular weight heparin. The maximum coronary artery aneurysm Z-scores diminished with time for patients on low molecular weight heparin, but not significantly for those on warfarin. So, heparin is a potentially viable alternative for children, especially the younger ones with coronary artery abnormality, especially the giant aneurysms associated with Kawasaki disease. In another pragmatic registry trial, to determine the effectiveness of low molecular weight heparin or warfarin for thromboprophylaxis in coronary artery abnormalities, 383 patients were studied. This graph shows the cumulative incidence of coronary artery thrombosis in patients without previous thrombosis, that is primary prevention, comparing low molecular weight heparin, warfarin, and those who had no anticoagulation. So it clearly shows that patients who had not received any anticoagulation had higher incidence of thrombosis compared to those who have received anticoagulation. Also, the cumulative incidence of coronary artery thrombosis at approximately 2.5 years of starting thromboprophylaxis was similar, with no difference between low molecular weight heparin and warfarin. 63 patients developed coronary artery thrombosis as a complication of their abnormalities, out of which 51 patients received secondary thromboprophylaxis, 21 low molecular weight heparin, and 24 received warfarin. So there was no major or statistically significant difference in the incidence of further coronary artery thrombosis between these two strategies. Also, the severe bleeding complications were generally rare and noted equally for patients on low molecular weight heparin and warfarin. There have been several case reports documenting the use of low molecular weight heparin in children with Kawasaki disease associated coronary artery abnormalities, wherein they have shown that heparin effectively prevented luminal proliferation and thrombus formation in the coronary artery abnormalities. In this recent study, where the effect of deltaperin was investigated in the initial treatment phase to be associated with a lower prevalence of coronary artery lesions in patients with acute Kawasaki disease. Patients were given deltaperin along with IVIG in one group, while the other group received only deltaperin and aspirin. So it showed that the incidence of cardiac sequelae was 0% in the group who had received deltaperin in addition to IVIG, compared to around 12% in patients who had received only IVIG at a rate of 400 mg per kg per day for 5 days, compared to 2.5% in patients on IVIG at 2 gram per kg per day. So, the concomitant administration of deltaperin was associated with a lower prevalence of coronary artery lesion in children with Kawasaki disease. However, this study only showed the reduction in the risk of developing coronary artery lesions, but further studies are required to establish its effectiveness as a long-term thromboprophylactic agent. So, low molecular weight heparin can be given 12 hourly subcutaneously. The dose range from 1 mg to 1.5 mg per kg per dose, depending upon the weight of the child, age of the child, and the dose is usually titrated to anti-factor 10A target range. So I would conclude by saying that though warfarin is efficacious and is generally efficacy in treating complications associated with coronary artery abnormalities, but bleeding complications and ease of administration are the concerns. It is difficult to use in young children because of need for monitoring INR levels. It is difficult to manage in many children with INR in goal range seen in only two-thirds of the time. Although twice daily administration with low molecular weight heparin is a concern, but it has found to be equally efficacious in preventing thrombotic events. So it is preferable in infants and younger children. So my next colleagues will be discussing about the role of warfarin and direct oral anticoagulants in these children. Thank you so much.
The next speaker is Dr. Avinash Anantraj. Avinash is an associate professor in the Department of Cardiology at the Pgimer Polytechnic.
So, good evening everyone. I thank the organizers for the kind opportunity. So my role would be to talk on direct acting oral anticoagulants in Kawasaki disease. So I bring greetings from Pondicherry. So disclaimer is I don't have personal experience in treating children with DOACs, and this is fully a theoretical talk. So we'll go through this talk in the following contents. So what is the need for direct acting oral anticoagulants in children in Kawasaki disease, and what are the problems with the current standard of care, and what is the journey of DOACs in children, and what is the specific evidence in KD, and what are the disadvantages of using DOACs, what are the cost comparisons pertaining to our country, and in case we choose to use DOACs, then what is a guide that is available to choose the dose in children, and what happens if a child starts bleeding while on DOAC, what will be our strategy. So DOACs are of two types, either factor 2A antagonists like dabigatran or direct 10A antagonists, which are rivaroxaban, apixaban, edoxaban and betrixaban. So presently rivaroxaban, apixaban and edoxaban are available, so we will be restricting the discussion only to these 10A agents. So what is the specific need for DOACs in children? That is, what are the problems with the present standard of care, what are the problems with vitamin K antagonists, and what are the problems with low molecular weight heparin. So first, vitamin K antagonists, there is a need for periodic monitoring, and so periodic monitoring involves pokes to the child, which is not taken well by the parents as well as the child, and there is a need for periodic physician consult for dose tailoring, which is also a time-taking prospect for the physician as well as the patient. And significant interactions with food and drugs when it comes to warfarin. And there are significant problems with angiogenesis, and bone density impairment is a problem that has been well established with children on long-term warfarin. And also there is a problem of delayed onset of action. We start warfarin and wait for the therapeutic action to happen over several days. And warfarin has a narrow therapeutic index, as we all know. Some children don't attain the therapeutic range, and we increase the dose, suddenly the INR goes to very high levels. So there is an unpredictable pharmacological response. And studies have shown, as the previous speaker mentioned, the time in therapeutic range when a child is on warfarin is nearly only 60%. So in considerable time, the child is actually less than the therapeutic range. So there is a high chance for formation of thrombus while on warfarin. Now the problems with low molecular weight heparin, there is a need for twice daily injections, which is really a troublesome prospect for the child. And there was a study which assessed the quality of life and the parent anxiety levels when home administration of low molecular weight heparin was done in assessment in Australia. So there was a significant component of parent anxiety, and that also puts off the parents from taking twice daily heparin to the child. And it is an expensive prospect compared to DOACs in India. In the West, DOACs are more costlier compared to low molecular weight heparin, whereas in our country it is it's reverse. And unfractionated heparin has significant problems with bone density impairment similar to vitamin K antagonists. and low molecular weight heparin is plus minus. It may cause bone density impairment. So these are the problems with the current standard of care. So with the direct oral anticoagulants, there are certain pros and certain cons. The pros are it's fully administered orally, and there is no need for frequent monitoring. There are child-friendly formulations available in the West, and soon it may be available in India also. And in comparison to warfarin, the onset is immediate and the offset of action is also immediate. And there are very few food and drug interactions. There are interactions, but they are very few. And the presently available pharmacokinetic and pharmacodynamic studies, which are very less in children, show presently a stable PK and PD data. And so far, adult studies have shown that there is no bone density impairment with all the DOACs that have been studied. And the little data that is available on children also shows there is a little bone density impairment. But the cons are, these are expensive, and in case a monitoring test is required, supposing there is a dosing problem or a child starts bleeding, then the suitable monitoring tests are very few and they are not easily available when it is required. And most of the DOACs, it is a twice daily administration, which is also difficult for compliance in a pediatric population, except for edoxaban. And in case of a toxicity or a bleed, when we need to reverse it, the access to the reversal agent may not be easily possible. So far, what has been the journey of DOACs in children? The US FDA approved DOACs for use in adults in 2008 for non-valvular AF and venous thromboembolism therapy. Since then, pediatricians have started using this in children for venous thromboembolism therapy and prophylaxis off-label. And US FDA approved DOACs in children in 2022, and trials for venous thromboembolism prophylaxis and treatment primarily in children who have blood leukemias and indwelling catheters have been done. And select high groups requiring treatment for, so these are all venous thromboembolism therapies. So our primary concern is arterial thrombosis. So whether there are studies on DOACs for that. So select high groups which require treatment for arterial thrombosis are KD and children who have undergone therapy for single ventricle like Fontan pathway. So there are studies on that. And saxophone, which is a study on apixaban, and N-Noble, which is a study on edoxaban, have a considerable population of KD in their study subgroup. And the present pharmacokinetic and pharmacodynamic data which are available from these studies presently show a good safety profile, and dose adjustment data for children in bigger studies are awaited. So the specific evidence in heart disease but not Kawasaki disease is available from Universe study, which used a liquid formulation of rivaroxaban in comparison with aspirin in post-Fontan children within 4 months of surgery. So usual recommendation post-Fontan children after 3 months is either warfarin or aspirin. So in comparing with aspirin, what is the role of rivaroxaban was studied in the Universe study. And they did an initial pilot study where 12 children were given the dose equivalent of 10 mg adult thromboprophylaxis dose. And after this was done, they took to the second part of the study where 100 children were randomized 2:1 to rivaroxaban versus aspirin, 5 mg per kg per day, and it was evaluated over a period of 12 months. So one child in the rivaroxaban group had a major bleed versus 0 children in the aspirin group. And there were no clinically relevant non-major bleeding events. So no significant difference was seen between the two groups. So this gave a go-ahead for rivaroxaban in heart disease. And DOACs, what are the specific evidences in KD? So N-Noble, which studied edoxaban versus standard of care. So 100 children, this is also a 2:1 comparison. So edoxaban versus standard of care, either warfarin or low molecular heparin. Of the 100 children in edoxaban group, 24 were KD. So almost 1/4 were KD. And in 22% of the standard of care group also were KD. So overall 22% were KD children. And in the saxophone study, that is apixaban, there were 3 categories of children. So there was a question regarding like what is the age from which DOACs have to be used. In both N-Noble as well as saxophone. In saxophone beyond 28 days. So newborns were excluded, but from 1 month of life there is data for use in children. So till 18 years were enrolled in ENNOBLE. So we can practically take from 0 to 18 years, there is data for DOACs. That is these two DOACs which were tested in KD. So in saxophone, KD population comprised of around 14% of the study group. So in ENNOBLE, as we can see from the table, there were no significant differences between the standard of care and edoxaban. And in the saxophone study also, there were no major differences. So in both the studies, it was found that the DOACs were comparable to the standard of care, or in other words, non-inferior to the standard of care. Now, dabigatran, diversity was a study which was not related to patients with cardiac disease, but children at risk of venous thromboembolism. So this was done even prior to the studies which we discussed previously. So from 2014 to 19, and a longer period, and 2:1 randomization, dabigatran versus standard of care. Non-inferiority design was done, and this was also from birth to 18 years. So patients received various formulations based on their age category. And there were 5 minor bleeding events and 1 major bleeding event in the trial group. And P for non-inferiority was achieved, and there was no difficulty in compliance. So that was also assessed. So in the various formulations that were given to the children, there was no difficulty in compliance irrespective of the age. So what are the dosing studies which are available and how to choose the right dose? So apixaban, the data from saxophone, like how they used based on the weight, what dose was used is given here. And what formulation, whether a liquid formulation or a capsule or a tablet was given. And these are the dosing studies from rivaroxaban. So rivaroxaban, in Einstein junior study, it was used for venous thromboembolism prophylaxis. So this was not a cardiac population. This was a general population, like children with tumors and other children at risk of venous thromboembolism were treated here. Whereas universe study was the post-Fontan thromboprophylaxis, where aspirin was compared with the 10 mg equivalent. So in Einstein, 20 mg equivalent of the adult dose was given, which was a BTE treatment, whereas in universe, 10 mg equivalent of adult dose was given. So that was the thromboprophylaxis dose. So the doses which are used for rivaroxaban are available in this table. So in the diversity study, dabigatran, as we previously saw, various formulations were available based on the age ranges, and what were the doses which were used is given here. So how to choose the right dose for edoxaban? In the ENNOBLE study, edoxaban was used like this, like 1.4 milligram per kg until the age of 6 years, and 1.2 milligram per kg for the age of 6 to less than 12 years, for a maximum dose of 45 milligram. And beyond 60 kg, the adult dose of 60 mg was used. So now cost comparison, whether it is viable to use in India. So I have taken the prices from NetMeds and the select brands which are usually available. So apixaban, a strip of 10 costs around 3,200 per month, and warfarin costs around 100 per month. So this is a cost comparison. Low molecular weight heparin, if we are giving twice daily for a 40 kg child, it costs around 28,000. So Western data says DOACs are costlier compared to low molecular weight heparin, but in our country, DOACs are still cheaper compared to low molecular weight heparin. Thus, apixaban is 40 times costlier than warfarin, whereas low molecular weight heparin is 10 times costlier than apixaban. And rivaroxaban is cheaper than apixaban, whereas dabigatran is like 10 tabs cost around 720. So DOACs are costlier compared to oral anticoagulants, but cheaper compared to low molecular weight heparin. And child-friendly formulations, dabigatran comes as sprinkles or pellets in various strengths and as an oral formulation. But this is all data from the West. In our country, we are able to see that only the adult formulations are available. So they have to be converted into solutions, which we usually do for pediatric population in the other drugs. And edoxaban is available that can be crushed into liquid for younger patients. So tests to assess the anticoagulant effect for dabigatran, APTT, TCT and dilute TCT are used. And for anti-10A agents, anti-factor 10A assay is used, and PT-INR shows a minimal effect. So what are the antidotes in case one is needed? So for dabigatran, idarucimab is used, whereas for factor 10A agents, it is antinaxant alpha. So what are the adverse drug effects of direct anticoagulants? So for bone metabolism, Heparin is bad, low molecular heparin probably neutral. Vitamin K antagonists are bad, whereas DOACs appear to be good so far from all the adult data which is available here. So all these are adult data, primarily for rivaroxaban and edoxaban and dabigatran. For saxophone, pediatric bone metabolism data was studied, but it was a very small number. So paired bone density scans were available for 16 participants on apixaban and 11 participants receiving standard of care. So the mean change in lumbar spine values, so here also Z-score was used. So they found that it was minus 0.2 to minus 0.3 for standard of care agents, whereas it was in the plus Z-score for apixaban. So they could not reach a meaningful conclusion, but they suggested that the negative Z-score in the standard of care arm suggested that the possibility of either less bone accrual in the pediatric population taking standard of care. So we may come to a conclusion that saxophone is probably better compared to standard of care when it compares to bone metabolism data in pediatrics. Heavy menstrual bleed, especially in young adolescents who are on oral anticoagulants, was a problem which was encountered in Hokusai VTE data, which was a study on VTE in children taking direct NA antagonists. The characteristic and outcome of abnormal vaginal bleed in women who are less than 50 years of age receiving edoxaban or warfarin for the treatment of VTE was studied. And abnormal bleed occurred more frequently in women treated with edoxaban rather than warfarin. But most of the events could be conservatively managed, and it was only a mild outcome. So we come to a scenario where a child on DOAC needs urgent surgical procedure. So the recommendations that are given are, in case of a low bleeding risk procedure, stop the DOAC 24 hours before the surgery and restart on the same day if there is no bleeding. Whereas if it is a high bleeding risk procedure, stop 48 hours prior to the procedure and then restart 24 hours after the surgery if there is no bleeding. And what to do if a child starts developing bleeding on DOAC's treatment. So there are some case reports which are available. So what have been done in these case reports? So a child who developed an intracranial hemorrhage while on rivaroxaban, a child weighing 20 kg, from the adult data which is available, they had made a dose extrapolation, and they had made a 25% of the adult dose based on the weight of 80 kg, assuming an average adult will be 80 kg. So they had given 100 mg of IV bolus of andinoxant alpha, followed by 100 mg IV infusion over 100 minutes. And with that, the child improved, and she was, burhole was done, and the ICH was relieved. And dabigatran overdose with a poisoning intent was taken by a child who was 15 years old, and edorizumab was used for reversal. So here they were able to show the test data also. So they were not able to get the drug initially for the first 20 hours. So initially they managed with other drugs. So the APTT data and the thrombin time data, everything is shown. It is all deranged till the first, till the time the edorizumab was given. And within 1 hour of giving edorizumab, it has come to the normal range. So probably it is reliable for dabigatran in children also. So summarizing, almost 2,800 children aged less than 18 years have participated in the various direct oral anticoagulant studies, providing evidence on safety and efficacy in the pediatric population. And they have almost similar efficacy and safety profiles compared with standard of care in the pediatric population also. And significant advantages over current anticoagulant options are available related to ease of use. And PK and PD data also derived from trials show that dosing regimens in children achieve similar drug concentration similar to adults. And results also confirm that therapeutic monitoring is not routinely required in majority of the patients receiving DOACs. So conclusions, DOACs have an undeniable advantage over VKS and LMWH, which are the present standard of care. And with specific evidence in KD, the two drugs are apixaban and edoxaban. Specific evidence in heart disease, but not KD, is rivaroxaban. Edoxaban is definitely superior because once daily dosing is preferable in children, and no safety data on reversal of agents in children is still now available, and it's still not FDA approved. They appear to be bone safe from the present data which is available, and menstrual bleeds in adolescents is a concern. If expense comes down, they will play a bigger role in India. So thank you for your kind attention, and wishing happy learning in the upcoming talks. Thank you.
Thank you, Avinash. Both the talks are now open for questions. We have never used DOACs in KD. We have been managing our patients with warfarin and low molecular weight heparin. With both of these drugs, there are issues in children, but they are manageable. times to come, I'm sure many of us would start using DOACs in this situation. There are several large studies going on DOACs in KD, and Dr. James Burns Center is gradually shifting to DOACs. So, any questions or comments on the two talks by Dr. Aman Gupta and Dr. Avinash?
So, we have recently used drugs in two patients who are post central venous aneurysms. So, one patient was some kind of the cause, the MR was the MR started drugs. And recently we have a patient of nephrotic syndrome with cerebral venous thrombosis, but who also had factor 5 mutation. So, that patient was discharged. Initially started with an weight and discharged patient on drugs, but not the
So for last 6 months we have completely shifted to DOACs, but same as we are not yet sure for what will happen if the child bleeds after. So far we have not got any instance of bleeding. So for most of the cases where we were using warfarin, we have started using DOACs even in all the cardiac group also except for the MDR patients. But for the testing and whether it would be as efficient as warfarin, we are not yet sure.
Meanwhile, will you give FOP for such situations? It also has factor that whether you need a special antidote. Is there any what's the difference between them?
Like people have used tranexamic acid and prothrombin concentrates till the time the idarizumab was available in that child, but I'm not sure about.
What's the special concern of that drug when compared to the other agents? Like warfarin is also fluoxetine, LMWH also has any activity, which gets reverted to the FOP. What's the special about these molecules? Need a specific drugs?
I'm not sure like specific agents why they are required, but
It is specific antagonist.
yeah.
I think it's specific antagonist.
And
Otherwise, the other things which are generalized treatment which you carry on in India.
And even after the agents have been given, the thrombin time was not corrected, but after the idarizumab was given, immediately it reversed to normal. So.
Sir, is the antidotes are available ready?
Yeah, it's a difficulty getting it. So even in the West, this report was from Britain, so even there it was difficult to get within like 20 hours they took to arrange the drug. So.
And what is the half-life of the molecules or DOACs? I mean, if side effect data, etc. are documented.
No, after giving the agent, the effect gets reversed within an hour. That's what we saw in the report. So if the specific antidotes are available, then it's getting reversed immediately. And
There are limitations in our country.
yeah, I think getting the agent, I'm not sure like whether it is easily available. I too. Yeah.
Thank you, sir.
Despite the vitamin-rich food restriction, we found that most of the time this INR variability from the lab to lab. And then he sometimes switched to acid form or like that. Is there any solution for or one lab we have to rely or what is the suggestion for INR variability?
I don't know, sir. Like we have the same problem in Pgimer, not with children, but with adult patients post valve replacements. So when we take our lab as reliable, but I don't know whether that is the case. But most of the time, patients get it done from outside and then they come with the reports. So it is a difficulty doing that. And presently, we have one child who is on warfarin with a giant aneurysm. But I mean, she never attained the therapeutic range. So INR is always 1.5, 1.6. We have increased it to the maximum, beyond the maximum weight also. But we are still not considering DOAC because of the cost consideration. So that is it.
You have touched one important aspect that you have never touched the therapeutic targets of the INR. So, but we have also seen and we have analyzed data, Subrit has analyzed data on the anticoagulation in Kawasaki disease. So, what we have seen is that we may not need such a high therapeutic targets of INR in patients with Kawasaki disease always, and our therapeutic range is around 1.5 to 2. Okay. And on that most of the patients are doing well. We are yet to finalize the final analysis, but based on that, possibly, and there are one or two studies published from Jagan Guru also, and they also suggest that possibly that more than 2 INR or that possibly is difficult to achieve also, and it may not require always. So possibly we have to maintain, and whenever we try to maintain it a very strict range, because it will go beyond that, and that is also a problem in young children. So possibly we can and I don't know whether we are right or wrong, but possibly because based on our experience, around 1.5 is also reasonable.
I do agree. 1.62, 2.2.
We usually don't require monitoring when the patients are on DOACs. So, is there any particular dosing or particular age group in which we have to monitor for the side effects or to look for the risk for bleeding in particular populations?
Yeah, like from the studies which are available, no specific recommendations are there, and they are not tested in specific age groups. But because they assessed the pharmacokinetic and pharmacodynamic data, they were in their protocol, they had specific time periods at which they were doing the test to assess the drug levels and all. But as such, there is no indication to monitor the drug levels or to check the anti-TNA levels.
Thank you, Vilas.
Thank you.
With this, we move on to the next talk, and that will be given by Dr. Mansoor Singhal. And for a change, he would not be talking on CT coronary angiography, but he will be giving his experience with cardiac MRI in children with Kawasaki disease.
स्लाइड शो किया ये है ना दोबारा कीजिए बंद करूँ क्या इसके अब स्लाइड शो कीजिए यहाँ से आ गया ना ओके इसमें लेजर है सर
Thank you, sir. Definitely, this is a change for me as well. So we will discuss, we were discussing about the role of the advanced imaging methods, especially the cardiac MR with Professor Itsuko Suda. And I had an opportunity to work with their team when I was in NCVC, and that gave us a lot of impetus to, integrate this imaging. And I'm happy to share that we have started doing MR in this thing. I will show you some examples. So if we talk of Kawasaki disease, so it is not just restricted to the coronary arteries, and it's much beyond that, which has been proven beyond doubt. So for that matter, definitely we need to see the coronary arteries and their long-term follow-up, and it involves myocardium, and recently, it can be in the form of inflammation, ischemia or fibrosis. And yesterday I was enlightened by your talk, ma'am, that it involves endocarditis also. So we'll look into that aspect. Can we see that on any imaging? So if we see, there is unambiguous and unequivocal concept that KD, not only just involve coronary arteries, it involves myocardium and maybe other organs which are still unknown, because that is the enigma and that makes this disease fascinating for all of us. Whether it's coronary arteries, whether it's myocardial ischemia, or whether it's how the myocardium is involved. What about the functions, valves, as far as endocarditis is concerned. But that is usually restricted in the acute phase, and the involvement of systemic arteries. So when we talk of MR, we talk of MR angiography first. You must remember that it is a high diagnostic accuracy for the coronary artery abnormalities, and at the same time, it gives us an opportunity for assessment of the function, which is the gold standard nowadays, and myocardial tissue characterization. Combining MR angiography with the cardiac MR may be a challenge and can take long accusation times. And in most of the centers, including NCVC, they will divide this into 2 studies, but in PGI we try to club both as one. If so is the case, then why I always talk of CTCA then? Why not MR? Because it has a long accusation times, and yesterday we were discussing with Professor Suda that majority of the children may not, are not comfortable MR doing for the next time because of long accusation times. But having said that, this is one of the caveats of cardiac MR other than this lower spatial and temporal resolution what we get with CT. An assessment of mildly stenotic lesions and assessment of distal arteries may be difficult on MR. And there is the CTC help. So, we need to customize, tailor our investigation based on clinical need. So that is why from a general concept, the medicine is shifting more towards the personalized and precision medicine, and that's the way forward. And in diseases like AD, this becomes more imperative. So we see, we'll go see what are the possibilities on cardiac MR. So first we need to see the coronary arteries, which can be, gives us an opportunity to assess aneurysms. Yes, we can see aneurysms, stenosis, thrombosis, occlusions, collateral flows, everything is possible on cardiac MR. We'll see in some case-based approaches that we have done. These are practical things that we have been doing. On MMRCA, you can see the coronary artery anatomy if done properly and child cooperates. You can see all the coronary arteries. This is the RCA which is showing a fusiform aneurysms, and so is the aneurysm sitting in the LCX. And you can have, 3-dimensional imaging of the MRCA that you can do with the CT scans as well. These are just, it all depends how the child had been cooperative and the imaging has been done. So when I say this, so usually MRCA should be restricted in the children who can get an MR done without any, when the child is old enough to listen to our instructions. Am I right, ma'am, Suda? For younger children, MRCA is difficult and should not be even considered. So we have discussed about, there are videos that is expected to be, just a minute. The second part is, when we have stenotic lesions and these are on follow-up, the MR, when we talk of MR, usually it is in follow-up imaging. It is not at during the presentation or the initial presentation. So when you have stenosis, so we have seen morphologically, if there is a stenosis, what is its effect on the myocardium? That you can see either with a stress perfusion or a dobutamine additional stress. So with that, you can see what is the hemodynamic effect of those lesions, and that can help us in making therapeutic decisions, maybe in the form of interventions or in the form of surgical intervention. That depends on how many arteries and how many segments are involved. So this is about, the stress MR. So, these are the borrowed slides. So there is an aneurysm in the LAD. And if you see, this is an rest perfusion versus an stress perfusion. I don't know, it's not projecting. Can you see this black line, which is then LAD territory, that tell you, this territory is ischemic. Whether this territory is infarcted or not, you can see on the late gadolinium enhancement imaging. So in that late gadolinium enhancement, anything which is white is dead. And the good part is, if we talk of the American 17 Hurt model, so the vascularity or the vascular supply is territorial. That can tell you very well which territory is involved. You can see this black line coming towards the LAD side, just tells this territory is slightly ischemic. Now third thing, so we have discussed two things. We have discussed the anatomy, we have discussed about the ischemia. Third thing is what is the effect of this disease per se on myocardium, and how the myocardium is getting affected by ischemia is by myocardial tissue characterization. So why this concept has come? This concept has come from Dr. Najib Dada, who had written a remarkable article who said, see, KD is not just coronary arteritis, it's probably myocarditis as well. So, over the time, as of now, I can make this statement. Myocardium may be involved in the initial phase, but in the scans that we have done, maybe around 85 as of now, we have not found myocardial abnormalities except in infarction. So maybe myocarditis may be an acute event which probably resolve. I don't know whether this statement is right or wrong. This statement is solely based on the imaging that we have done. And infarction we can detect up to 1 gram of tissue. It's so specific. So when we talk of myocardial tissue characterization, we has already discussed the ischemic scar always territorial. And that's how we can distinguish whether the scar that we're getting on myocardium is ischemic or vis-a-vis it's a sequel of myocarditis that patient develops during the initial presentation. And how we do that, we'll show with an example. This was a 10-year-old male who is a daughter of a pediatrician. So, there was a thrombus in one of the proximal segment of the left can I see, let me show that, bring that pointer. Okay. There was a thrombosis in the proximal LAD, and you can see the scarring, which is transmural in the region of apex. And these, these are the recent parametric maps, these are T1 and T2. I think this is beyond the scope of discussion as of now. Just showing these images to make you aware that these things are also possible. And more important, you can see the function which is gold standard, which can help you in longitudinal follow-up as well. And the fourth thing is the ventricular wall motion and the quantifications. You can see whether it is hypokinesia, it is akinetic, it is thinned out. If it's thinned out where there is thrombus inside, so what you do is you have a stack of short axis images from base to max, and with this stack you calculate your functions based on drawing the circles on the endocardial, the epicardial. These are 4-chamber views, and this is the 2-chamber or the vertical view which you see with the and this is how, sorry why this slide has migrated. So you can have your this LV function, RA functions, RA dimensions, everything, and you can have in a single this thing investigation. Then about the endocarditis, if there is a mitral regurgitation or mitral abnormalities on follow-up, you can see the valvular regurgitation. You can quantify them. You can see this in jet, because of mitral stenosis, you can see which is the LA is dilated as well, and you can quantify them. And this quantification is gold standard. It is just like you do on echocardiogram. In fact, better than that. And at the same time, if there is a suspicion, this is not something which is to be routinely done. If you have already diagnosed patient having systemic aneurysm, you can do an contrast enhanced MR angiograms, and you can image all the systemic arteries. This is one such example which I have taken from literature. So a cardiac MR, it can give you immense information, which is not just restricted to morphology. You can have functional information, you can have myocardial tissue characterization. And having said that, it is only investigation that can tell you about myocardium. There is no investigation as of now which can give you the insights in myocardium other than MR. Now, what are the newer updates? This I learned when I visited Dr. Suda's center. So you can see the intraluminal or the mural pathology, intraluminal morphology, and when we say the MR is a long acquisition times, now there are a few things in place which we called as compressed sensing that gives acceleration to image, and we can cut short imaging times. We have yet to see it. So once we have done the morphological imaging, this is called a Dixon scan. I think you must remember this word Dixon image. With a single acquisition, it gives you 4 set of images, and this 4 images is fat, water, and fat is in phase and out phase, with which you can characterize your plaques. You characterize your thrombus, and this helps in follow-up. So this is an image from your center. I forget his name, who is an MR radiologist. Dr. Moita, yes. So, so this is CTCA, you see calcification. Calcification is a killer for the MR investigation. So this is probably one of the investigation at the beginning, and you see you can do a heavily T2-weighted MP range images. In that you can qualify the lumen as well. In other example, you see this is a calcified lumen, which is thrombosed, and you can see on follow-up with some bright dots between showing areas of recanalization. And with this, there has been change. And this has been made possible because this is slightly busy slide and more directed toward radiologist. But I want you to know this, how this is possible. This is possible, and you don't need any contrast. And these are inverse recovery based sequences which are heavily T1 weighted. That gives you about the vessel wall information. Now this is one of the slides I requested Professor Utsuko Suzuki ma'am around many years back, and she was kind enough to share these slides with me. So I am thankful to her. The MR is a major role when you have a thrombotic lesion. So there is no way we can follow them up. So what she showed me is an echo image. This is an echo image which is showing thrombus, and this is a catheter angiogram, large aneurysm which are prone from thrombus. On MR, you see this large thrombus, and when you do perpendicular imaging to it, you will find something like cobweb type of appearance. And this is the morphological images of the same. So MR not only will tell you the morphology, it helps in characterizing the plaques as well as the vessel wall. But this is what it is. But what is the CMR in the real world scenario? The real world scenario is at presentation, it is not advisable or indicated. And follow-up, definitely it has a role. And what's the role it has? It's a long-term management of sequelae of KD, which may be in the form of coronary artery abnormalities, thrombosis, and you can have functional information and myocardial tissue characterization, and which are indispensable. So I will show you a few examples which I have done very recently in the last 2 months. So this is one example. I think Dr. Yamini is going to show these cases in details maybe tomorrow. So this was an 8-year-old child who was diagnosed with Kawasaki disease, and these are CTCA images at presentation. So you see there's complex aneurysms in the proximal LAD, which is involving the diagonal 1 images. LCX is involved, OM is involved, RC is involved. On chlorine inspection, I think Ripu is presenting this case. If you see the proximal RCA is dilated, and you see a filling defect in the mid RCA which was thrombosed. Now we have an option to image this patient on CTCA, but matter of the fact is these patients will have many follow-up examination. Is it justified to put this patient on ionizing radiation every time? So we have selected these patients, and Rakesh is a part of that team. So what we have done MRCA just 2 weeks before, and this is a follow-up of MR after 3 years. And what you see over here is, I will show this video as well. You can just have wonderful imaging, and you have seen that RCA aneurysm is more or less regressed and restricted only to the proximal segment, and this aneurysm is also remodeled. And probably there is a tight stenosis at the the LAD. So probably we'll do an functional imaging as well. The function was more or less normal in this patient. So this is about the function. So we have got morphological information, we have got functional information. Then you can have your perfusion imaging. This is the first pass perfusion imaging, which is a standard for any MR protocol. Ma'am Suda, we are not doing stress MR as of now because of our own restrictions and challenges. This is the LG images which show the myocardium clean, no thrombus. LG, you see there is a bright spot. Can you see this? Can you see this bright spot? This is subendocardial, this is inferior wall MI. So means what has happened is this thrombus which has happened in the mid RCA has led to a small volume thrombus through small volume MR infarction. And this is very, very specific. It is 100% specific. That is territorial, but it's subendocardial. It is not transmural. So it will not have any, we know that, it has caused some defect, but it is not that functionally important. And there are advanced parametric maps that we do on T1, T2 images to see the myocardium elsewhere where the LG is normal. And with this, we do multiple ROIs, and till yet all the patients, we have found the T1 and T2 values within normal limits. That is, very satisfying to me that probably myocardium may be involved in the acute phase, but definitely it heals over or get unaffected in the chronic phase. I will show you the second case. This was a child who had a very relentless, and very, scary clinical presentation. Pleuropericardial effusion. All the coronary arteries are badly affected, so much so that pericardial window had to be created. And this is now this child is 22 years old. I think he's an athlete now. Rakesh is an athlete now. Huh? This is, he's playing very well. So this is an MR that we did 2 months back. So what you see over here is most of the aneurysm have regressed, and this is the LAD aneurysm is also regressed, and more importantly, there is no stenosis. So beautifully it will tell you about if had there been stenosis or it is a normal vessel. Functional global LV assessment was perfect. His ejection fraction, if you see, was more than 60%. You see it's 61%. And these are their MRCR images, myocardial perfusion imaging, no perfusion defects, no LG. This is very, very satisfying, though patient has coronary artery abnormalities, but it has no impact down the line into the myocardium. So we can tell them to have his normal activities done, but definitely to continue on medications and have follow-up imaging. And tissue characterization, what we have discussed on T1 and T2 maps, were within normal limits. So with this, though we have discussed all the aspects of MR, we have some practical implications that we have seen, and I would like to conclude what I have learned from the giant sitting in this hall, that MRCA gives you an explicit demonstration of coronary artery anatomy with plaque characterization, and so. For that, it is the investigation of choice, probably for the thrombosed patients. And we need to know which imaging and when that imaging has to be done. So it is recommended only in follow-up of patients with large aneurysms or aneurysm with thrombosis. Perfusion imaging, rest and stress, you can consider. Rest is a part of investigation, whether the patient needs to be stressed depending on whether the patient has stenotic lesion or not. If there is stenotic lesion, then either you can have a cardiac MR or have a nuclear myocardial perfusion imaging. But nuclear myocardial perfusion, remember, it is associated with large radiation exposure. The myocardial tissue characterization that you get is highly specific, and the addition of parametric maps will tell you about the areas of the remote myocardium where the LG is not seen. Acute phase, definitely childs are small, it is not recommended, and if at all you have to consider uni or general anesthesia, so it is not recommended. And we need to know, there may be investigation, but we need to know what they are, what they offer, and what are the challenges. So challenges are long accusation times, and definitely the expertise. Still we are struggling for the last 5 years to make this MR a reality the way it should be, but days are not very far that we'll achieve that day once. So we are rigorously, pursuing that MRCA, and we are very happy and satisfied with the progress made so far. So with this, I conclude, and I would like to have the questions, which I believe there should be many. Thank you.
For the poor pediatrician, life has become very complicated. So we had echocardiography before, that was followed by CT coronary angiography, and now we have the full gamut of MR angiography. Questions? Yamini, Lutu?
So thank you for such a wonderful presentation, and it was so eye-pleasing. So my question is, like we know, it is very rare to have progressive increase in the giant coronary aneurysm in the chronic or the remote phase of KD. So what is your experience about progressive increase in the size of giant coronary aneurysm in the remote phase? also the development of new aneurysm in the remote phase.
There may be Madam Suda, we can help you as well. Ma'am, she is asking what is, can the aneurysm increase in size over time, or can new aneurysms can develop? So this is just an observation we have seen in few patients, and the aneurysm we have seen increasing in size, the new aneurysms coming up.
We experience 5% of patient coronary artery red carrier directed and expanding aneurysm was found. But expanding adolescents adult was found. And but in such case, not harsh kid increased. But in one case, in giant aneurysm, those occur and the root of coronary artery was almost lower. But difference, some cases, more and more expanding, direction of aneurysm and coronary artery bypass grafting was performed reported.
I mean, they can expand in 5% of patients. We have just seen few and has an experience of more than 3 days. Yes, that is not unfortunate. Yes, ma'am, it's always, delighting to answer your questions.
Thank you so much for this wonderful presentation. But just I was wondering, what is your experience with the late gadolinium enhancement later on when you follow up the patients?
We have done maybe around 80-85 patients. It's a wonderful investigation.
So, you're not finding many
No.
positive
I
cases?
only found the late gadolinium enhancement only in the patient who had giant aneurysm and probably thrombosis. Otherwise, we have not found LG in any of the patients. What to talk of LG in parametric maps at all in normal.
Another thing is that in MRI, can we see the inside of the coronaries?
Yes.
We can see the
That's why
inside of the coronaries as well.
That is the Dixon imaging.
Okay.
You can get it, you can characterize the inlumen contents. You can see the intra-plaque hemorrhages as well. You can see calcifications. You can have serial monitoring of the thrombus.
I noticed there was a case where you had a child later grown into a 22-year-old adult who had an aneurysm and he's an athlete now. So if we are not doing the MRI and not checking the lumen, how safe are we to give them this kind of a go-ahead that they can do the usual athletic activities?
Yesterday also, probably missed, we had 3 patients when Madam had seen. So one of them is an archer, this was a different patient. He had an aneurysm. So the conclusion was, if this aneurysm, patient has to continue on therapy. Patient need to know his thresholds and he should not continue beyond one threshold, and Rakesh can answer it better about the counseling and everything.
This is with the MRI or without the MRI?
Until, once you have a stenotic lesion, he has to undergo myocardial perfusion. We have lost one child just now, around 3 months back. He was a mountaineer and he kept on, climbing and he collapsed. So you must, when you have a stenotic lesion, that's how you do the molecular.
What I'm saying is, suppose you don't have a stenotic lesion in echo or CT also.
Yes.
You don't have a stenotic lesion.
No need.
If it regresses, then can we give them the go-ahead that they can do?
Yes. That's what
Not checking the lumen in this
Yes, yes. That Madam Suda can also answer that question. And she is asking if there is no stenosis and the lesions are there. There may be lesions. Can the child go ahead with his normal physical activities?
No stenosis. In the case if no stenosis, not limited for activity, I do.
Rakesh can answer in our setup.
Thank you for the talk. Sir, I have just one question. As you said that there is a lot of problem because panic infection is too large in smaller babies. So sometimes we only need to have or follow functional assessment of the ventricles. So with the new high-end echo machines, which give functional assessment, the 4D functional assessment as well as the myocardial work, how closely do they relate to the MR functional assessment?
There are, one is theoretical part of it, one is the practical part of it. The gold standard is MR, no ambiguity about that. But why we need myocardial function in every patient who is in kidney? Echo is good enough. When we do an MR, we don't do for function. When we see there's an abnormalities and part of that investigation, but not in every part. That's why in the beginning I said angiography as well as myocardial function are two different subjects. And in every center, they will do as two separate examinations. We need to know what is the purpose of doing an MR, whether you want to see the coronaries or you want to see the function. And function is only to be seen when there is stenosis. When stenosis, you do perfusion, stress as well as rest, and you see the myocardial, what is the end effect within function. In any case, what I mean, it is not just a protein thing that we need to consider. It is all to be individualized. Every patient is different, trust me. Every patient across activities or for any disease is different. You have to customize, you have to individualize. The guidelines is just an umbrella, but you have to, you have to think which investigation is to be done in which clinical situation.
So I have a question. So when we are following patients up chronically, there might be a dilemma that if the aneurysm is regressing or a stenosis is developing, like it might be reducing in size. So is that just the regular course of the disease where the aneurysm is just regressing or the artery is undergoing stenosis? So can we be assured that if we do a cardiac MRI with stress testing, it will help to solve this dilemma? Can we use this?
Yes, definitely. It is a way forward. If you there's a slight clinch of the diagnosis, or if you think over it, if there may be stenosis, you must consider myocardial perfusion imaging, which can either be in the form of MR or nuclear myocardial perfusion imaging. In NCVC, they do a lot of myocardial perfusion imaging, which is radiation optimized. And I checked whether we have that system, and we have that system. The semiconductor based system, and we have one system.
Sir, one practical question.
Yes.
So do you use general anesthesia for operating this MRI?
No, it should. If you have to consider anesthesia, don't consider MR. As simple as that. We get a lot of respect for congenital heart disease. We straight say no. If you want to have anatomical information, go with CT. If you want to have some functional information, consider echo. That's it.
Okay, thank you.
Thank you, sir. Thank you so much. I would like to make the emotional statement coming to this forum. I enjoy being a pediatrician rather than a radiologist, and I cherish it. Thank you so much.
So we go on to the next talk, and this will be given by Dr. Pankaj Gupta, who is an additional professor in the Department of Radiodiagnosis at our institute. And he will be talking on artificial intelligence in the evaluation of coronary artery lesions in Kawasaki disease. So apart from his other attributes, he has a very special qualification, and that is that he is pursuing a PhD in Artificial Intelligence from the Indian Institute of Technology of Delhi. In fact, he's about to complete it, and there are only 2 medical doctors in this country who are doing their PhDs from an IIT while continuing their medical practice, and it so happens that both of them are sitting in this hall. So one is Pankaj, the other is Dr. Amitabh Chattopadhyay, who is pursuing his PhD from IIT Kharagpur.
Very little about Kawasaki disease, but what I like to do here is to just try to see what all has been done in artificial intelligence in this particular area, and how we can go ahead and help these children with more algorithms and other protocols to minimize the radiation and optimize care. So I just did a systematic review to understand what are the knowledge gaps as far as the AI in Kawasaki disease is concerned. So this search strategy was completed a couple of days back, and the aim of the systematic review was to identify the studies that have explored diagnostic performance of artificial intelligence for detecting coronary artery abnormalities based on clinical echocardiography, CT/MR or catheter angiography using machine learning algorithms. So as you see, I extracted 650 PubMed papers, and after removing duplicates and screening by titles, found 65 papers, out of which I excluded 28 by abstracts, and finally reviewed 37 full-text publications. And in this talk, I'll be talking about some of the studies which I find are interesting and can help us understand the disease further. This was my search strategy, basically tailored at including all keywords related to Kawasaki disease and artificial intelligence. Unfortunately, I'm not going into the details of AI and machine learning just for the sake of time, and believe that the previous speakers would have talked about them. So this is a very latest study that was published, and the general trend for machine learning in Kawasaki disease, which I find, is to develop nomograms for prediction of coronary artery lesions. So this study did the same. And as we can see here, this was 677 patients, and they had 16 parameters on which they built the machine learning algorithm. And in the final nomogram, they included 5 parameters. Out of the total cohort, the coronary artery lesions were present in 205 patients. And we can see that the area under curve for prediction of aneurysm in the validation cohort was 0.844. I'll be talking about the limitation of these studies. There are a lot of limitations when it comes to the experimentation and other aspects. So I'll be summarizing them at the last of my presentation of these papers. This was a second paper, again a similar approach, a larger sample size, more parameters included. This split is all right, and there is 5-fold cross-validation. And what we see is that now these authors are reporting even higher performance for prediction of coronary artery lesions. Another study, a very recent study again the number has further increased. The prevalence of coronary artery lesions in this cohort was 12%. And what we see here is that even the parameters which they included, and these are ranging from the clinical to laboratory parameters, have also significantly increased. There are more than 50 parameters which they included. And they came up with a nomogram which comprises of several important clinical and treatment as well as biochemical parameters, and they show that the area under curve for prediction of coronary artery lesions is 0.703. So just to highlight, we have 3 studies published in 2025, almost similar methodology but strikingly different performances. This study to me looks more realistic as far as its performance is concerned, but again there are limitations which I'll be discussing later on. So in these studies, as we realized, there are no imaging parameters included. All of them are basically clinical and laboratory parameters. And this was the study in 2024 that actually talked of radiomics based on echocardiography. So radiomics is basically like genomics, metabolomics, similar to that, where we extract a lot of information from the imaging and then try to develop an algorithm based on that. So in this particular study, they developed a model based on 3 clinical parameters and 6 ultrasound radiomic parameters, which they call as ultrasomic parameters, not a very standard term though to my information. And then based on that, they developed a machine learning algorithm. The good thing was that this study had 2 validation sets, which means more explanation of the algorithms in 2 different populations. And what we see is that the area under curve is 0.84 in validation set 1 and 0.74 in the validation set 2. Another study which again aims to develop nomogram and includes several parameters. These are like 45 parameters. And we see that the baseline Z-score, which is based on the coronary artery echocardiography, is also included in the development of this nomogram. And they also showed that the performance was comparable to previous studies in the validation cohort. I'll skip this study and go to this particular study, which is of interest to me. So in this particular study, they developed an algorithm for automated detection of the coronary artery aneurysms based on echocardiography. And this was basically a detection algorithm which is very popular, popularly known as YOLO algorithm. You will read that in many AI-related papers. And you can see that this algorithm basically helps to perform automated detection of the coronary artery aneurysms and can be useful when there is limited expertise for performing echocardiography in these small children. And they showed that the typical metric for detection is mean average precision, which is MAP. And this is a very high MAP. Anything which is more than 60 is considered acceptable. And as we see that in this study, they have shown the MAP is more than 0.6 for almost all the algorithms which they developed. This again is a study which is of interest to me and which basically develops a classification algorithm based on the entire echocardiography image. So the hypothesis there was that this was done during the COVID time. So the authors included patients who had presentation which was similar to Kawasaki disease, but the final diagnosis was KD in 138 and 65 pneumonia patients. And they believed that the detection of coronary artery lesions in these patients would actually help differentiate Kawasaki disease from the other illnesses when there is a significant clinical overlap. So what they did, they basically trained the classification algorithm over the entire ultrasound image and then using different classification algorithms. See, these are not very sophisticated, these are very old algorithms and they are using the entire image, which is again a significant limitation of the study. Despite that, they showed that the models were sensitive, though poorly specific for the differentiation of KD from the other pneumonic illnesses. So overall, there were 6390 patients in this review which I did, and we can see that the area under curve ranged from 0.65 to 0.9. Again, a very varied performance reported by different studies. The specificity and sensitivity were also very variable in these studies. This is just an overview of all the studies, but my summary of this evidence is that the clinical parameters do have a promise for identifying the coronary artery lesions in patients with Kawasaki disease. However, I believe that imaging is underutilized, and the major limitation of this work is that they are all based on mostly single-center studies. And as we see, there are a lot of different clinical parameters that have been included. So it's important that for any AI-related studies, the models are tested on multiple different patient populations so that we can really prove that these models are generalizable to a different population, which has not been done in any of the studies which I have reviewed. Also, as I reported, there were only 2 studies that were based on imaging, so I believe that there is a lot of promise for the use of imaging for performing many of the tasks which Dr. Manful were also talking about. We just sort of tried doing something related to the Kawasaki disease, so I got a data of 10 patients with CT coronary angiography. 5 of them were normal and 5 were abnormal. And we thought of making a fully automated pipeline for detection of coronary artery abnormalities or to classify the coronary angiogram as normal or abnormal. So this pipeline would comprise of initial automated segmentation and followed by detection. So how I propose to do it was, there is already a trained model that is available, which is a public model, which is known as a total segmentator, a very popular segmentation model for coronary artery segmentation, and then the detection algorithm. So this is the total segmentator model which I took from the GitHub, and then using this model, I did not train it. So this is a pre-trained model. So this obviously requires fine-tuning. I have done it in a very short period of time. So but you can see that even when I run this model in the inference mode, it is giving me automated segmentation to, I believe, to some accuracy. There are missing segments definitely in between, and this can be definitely optimized. This is another example where again the segmentation algorithm automatically segments the left anterior descending accurately. There is part of the left circumflex which is also segmented, but it misses the right coronary artery. This was another algorithm which I tried to improve the segmentation, and we can see that now even distal part of the coronary artery is also being segmented. This was the segmentation part of it. Then I developed an algorithm for the detection part. So how I proposed the detection part was to basically identify all those segments that were more than 1.5 times the normal coronary artery, but that we understand would lead to a lot of overdiagnosis. And the question was framed in a way that if I see an abnormality on all the three planes, I consider that as a true abnormality, and across all the series that are available to me. So as a result of which, you see there are a lot of potential aneurysms which the model has detected, but there is a confidence score which I developed. So anything which had a confidence score of more than 0.5, based on their registration across different series and multiplanar images, was labeled as a confirmed aneurysm. In fact, this was a patient who had 2 coronary artery aneurysms in the left anterior descending and left circumflex, which were accurately detected. This is very preliminary work, obviously, and there is a lot of optimization that is required. But this seems promising, and we aim to test it on a diverse patient population. I think more important would be to develop a similar pipeline for echocardiography images, because their interpretation can be even more challenging. We also wish to assess more coronary artery lesions, and during one of discussions with Professor Surjit Singh, he asked me whether we can also assess the natural history of coronary artery lesions based on AI. So I think we can do that, but we need a lot of training data and follow-up of patients. And I am also looking forward to developing a large vision language model which will help us automatically report the coronary artery abnormalities using large language models. Thank you very much.
So that adds another aspect to the imaging issues of Kawasaki disease. Dr. Pankaj's talk is now open for comments.
That brings me to the philosophy of customer care. So I'm quite happy that me and Carl learning for maybe a decade, maybe more than with good understanding. So when we discuss, can we do that directly, and records can be bring immediate data, it was promising. Until we promise you that we don't have any data, the data belongs to you. And if you are ready to do that, please go ahead. We will all support you. And if the things are in chair, and the team is very, very happy that we got this important aspect, which is it can bring a change to the other centers who are struggling to integrate CTC as a part of their management level. Thank you so much, Pankaj, for coming here and giving such a lot of talk. Thank you so much.
I think this is one aspect of imaging about which we are likely to hear more and more, and more so in Kawasaki disease. Okay, so thank you, Pankaj. So with this, we come to the last session, and this will be taken by Dr. Suda, and she will be talking on coronary artery thrombosis in Kawasaki disease, presentation, diagnosis, and management.
Thank you. I would like to present our experience of PCI in Kawasaki disease. There are two major problems in PCI region caused by KD. The target vessel is small, and the size of the guiding catheter suitable for the use of larger balloon or bar is also limited by the diameter of the femoral artery. The second is existence of giant aneurysm with localized stenosis. Relief of stenosis is not always improvement of prognosis in such patients. Intracoronary thrombolysis, ICT, and intravenous coronary thrombolysis, IVCT, were useful for small children. Revascularization for ACS had these three effects: reduction of myocardial ischemia, decrease of myocardial infarct size, and improvement of long-term prognosis. I present the cases. I will present the treatment an 8-year-old boy with bilateral giant aneurysms. He visited the emergency clinic because of chest pain. His electrocardiogram showed hyperacute T wave in V2 to V4. An emergency coronary angiogram showed complete occlusion of the left anterior descending artery. Intracoronary thrombolysis by tishprafinogen activator was performed for the left coronary artery 2 times, and the thrombus dissolved. The reflow of the LAD was detected and chest pain was disappeared. Coronary angiogram after 5 years after ICT revealed the patency of the LAD. He had had no symptom for 11 years after ICT. However, he had undergone bilateral CABG at 19 years old because of localized stenosis in RCA and LAD. Here we see an infant patient in detail. A 22-month-old boy, body weight 10 kg, had severe KD with IVIG resistance at the age of 4 months. Coronary angiogram at the age of 6 months indicated bilateral giant aneurysm. At 22 months, he suddenly became pale and had syncope while walking morning. He was evaluated at the hospital 5 hours after the episode. Abnormal Q waves were present in his electrocardiogram. He was admitted to the hospital in the afternoon, and next morning he became pale again and hypertension. ST depression on his ECG was found. ICT was performed, but his condition worsened in the evening, and he was transferred to our hospital. Coronary angiogram at the age of 6 months indicated bilateral giant aneurysm. In the coronary angiogram at the age of 19 months, the size of bilateral aneurysm decreased, comparing with the initial coronary angiogram. On admission, abnormal Q waves were present in lead 2-3 AVF of his ECG. Hypokinase of the inferior were detected on 2DE. These changes seem to be occlusion of the right coronary artery. In the next day, in second illness of the episode, STT depression in V1 to 6 was noted on ECG. It indicated ischemia of the left anterior descending artery. He was diagnosed as having acute myocardial infarction. Cardiomegaly and pulmonary edema were seen on chest X-ray. At the third illness, abnormal Q wave in V1 and V4. After intravenous coronary thrombolysis, coronary angiogram reveals segmental stenosis of the right coronary artery and severe stenosis of the left anterior descending artery. He was transferred to our hospital. He underwent coronary artery bypass grafting to the LAD with left internal thoracic artery 1 month after his acute infarction. Coronary angiogram 25 days after surgery indicated complete occlusion of the proximal portion of the LAD with distal LAD flow supplied by the internal thoracic artery graft. Although CABG improved perfusion of the anterior wall of the left ventricle, the BNP increased more than 1,000 picogram per milliliter. Again, and left ventricular endodiastolic pressure was elevated after surgery, suggesting a transient worsening of heart failure. Very low dose carvedilol was started. The LVEF improved. This slide shows the parameter of his cardiac function. Beta blocker and ACI were very useful for heart failure after myocardial infarction. This slide shows the finding of two-dimensional echocardiography. Mitral regurgitation was slide. In myocardial perfusion imaging, myocardial ischemia was improved after coronary artery bypass grafting. Thrombolytic agents are shown. Rapid diagnosis is very important. If CPK would be elevated, it's too late. Symptom and serial electrocardiogram should be checked, and two-dimensional echocardiogram checked. This 10-year-old girl had chest pain in the morning with ST depression. Although the chest pain disappeared after 1 year, she was transferred to our hospital. Thrombus in coronary aneurysm of the left coronary artery was detected by 2DE. A coronary angiogram showed an occluded left circumflex. Warfarin was added to the aspirin she was receiving. After 5 years, the left circumflex had reopened. In the same patient, CR coronary angiogram are shown. The next is an adult case. The cause of acute coronary syndrome caused by atherosclerosis in adult is plaque rupture. In contrast, acute myocardial infarction in Kawasaki disease is caused by coronary artery occlusion due to thrombus. A 33-year-old female visited the emergency clinic because of chest pain and back pain. She was felt pain on effort before 3 days. She had coronary risk factor of obesity and smoking. The STT segment was elevated in lead 2-3 AVF in her 12-lead electrocardiogram. An emergency coronary angiogram showed 90% stenosis due to massive thrombus in an aneurysm of the right coronary artery. Aspiration of massive thrombus was considered too risky in those days. Therefore, intra-aortic balloon pumping was instituted. Chest pain was improved. After 3 days, thrombus size was reduced and stenosis decreased to 75%. Warfarin and aspirin were begun. She was discharged. However, she had further chest pain 30 days after initial attack. The ECG shows small negative T wave in lead 3. An emergency coronary angiogram showed complete occlusion of the RCA due to massive thrombus. The distal RCA was injected through from the left coronary artery. Repeated aspiration with thrombus and percutaneous balloon angioplasty was successful. CPK was not increased. Early revascularization after acute myocardial infarction minimized infarct area. Pathological finding of aspiration sample was shown. The factor of plaque was none. She had no symptom and previous finding of ischemia. Thrombus suddenly developed in the large aneurysm many years after the onset of KD. After that, she has had no cardiac event for 15 years by treatment warfarin and aspirin. A 26-year-old man had acute myocardial infarction because of occlusion of the left main trunk. ST elevation in ECG was found. Percutaneous transluminal coronary thrombolysis using tissue plasminogen activator was successful. CAG are shown. He had had history of regression of both coronary giant aneurysm. He had been a smoker. Although he had had no other risk factors, atherosclerosis. On the other hand, Some stent malposition for ACS were reported because of underestimation of stenosis diameter on the morphological characteristic. It is difficult to evaluate the precise diameter of culprit region because of mass thrombus. If the patient is younger, it may be better to avoid emergency stent implantation, except in life-threatening situations requiring rescue. The previous study involved analysis of 62 patients who had had previous myocardial infarction. We reviewed 62 patients. The age at initial MI ranged from 3 months to 33 years with a median of 2 years. The distribution of the interval from the onset of acute KD to initial myocardial infarction is shown. The median was 7 after acute KD. Symptoms and signs at initial MI are shown. Chest pain, abdominal pain, and vomiting, pale, arrest, abnormal ECG, thrombus by 2DE, convulsion, and syncope were found. Time of MI is shown. Repeated MI was found in 21%. Area of MI is shown. Inferior MI and anteroseptal MI were 56% and 39% respectively. Thrombolytic reperfusion therapy is performed in about 50%. ICT and IVCT were 20 patients and 18 patients respectively. ICT and IVCT were useful in the smaller children. Thrombolytic reperfusion therapy should be performed rapidly. In the next, we reviewed the clinical feature of 50 adult patients who had ACS caused by CAL due to KD or probable KD from 1980 to 2008. Their age at the onset of disease are shown. 90% of patients were less than 40 years. 40% of patients had no coronary risk factor. Smoking was the most prominent additional risk factor. The left pie graph shows number of branches with CAL. The right pie graph shows the number of culprit regions. The initial treatment, the characteristics of culprit region are shown. GIAN aneurysm were found in 42 patients. Calcification was detected in about 50% of patients. The initial treatment of ACS is shown. ICT and PCI were performed in 11 patients and 8 patients, respectively. 26 patients were treated medically. Elective CABG was performed in 15 patients. Outcome is shown in this slide. 3 patients died. ACS treatment has improved remarkably over the last 3 decades, thanks to thrombolytic therapy and improved PCI. Thank you for attention.
Enormous amount of data that she has presented, and we
years and years of experience, long-term follow-up of what happens to these children. And this is the kind of data which we don't have in India yet.
Thank you, ma'am. Besides having academic things, what we need to learn is about how to love your subject, your persistence, perseverance, and long-term follow-up. Thank you, ma'am, for your insights. It definitely gives us so much motivation and definitely gives momentum and impetus to work on this effect for environment. Probably in the decades to come, probably we will have at least some kind of data like this so that we can help the KD community worldwide. Thank you.
So what she has touched upon is the interface between pediatric cardiology and adult cardiology. So something I think which we need to involve our adult cardiology colleagues also, because many of these patients would be reaching them. So unless they are aware of Kawasaki disease and its complications, they would perhaps not be in a position to manage them adequately. Sahih? Devdatta, Dr. Amitabh?
What? It's an enormous data collection, I would say. One of the reasons, I can guess that probably they have been extremely meticulous in observing and maintaining the data. So far in Calcutta, we had 3. And out of them, we have been collecting and maintaining somewhat to some, but not to the extent what she has done. I think it may be a proper one if an all India basis registry is maintained, so that we can at least get hold of what is being done and what is to be done. What needs to be done if we get such patients. Obviously, one of the main factors is what she presented on the long term. All the 3 patients have presented suddenly, even though they have been on some follow-up and on medications. So that is one of the critical junctures that the emergency aid and emergency medication and therapy can be given only when we are aware that this patient can present at this time or in this state at somewhat in his or her life. And they have to be told that this can happen despite all the things, preventable things, whatever we take. Because all the 3 patients presented almost in emergency condition, like stenosis, and they collapsed in some state, but they were quickly recovered and sent to the hospital, and the medications and other therapy were done.
Have you ever encountered a myocardial infarction in the acute stage?
So we have encountered in 2 patients, sir. One was a 5-year-old small girl who had familial hypercholesterolemia. Her father died at the age of 43 because of severe coronary diseases, and she presented with very overt entherism. He had giant xanthelasmas all over the body, including the knees and the ankles and everywhere. And she has eye features also. She went to CABG. But these people usually, even after the correction in the CABGs, they tend to reaccumulate the new grafts also get clogged down because of the inherent metabolic defect. So they have to put on high medications and they might have to undergo plasmapheresis. One was this one. The other lady was 11 years. She underwent CABG because that also was familial hypercholesterolemia and she was doing well.
No, in KD?
No, sir. In KD, we haven't had an acute one.
Any experience of acute MI in a Kawasaki disease patient? We haven't ever diagnosed acute MI.
So we haven't got an acute one. The child which we presented, in the 3 cases, they were semi-acute. They were presented as dilate cardiomyopathy. That means the damage has already occurred and they had survived it and presented later as DCM, dilate cardiomyopathy. We haven't had an acute attack.
On retrospective, I think the case that they presented the one with the RC stenosis, that child was actually having an acute MI. The one we lost to particular the proteins were high for the 7-month-old child is very sick, and that child was to take out the child before we could do anything, the child sort of crashed in the case. with some potential arrhythmias that and just to include that when we are following up these children with KD, especially when they are having aneurysms and they are at risk, then I think we should include in every follow-up or make them aware that whenever these children, especially the small infants who are not vocal about their problems, when they are having these episodes of excessive crying, very sick, then we should include an ECG and enzyme tests in them along with the physical evaluation as well.
On the other side, the data is what we were discussing yesterday. 15,000 KD patients per year in Japan, 5 lakh children on follow-up. Lot of awareness is what is awareness. That once you do catheter angiogram in this cohort of patients, if you find anything which is suspicious of Kawasaki disease and catheter angiogram, it goes to the adult cardiologist or never think of that. You will make aware of them. When I was in Yale University, I used to see helicopter flying every 15-20 minutes. This is the state of healthcare system in Japan. On the radiology basis, I tell you, in India, the population of MRI for 100,000 population is 0.2. Japan is 34. And so it was a CT scan. So this is, this matchless medical services that this country has spent on their citizens.
Sir, one of my colleagues, Dr. Snehal Patel, he had actually presented a case in Frankfurt. He had actually presented a case. He had a KD patient, 3 years, who presented with aneurysm and then clot. That was an emergency. And what he did was in thrombosuction. We have the pictures as well. He did a thrombosuction. He went inside the right coronary artery, took out the clots, and demonstrated after 1 year. He did a scan again, and the child was doing extremely well. RC stenting and thrombosuction. We have the pictures and we can show them. That was the only case I know of that he did.
What were the presenting complaints of this child?
The child, he had a KD and an aneurysm, and the child collapsed. And when that was retrospective. And when they brought in the patient, he went inside and took out the clot with the right coronary artery catheter. He went inside the right coronary artery and took out that clot.
In a known case of KD?
Yes, sir, in a known case of KD, but they discovered it in a retrospect with an aneurysm and everything.
The parents were residing in Calcutta?
No, sir. He was from Gujarat, Surat. So that case, he had done an emergency thrombosuction. So they took out the clot going inside, and then they do that angioplasty.
They just put a stent there.
Yes.
That's the problem.
That's the
problem. I had a long discussion with Professor Peter Mura, who is a pediatric surgeon, and I told him that we spent a lot of time in hospital lunch. He says in KD, you have to do intervention with with lot of thinking. At that time, the operating cardiologist probably never thought that KD. There he found aneurysm. There was thrombosis, he sucked it and put them. We must understand the pathology of lesions of Kawasaki disease are entirely different to the atherosclerosis. My 18 years of cardiac radiology, I've never seen a single patient of atherosclerosis presenting with aneurysm. Presenting, if you put a stent, I don't know how effective it will be, that is time to tell. But as far as literature is concerned, you will not find a single patient like this who has been stented like this. I'm pretty sure.
I think they did under some emergency conditions. I got to see the pictures.
That's fine. That's fine. I'm not saying to a particular case, because when you see something happening, you have to do something. That is a wonderful job probably done at that time. But for the sake of discussion, we are discussing this.
Sure.
Right.
What about its function as of now? Cardiac function. No hypokalemia, nothing. That's great.
My question would be to all the cardiologists and other dignitaries here. Like how do these children present with acute coronary syndrome? Because we have never seen anyone, and they don't complain with they don't come with the actual complaints, and
and there can be some risk Kawasaki disease also. So they may just present cardiovascular collapse. And in our center, and I think in most centers, they don't do ECG routinely in a child with cardiogenic shock.
That's the thing I was saying. That's if I may. That's the thing I was saying, that we should routinely include that ECG and keep our minds open, especially when there is a history of aging. With small infants who are just present with excessive crying, sweating, they will not be able to tell the symptoms. And like adolescents with chest pain, the cases that Dr. Chattopadhyay said, I don't know, that may have got different symptoms. But that one case that I saw, just came in shock, a very, very cranky child with poor pulses, poor low BP, prolonged CRT, like any other features of cardiogenic shock. It was only the ECG when we documented the ECG. That also we should not see the ECG in the screen. It's very difficult to detect the STs, T segment changes if sudden. We should have an actual printout of the 12-lead ECG with the longevity. Along with the tropogens.
Especially in the issue of grading. Never forget to take ECG, and as she has spoken about the symptoms, crying, shaking, suffocations, that's not appropriate also. I think it's appropriate. And another thing, in India, the organ donation has to be motivated, because very difficult to get pediatric hearts. Means pediatric heart transplant is very poor in India. Whereas in US, it's really happening. So here the parents should be motivated for in future, I mean, because all these PPCA, bypass and all is like a temporary measures only. So sometimes need a heart transplant also. I met one person who had 2 heart transplants with his child is came to type A for 10 years.
Yes, type A.
But in US it is happening, but in India, very difficult to get a pediatric heart transplant because in tiny baby, bypass and all is very tough actually. Yeah, diffuse organ involvement someday. In future, we have to think about the heart transplant also.
Yeah.
So, couple of years back, we had a child around 2 years who actually had giant aneurysms, but was being managed by a very senior personnel, pediatrician, with only aspirin. So this child was once admitted with vomiting. So in the afternoon, the child was admitted with vomiting, and at night we came to know that the child had collapsed. The child was immediately shifted to PICU. They realized that the child was having ventricular tachycardia fibrillation. They couldn't discharge it. Possibly it was acute MI.
Request you or other esteemed faculty. See, when we diagnose a child with KD, just take a child with type 1 diabetes or CAH, we give a card to them, thinking these symptoms are there, anyone nearby should administer them glucose or something like that. So should we have some card for them, if some sudden collapse occurs, this should be suspected?
Yes, brilliant idea. Brilliant idea. In fact, we should have that card parents tell their symptoms wherever they go. Maybe already having Kawasaki disease.
Yes, I totally applaud that suggestion. We should.
All patients who carry with GIAN aneurysm should be explained about the signs and symptoms of acute heart during the time of disease.
And even nowadays, the only 3 electrodes, and in the home itself, they can monitor the ECG. So we can train such a patient 5,000 rupees. This is my hospital. Very easy to take ECG, take a tiny baby, so we never cut the bulb and sucking the runners out in the chest and all. So even in the home, they can take up and through Bluetooth, they can switch the corresponding consultant law.
So we are having a couple of pediatric cardiologists over here. So is Kawasaki disease discussed in pediatric cardiology conferences?
Yes.
Is discussed as a segment definitely, and the long-term effects and long-term things, but not to the fullest extent that here would be. They would cover 24, but it is discussed.
So I thank Dr. Suda. She has been tirelessly working over the last so many weeks. The kind of experience that she has, no one in the world has, and that is very obvious from her presentations. And I thank everyone in the hall for sitting here from 8 o'clock in the morning till 6. Thank you very much. So we meet tomorrow. Tomorrow we are meeting not at 8 but at 9. So I think Rakesh has taken pity on some of us. So we meet at 9 tomorrow.
Some relaxation.
Thank you.
Yes, sir.